करना A very good morning. A very good morning. We welcome you all to the inauguration ceremony of 12th World Dental Sciences and Oral Health Conference organized by Cynodent and Indian Society of Dentistry in collaboration with Fairfaxard Academy USA and Department of Periodontology, King George's Medical University Uttar Pradesh and King George's Society of Periodontology in our wonderful city of Adab, Tehzeeb and Nawab, Lucknow.
We would like to invite Dr. Shweta Ghanwat to perform the inaugural dance.
Thank you, Dr. Shweta, for such a blissful performance.
Now we welcome our chief guest, Honorable Dr. Pankaj Patil, sir, International President of Fairfaxard Academy USA, International Counselor of International College of Dentistry.
We would also like to welcome our guest of honor, Dr. Ranjit Kumar Patil, sir, Dean, Faculty of Dental Sciences, KGMU. Professor Dr. Nandlal, sir, Head of Department Periodontology, Chief Advisor and President King George's Society of Periodontology. Professor Dr. Pavitra Rastogi, sir, Convener-in-Chief, Deputy Registrar and President UPDCI. Dr. Anmol Bagaria, ma'am, Organizing Chairperson, Founder and CEO, Cynodent, President, Indian Society of Dentistry, and PFA Section Chair at Asia Large Legion. Dr. Ashish Chandra, sir, Organizing Secretary, Co-Director, Cynodent, and Vice President of Indian Society of Dentistry, PFA Section Co-Chair at Large Asia Region.
We request all the dignitaries to grace the dais. I, Dr. Misbah Kadri,
and I, Dr. Akshita Gupta, will be the master of ceremony for today. We welcome you all to the inauguration ceremony of the 12th World Dental Sciences and Oral Health Conference, organized by Cynodent and Indian Society of Dentistry in collaboration with Perifoctured Academy, USA, and Department of Periodontology, King George's Medical University, Uttar Pradesh, and King George's Society of Periodontology. This conference will focus on innovations and interdisciplinary approaches in dentistry.
It will bring together stalwarts and delegates from a wide range of discipline to meet, greet, and learn new things. We also look forward to hearing from our delegates through the numerous scientific presentations on their breakthroughs, advancements, and trends in the field of dentistry. Following our culture of Atithi Devo Bhava, we would like to start with the ritual of presenting a bouquet to our chief guest and all the dignitaries as a token of respect. No academic event can be implemented Please put a big round of applause. No academic event can be implemented without Ma Saraswati's blessing. Thus, I kindly request all the dignitaries to come forward for the lamp lighting.
या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
Now we would like to invite Dr. Ashish Chandra sir to address the gathering.
A very good morning to one and all present with us today. I, Dr. Ashish Chandra, extend a warm welcome to you at the 12th World Dental Sciences and Oral Health Conference, organized by Cynodent International and Indian Society of Dentistry in collaboration with Department of Periodontology, King George's Medical University, Lucknow. I heartily welcome the dignitaries on the dais, Chief Guest, respected Dr. Pankaj Patil, sir, PFA International President, Guest of Honor, Dr. Ranjit Kumar Patil, sir, Dean Dental College, King George's Medical University, Lucknow. Special welcome to Dr. Nandlal, sir, Professor and Head, Department of Periodontology, King George's Medical University. Dr. Pavitra Rastogi, sir, Deputy Registrar, KGMC. Dr. Anmol Bagaria, Founder and CEO of Cynodent, Section Chair at Large Asia Region. A special welcome to Dr. Ruchi Patel, Section Chair, Kenya, Perifoctured Academy. Heartily welcome to Dr. Shadab Mohammed, sir, Head of Department Oral and Maxillofacial Surgery, King George's Medical University, respected principals, heads of various dental colleges, and student awardees. I also welcome our respected dignitaries all of the dais and all the dear delegates. Cynodent has served you selflessly for 8 glorious years now, and today we are yet again at your service as we embark upon this beautiful 2 days of learning and sharing. We started yesterday with extensive learning with pre-conference courses, which included certified hands-on courses on facial aesthetic, lasers, implants, digital dentistry, smile designing, and guided bone regeneration. And today we officially inaugurate our conference, where we will have scientific sessions and lectures from eminent speakers from all across India and internationally. And not just that, to acknowledge and honor the stalwarts of dentistry, we have International Dentist Awards recognizing and honoring dentists across the globe. So buckle up yourself, because there's a lot we have to teach, and there's a lot you have to learn and upgrade your skills and knowledge. And yet again, on behalf of Team Cynodent International, I commit to continue to serve you in the coming years as well. I wish you all a good time with us. Thank you.
Thank you, sir, for your words of wisdom. We would like to invite Professor Dr. Pavitra Rastogi, sir, to address the gathering.
First of all, a very good morning to everyone present here. And on behalf of Faculty of Dental Sciences, I welcome you all in this great, grand, huge, and historic premises of King George's Medical University. This institution of King George's Medical College is one of the oldest institute of India, which is more than 120-year-old. But the university is very young, that is 18 year. So very, very respective dignitaries on the dais. The chief guest of today's program, the International President of P.F. Orchard Academy, Dr. Pankaj Patil ji. Dean Faculty of Dental Sciences, King George's Medical University, Professor Ranjit Kumar Patil Sahab. My head of the department, Department of Pedontology, Professor Nandlal Sahab. And the organizing chairperson of this extravaganza, very dynamic, very energetic, Dr. Anmol Bagaria. And very humble, Dr. Ashish, who is the co-organizing secretary of this conference. And dignitaries of the dais, my mentor, my teachers present in front of the seats, Professor Pradeep Tandon, who is the B.C. Roy awardee, and Padma Shri, Professor Shadab Mohammad Saab, who is the head of the Department of Oral and Maxillofacial Surgery, King George's Medical University. We welcome you, sir. Head of the department, Dr. Vinay Gupta, Dr. Anjani, my colleague, Dr. Umesh, and my batchmate, Dr. Sarwar Hashmi, who is head of the department, Oral and Maxillofacial Surgery, Aligarh Muslim University, who is sitting back. I welcome you, Dr. Sarwar. And the rest dignitaries, I'm sorry if I'm forgetting the names, and the different fellow colleagues from the different fields of dentistry. I welcome you all in this college and institution and in this conference. These conferences and continuing dental education programs are the need of the hour. We all know that change is the only constant of life. Change and advancement is the phenomena of life. We all know that research is the endless search of knowledge. And these conferences and continuing dental education programs are very, very important for the enhancement of our cognitive domains. We all know that according to the Bloom's taxonomy, we have to learn, if we all know that we are the oral health care providers. And this is the era of evidence-based medicine and evidence-based dentistry. So we are bound to provide the best available treatment to our patients. And it's our duty. So these educational programs and these programs are the need of the hour to keep update every time for ourselves. So in this conference, which is the 12th World Dental Sciences and Oral Health Conference, we organize different workshops and courses on facial aesthetics, lasers, laminates and veneers, and around more than 300 delegates participated in such workshops. So one more thing I want to tell you from this forum, that कि ये आज़ादी का अमृत महोत्सव चल रहा है. Today is the 17th of August. And according to the APJ Abdul Kalam साहब, कि सपने वो नहीं होते जो सोते समय देखे जाते हैं, सपने वो होते हैं जो हमें सोने नहीं देते. So I will not take this too much time. So हम सबको अपने बहुत सारे सपने पूरे करने हैं. And I am sure after this 12th World Dental Sciences Congress, all the delegates will get more information and more cognitive domain, the enhancement of the cognitive domain. So for the delegates, best of luck. And Lucknow is a good place. It's a नवाबों का शहर. आप आइए, घूमिए, enjoy करिए और खूब अच्छा सा यहाँ से experience लेके जाइए. Thank you so much. Dr. Bagaria is also sitting here. I'm sorry if I'm forgetting. Dr. Bagaria, खूब अच्छे से लखनऊ घूमिए. Thank you so much. Welcome you.
Thank you, sir, for your kind words. Now I would like to invite Professor Dr. Nandlal, sir, to address the gathering.
Good morning to all and everyone. I, Dr. Nandlal, Professor and Head, Department of Periodontology, Faculty of Dental Sciences, KGMU Lucknow, welcome you all in 12th World Dental Sciences and Oral Health Conference. This conference is being organized in collaboration with Cynodent, PFA Asia region, and Department of Periodontology, Faculty of Dental Sciences. I welcome the dignitaries sitting on the dais, Chief Guest Dr. Pankaj Patil, the International President of PFA, Professor R.K. Patil, our Dynamic Dean, Dental KGMU, Professor Pavitra Rastogi, he is President of UP State Dental Council, and Deputy Registrar of KGMU, Dr. Anmol Bagaria, Founder and CEO of Cynodent International, Dr. Ashish Chandra, Co-Director, Cynodent International, sitting up the dais, various dean, head of the departments, speakers, delegates, and electronic and print media persons, our teachers, Professor Tandon, Professor Shadab Mohammed, Dr. Rushi, and Dr. Bagaria, Mr. Bagaria. As we conduct this international conference every year to increase the knowledge in the various fields of dentistry, I hope you all will enjoy and learn various advancements and new technology and inventions from the conference. I once again welcome you all delegates in the city of Nawab. I wish a great success for this event. इसके अलावा मुझे एक और सलाह दी गई है, आदेश है कि एक शायरी कोई सुना दीजिएगा, एक छोटी सी. आप लखनऊ में हैं तो कम से कम जो डेलीगेट्स आए हैं इनको एक यादगार रहेगा कि ये सुना था हमने वहाँ पे. ये कोई हमारी नहीं है, शायरी सुनते हैं, याद कर लेते हैं. तो आपको सुनाता हूँ कि आँखों में रहा दिल में उतर कर नहीं देखा. बहुत गहरी चीज़ है. आँखों में रहा दिल में उतर कर नहीं देखा और कश्ती के मुसाफिर ने समंदर नहीं देखा. आँखों में रहा दिल में उतर कर नहीं देखा और कश्ती के मुसाफिर ने समंदर नहीं देखा. और जब से चला था, आज यहाँ जो पहुँचे हैं आप, ऐसे नहीं पहुँचे होंगे, तो जब से चला था मेरी तो मंजिल पे नज़र थी. जब से चला था मेरी तो मंजिल पे नज़र थी और आँखों ने कभी मील का पत्थर नहीं देखा. कश्ती के मुसाफिर ने समंदर नहीं देखा. और ये फूल मीन्स अचीवमेंट, जहाँ आज आप खड़े हैं, बैठे हैं, जो मिला आपको, ये फूल मुझे कोई विरासत में मिले हैं. ये फूल मुझे कोई विरासत में मिले हैं. तुमने मेरा कांटों भरा बिस्तर नहीं देखा और कश्ती के मुसाफिर ने समंदर नहीं देखा. और शेर का आखिरी लाइन है कि पत्थर मुझे कहता है मेरा चाहने वाला। बहुत खूबसूरत है कि पत्थर मुझे कहता है मेरा चाहने वाला, मैं मोम हूँ उसने कभी छूकर नहीं देखा, और कश्ती के मुसाफिर ने समंदर नहीं देखा। एक और साथी लगे हाथ सुना देते हैं कि तुमने चाहा नहीं हालात बदल सकते थे, तुमने चाहा नहीं हालात बदल सकते थे, और तेरे आंसू मेरी आंखों से निकल सकते थे। तुमने चाहा नहीं हालात बदल सकते थे, तेरे आंसू मेरी आंखों से निकल सकते थे। अरे तुम तो ठहरे रहे बस झील के पानी की तरह, तुम तो ठहरे रहे बस झील के पानी की तरह, और दरिया बनते तो बहुत दूर निकल सकते थे। बहुत बहुत धन्यवाद।
Thank you so much, sir, for such a wonderful words. We would like to invite our guest of honor, Dean Faculty of Dental Sciences, KGMU, Dr. R.K. Patil, sir, to address the gathering.
Thank you. Good morning to all. Today's chief guest, Dr. Pankaj Patil, International President, Fear Futured Academy, USA. Professor Nandlal, Head of Department Periodontology. Professor Pavitra Rastogi, colleagues. Dr. Anmol Bagaria, who is organizer of this Cynodent and all this event. Ashish Chandra, co-organizer of this event. Of the dais, Padam Shri Professor Shadab Mohammed sir, B.C. Rai Awardee Professor Tandon sir, all the delegates. On behalf of the Dean Faculty of Dental Sciences, King George Medical University, I welcome you all to the university as well as the city of Nawab. For you will find here the tehzeeb and famous cuisines. Hope this conference, 12th World Dental Sciences and Oral Health Conference, which is organized by Cynodent, Indian Society of Dentistry, along with Department of Periodontia, will give you the scientific feast for all of you. And I all in advance congratulate today's awardee and all the delegates who have come here. I wish a pleasant stay. Thank you very much.
Thank you, sir, for your inspiring words. Now, I would like to invite our chief guest, Honorable Dr. Pankaj Patil, sir, International President, PFA USA, International Counselor of International College of Dentistry, to address the gathering.
Good morning, everyone. PFA section chairs Dr. Anmol Bagaria, Dr. Ashish Chandra, and Dr. Ruchi Patel Sahi, respected dignitaries and distinguished guests. I do not need to remind this august audience what a challenging time we live in. It has been described as volatile, uncertain, complicated, and ambiguous. We face pandemics, natural disasters, effects of climate change, and sustainability. To cope with and manage all this constant change, we need leaders of a special kind with remarkable qualities. They have to have inborn honesty and integrity. I therefore behoves on all of us at all levels of our careers to look out for these future leaders, just like all those who have been inducted today, and encourage and nurture them. As most of you know, my emphasis during my year as President of Academy is international growth and recognition. We have made great strides in accomplishing this. It is interesting to see the international aspects of our profession. Even though ideas are different in all cultures, our professional mission is the same: care for our patients, care for our communities, and the ability to volunteer to provide care for those less fortunate than ourselves. The bond of professionalism is what holds members of our academy together. I encourage all of you to look around in your community for the opportunity to nominate your colleagues for membership in our academy. The academy growth is paramount. Academic growth continues at a great pace. I appreciate all the hard work our trustees and section chairs are doing on behalf of our academy. The progress our academy continues to make would be impossible without the hard work of our executive director, our officers, trustees, and section chairs. I congratulate Dr. Anmol and Ashish of Cynodent International in contributing to the advancement of dental profession by fostering growth and promotion of dental knowledge and recognizing distinguished members of our profession. And many congratulations to the new fellows. Thank you.
Thank you, sir, for your words of wisdom. We would like to invite our dignitaries to felicitate our chief guest, Dr. Pankaj Patil, sir. To felicitate our guest of honor, Dr. R.K. Patil, sir. To felicitate Professor and Head Dr. Nandlal, sir.
Thank you to our dignitaries. Now I would like to start with the Cynodent International Dentist Award 2024. For the first category of Best UG Student, it goes to Diya Kohli, BDS first year. Best UG Student, second year BDS, Khushi.
For the next category, Budding Dentist of the Year goes to Dr. Sonali Verma. Best PG Student of the Year goes to Dr. Shonika. Emerging Aesthetic Dentist of the Year goes to Dr. Piyush Pandey.
Emerging Oral and Maxillofacial Surgeon of the Year goes to Dr. Satnam Singh Jolly. Best New Dental Practice of the Year goes to Dr. Brijendra Singh.
Budding Dentist of the Year goes to Dr. Hrishita Handa. Emerging Public Health Dentist goes to Dr. Deepak Gurang.
Emerging Laser Dentist of the Year goes to Dr. Snigdha Bekwas. Emerging Endodontist of the Year, Dr. Rahul Pandey. Emerging Researcher of the Year, Dr. Gaurav Jain.
Emerging Public Health Dentist of the Year goes to Dr. Shilpi Gupta. International Dentist of the Year goes to Dr. Shalin Verma. Now for the Best Overseas Dentist of the Year goes to Dr. Rushi Patel Shahi Ma'am. Best Endodontist of the Year goes to Dr. Manoj Kumar Hans. Innovative Dentist of the Year goes to Dr. Shanmuga Sundaram. Budding Endodontist of the Year goes to Dr. Aparna Rai. Oral Implantologist of the Year goes to Dr. Ramandeep Singh. Emerging Oral and Maxillofacial Radiologist goes to Dr. Monica Bhatt. Budding Prosthodontist of the Year goes to Dr. Mayank Kumar Parak. It's time for the Best Dental College Award, and it goes to King George Medical University, Lucknow.
Congratulations to all the winners. Now we would like to invite Dr. Anmol Bagaria ma'am for vote of thanks.
So I welcome Professor R.K. Garg, head of the Department Neurology. He is the pioneer scientist of this university. Not only this university, he is one of the top 10 scientists of Stanford University. Professor R.K. Garg Sahab. We welcome you, sir.
A very good morning. Warm greetings to one and all present here. I once again welcome you all to the 12th World Dental Sciences and Oral Health Conference. Firstly, all thanks to God for blessing us all with His choicest blessings. I would extend my gratitude to all the dignitaries on the dais who have graced the occasion and inaugurated our conference today. Respected Dr. Pankaj Patil sir, Dr. R.K. Patil sir, Dr. Nandlal sir, Dr. Pavitra Rastogi sir, and Dr. Ashish. Thank you for gracing the occasion and your presence. Thank you for your constant support in making this event a grand success. I would also like to thank all the dignitaries of the dais, respected guests, deans, faculty members. I wish to extend my sincere thanks to entire organizing committee. Thank you for your support and your efforts. We could not have come this far without you. I would also like to thank all the speakers who have taken out time from their busy schedule and made it here. A big thank you to all my dear delegates and students who have trusted us and joined us today. Thanks to all the speakers, clinicians, and academicians who have joined us to enhance their knowledge and skills. I promise you the same next 2 days. Thank you all for your valuable time, trust, and support. Sorry if I have missed any names, but I am highly thankful to each one of you. I would end my note by saying a famous saying by Dr. APJ Abdul Kalam. All birds find shelter during a rain, but eagle avoids rain by flying above the clouds. Problems are common, but attitude makes the difference. Thank you all once again for being with us and giving your valuable time. Wish you a happy day and a happy conference ahead. Thank you.
Thank you, ma'am, for your kind words. Now we would request everyone to please rise up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I would like to request everyone to kindly wait for 10 minutes as we are going to start with PFA convocation and award ceremony. Thank you. I would like to invite Dr. Shadab Mohammed sir on stage.
I welcome Professor Anit Parihar, Head of the Department, Radio Diagnosis, King George's Medical University. Thank you so much. We would like to honor Professor Pradeep Tandon, sir. Please come on the dais, sir. Please come up, sir. Please give a big round of applause to Professor Pradeep Tandon. He is a BC Rai awardee. And our Professor Shadab, sir, is the Padam Shri of this university.
We will start with the PFA convocation and award ceremony in 10 minutes. Kindly wait. Thank you.
Dr. Anshula Sehgal, Dr. Archit Tiwari, Dr. Arshpreet Kaur, Dr. Arun Kumar Duraswamy, Dr. Arunesh Kumar Tiwari, Dr. Ashish Kumar,
Dr. Ashish Pandey, Dr. Atiba Makija, Dr. Azhar Malik, Dr. Bhuvan Nagpal,
Dr. Cassius Kuchikunel, Dr. Ashish Pandey,
Dr. Bhuvan Nagpal, I would also request everybody to kindly wait for the official group photo. Dr. Atiba Makhija,
Dr. Cassius Kochikunel,
Dr. Devina Pradhan, Dr. Divij Khullar, Dr. Drishti Kaushal,
Dr. Fahad Mansoor Samadi, Dr. Fasih Mohammad bin Farooq,
Dr. Gaurav Mishra. Dr. Garima Poddar. Dr. Gaurav Mishra.
Dr. George Scaria. Dr. Georgie P. Zakaria. Dr. Ghulam Sharwar Hashmi. Dr. Gursmat Kaur. Dr. Harneet Kaur. Dr. Harneet Singh Mego. Dr. Harsh Priya. Dr. Harsha Lalit. Dr. Harsimran Kaur. Dr. Rishita Handa. Dr. Insha Ilyas. Dr. Zerin Kuren, Dr. Keshav Malhotra, Dr. Khushbu Arif, Dr. Krishna Prasad Biswas, Dr. Madhura Datyatreya Kulkarni, Dr. Madhurima Sharma, Dr. Madhurima Sharma, Dr. Mahesh Srirang, Dr. Mamnoon Ghafir, Dr. Manasi Shimpi, Dr. Makbul Alam, Dr. Mayank Kumar Parak, Dr. Mabin George Matthew, Dr. Mohammad Amir, Dr. Mohammad Ribin Malathil, Dr. Mohammad Haris Khan, Dr. Mohit Tomar, Dr. Monica Bhatt, Dr. Mufid Abdu, Dr. Nalla Mili Lalitha Shri Rosa, Dr. Nandlal, Dr. Nandlal sir, Dr. Navlin Kaur Bhatia, Dr. Nayan Jyoti Sahu, Dr. Neelam Das, Dr. Neelu Verma, Dr. Neeraj A. Kolge, Dr. Neha Upadhyay, Dr. Neha Navid, Dr. Padma K. Bhatt, Dr. Palak Mishra, Dr. Panna Mangat, Dr. Paramjot Kaur, Dr. Paridhi Garg, Dr. Parul Lohra, Dr. Pavitra Rastogi sir, Dr. Pinky Mathur ma'am, Dr. Pragya Gupta, Dr. Pratik Prakash Bam, Dr. Pritam Rauri, Dr. Pritam P. Shah, Dr. Priyanka Pritam Shah, Dr. Rahul Kumar, Dr. Rahul VC Tiwari, Dr. Ramandeep Singh, Dr. Rameshwari Singhal, Dr. Ranjit Bharat Gandhi, Dr. Ranjit Kumar Patil Sir, Dr. Richa Ranjan Shahai, Dr. Rishabh Bhanot, Dr. Rishabh Kapoor, Dr. Rohit Kumar Sharma, Dr. Ruby Dwivedi, Dr. Ruchita Arora, Dr. Sachdev Madan, Dr. Sahil Chaudhary, Dr. Saif Rauf Siddiqui, Dr. Shakshi Chugh, Dr. Salman Anjum, Dr. Saloni Verma, Dr. Sania Khan, Dr. Sanjay Gupta, Dr. Sanket Kumar, Dr. Sarnik Sarkar, Dr. Satnam Singh Joli, Dr. Shadab Ahmed, Dr. Shalin Verma, Dr. Shikha Gupta, Dr. Shipra Nagar, Dr. Shubham Tripathi, Dr. Shirisha, Dr. Sonali Sharma, Dr. Subhash Singh, Dr. Sumit Kumar, Dr. Sunanda Roy Chaudhary, Dr. Suraj Arjun Ahuja, Dr. Swathi Krishna, Dr. Suranjana Jonak Hazarika, Dr. Swathi Krishna, Dr. Syed Tosifullah, Dr. Umesh Pratap Verma, Dr. Ume Habiba, Dr. Vandana Singh, Dr. Vishwaraj Nikam sir, Dr. Wasim Khan, Dr. Yashika Bali, Dr. Zeba Rehman Siddiqui, If anybody is missed, kindly come forward. Please put a big round of applause. Now, we would like to invite Dr. Ruchi Patel ma'am for oath.
Thank you, everyone. That was a long stretch. That was a really big number of inductees, and that just goes to show the amazing work your section chairs are doing here. I'm Dr. Ruchi Sahi. I'm the section chair for the PFA for Kenya section. I'm quite honored to be here to lecture, but also to have you guys take your oath. I know when I joined the PFA, my questions were, well, but what do I do? What does it mean? And the oath is really integral to you understanding what part you play in this prestigious PFA academy. So, because of your exceptional involvement, achievements, and leadership in the dental profession and your community, you have been nominated and accepted to be inducted as a new fellow of the Pierre Fauchard Academy. It is a distinct honor to be selected for fellowship into this international honorary dental service organization, and I offer my sincere congratulations to all of you. The PFA promotes the elevation of the standards and the practices of the art and science of dentistry worldwide. Each fellow-elect must approach fellowship with a sense of privilege and a realization of inherent responsibility. Thus, a pledge is required of you. I will read that pledge for you, but may all the fellows today of the PFA please rise as I read the pledge. Recognizing that the Pierre Fauchard Academy seeks to exemplify and support the highest traditions of dental professionalism around the world, I hereby accept as a condition of fellowship its principles and objectives. Therefore, let it be known that I pledge myself as a fellow of the Pierre Fauchard Academy to uphold to the best of my ability the honor and dignity of the dental profession and of the Academy. I pledge that I will conform my professional and personal practices to the high moral and ethical standards which the Academy exemplifies. To succeed in this high calling, I pledge to devote my best efforts to a continuation of development of knowledge and skill for myself and others in this art of science and dentistry. You will all indicate your acceptance of this pledge by saying, "I do." Please be seated. You are all all entitled to the privileges of this academy. When appropriate, you may use, following your name, the letters FPFA, meaning Fellow of the Pierre Fauchard Academy. It is your honor and privilege on proper occasions to wear the lapel pin as the key as long as you are a fellow among us. May you wear them with distinction to yourself and with honor to the Academy. Congratulations.
Thank you so much, ma'am. Now I would like to invite Professor Dr. R.K. Patil, sir, to deliver the vote of thanks.
Thank you. I sincerely thank PFA Asian region to conduct or hold this program here at King George Medical University. I thanks President PFA for coming all the way and to be here with us. Thank you, sir. Thank you very much. I thanks all the organizing committee and all the delegates here. Thank you very much.
Thank you so much, sir, for your kind words. Now I would like to invite Dr. Nandlal, sir, on behalf of fellow for vote of thanks.
Good morning to all. Sitting on the dais, Chief Guest Dr. Pankaj Patil, International President of Pierre Fauchard Academy, Dr. Rushi Patel, PFA Section Chair Kenya, Dr. Anmol Bagaria, Section Chair at Large Asia, Dr. Ashish Chandra, Section Chair at Large Asia. Sitting up the dais, my co-fellows, speakers, delegates, and electronic and print media persons. I, Dr. Nandlal, Professor and Head, Department of Periodontology, Faculty of Dental Sciences, KGME Lucknow, welcome you all from core of my heart in the most prestigious PFA Fellowship and Award, which is being organized by Cynodent in collaboration with Department of Periodontology Faculty of Dental Sciences, KGMU, Lucknow. This fellowship program includes galaxy of huge number of national and international fellows from various specialties of dentistry and have made a world record of inducting highest number of fellows. PFA will give international recognition to all its fellows. This event will provide a great opportunity to practitioners, clinicians, and academicians to learn and explore the depth of knowledge about dentistry. These type of fellowships and awards will give motivation to work hard and for the dental fraternity. I once again welcome all the fellows and delegates in the city of Nawabs with the hope that you will have a wonderful stay at Lucknow. I wish a great success for this event. Thank you all. Jai Hind.
Thank you so much, sir. Now I would like to invite Dr. Pavitra Rastogi, sir, to deliver a vote of thanks on behalf of fellows.
Thank you, dignitaries on the dais. And on behalf of all the fellows of Orofacial Academy, especially new fellows who have received the fellowship today, we are so grateful and pleased to accept our warmest thankful wishes for attending and making this convocation a special and memorable one. We are thankful to all the dignitaries. Your thoughtfulness is a gift we will forever treasure. A simple thanks may not be enough. We express our heartfelt gratitude to Orofacial Academy. Fellowship is a significant milestone in one's life. It marks the culmination of years of hard work, dedication, and perseverance. Whether it's high school, college, or any other form of academic achievement, completing an educational journey is a momentous occasion deserving of celebration. It's essential to pause and express gratitude to those who have supported and guided us along the way. I am thankful to my mentors and teachers who have not only imparted knowledge, but also instilled in me a passion for learning and a belief in my abilities. Your guidance, patience, and dedication have shaped my academic path and inspired me to strive for excellence. I'm thankful to my incredible family and friends. Their continuous support has been my anchor throughout this journey. Your belief in me has filled my determinations, and I'm immensely grateful for every word of encouragement, every hug, and every celebrity moment we have shared. Thank you for being my rock. I'm thankful to all my colleagues. I'm thankful to all my fellows, and especially students who are always supportive and a source of inspiration. Thanks to everyone.
Thank you, sir. Now we would like to start with the PFA award ceremony. First, we will begin with the Best Dental College. First goes to Faculty of Dental Sciences, KGMU, Uttar Pradesh. Next, we have Sharad Pawar Dental College and Hospital, Maharashtra. Next goes to Sri Venkateshwara Dental College and Hospital, Chennai. Next, Dasmesh Institute of Research and Dental Sciences, Punjab. Next, we have Nurul Islam College of Dental Sciences, Kerala. Next, we have Mahatma Gandhi Postgraduate Institute of Dental Sciences, Government of Puducherry Institution, Pondicherry.
Now it's time for Dental College in Community Service. Faculty of Dental Sciences, KGMU, Uttar Pradesh. The Smesh Institute of Research and Dental Sciences, Punjab. Dayananda Sagar College of Dental Sciences, Karnataka. KSR Institute of Dental Sciences and Research, Tamil Nadu. College of Dental Sciences, Davangere, Karnataka. Anil Neerukonda Institute of Dental Sciences, Vishakhapatnam. Now it's time for Best UG Student of the State. I would like to invite Komal Goyal from Pavitra Rastogi College of Dental Sciences and Research, Haryana. Diksha Sharma from SGT University, Haryana. For the Best Dental College in Community Service, Dr. G.D. Paul Foundation, YMT Dental College and Hospital, Maharashtra. Again, proceed to the Best UG Student Award. I would like to invite Akshita Gupta. Jasmine Sondhi, Dashmesh Institute of Research and Dental Sciences, Punjab. Nandini Mukesh Thakrani from Maharashtra. Sahana GV from Karnataka. Varsha S from Tamil Nadu. Rihanna Anas from Kerala. Kari Lakshmi from Andhra Pradesh. Jaya Sinivasan from Puducherry.
Coming on to the best PG student of the state, it goes to Dr. Surbhi Shri Guru Ramdas Institute of Dental Sciences and Research, Punjab. Department of Orthodontics. Dr. Vinisha Bajaj, Department of Periodontology. Maharashtra. Dr. Janani Rajesh, Department of Periodontics, Karnataka. Dr. Siri PB, Department of Conservative Dentistry and Endodontics, Karnataka. Dr. Varsha Patel, Department of Oral Medicine and Radiology, Karnataka. Dr. Sandeep BS, Department of Oral and Maxillofacial Surgery, Karnataka. Dr. Maniyar Nikunj, Department of Orthodontics, Karnataka. Dr. Deepti M, Department of Periodontology, Karnataka. Dr. Renu PB, Department of Prosthodontics, Karnataka. Dr. Ghazla Sultana DS, Department of Public Health Dentistry, Karnataka. Dr. Renu Jagan, Department of Orthodontics, Kerala. Dr. Indrapriya Darshini J, Department of Oral Medicine and Radiology, Puducherry. Dr. Vishakha Gupta, King George's Medical University, Uttar Pradesh, Department of Periodontology. Sedhu Bharat S. Sri Venkateshwara Dental College for Best UG category. Now coming on to the Student Appreciation Award, Misbah Kadri for outstanding contribution in community service. Shubham Bharti for outstanding contribution in voluntary service. Shubham Bharti for outstanding contribution in voluntary service. Congratulations to all the winners. And we request all the PFA fellows to please stay back for the photograph for the official website, and the others can move for lunch. Also, I would like to invite Dr. Anmol Bagaria ma'am to deliver the vote of thanks.
Firstly, I would like to thank our Honorable International President Dr. Pankaj Patil sir and Dr. Ruchi Shahi for traveling all the way to India and making this induction ceremony happen. And Dr. Ashish Chandra, the PFA section co-chair of Section at Large Asia region countries, for making this event a grand success. I welcome all the new fellows to our prestigious Pi Fortune Academy, USA. As we all know that PFA was founded in 1986, and today is a day which will be written in the glorious history of the PFA, as till date the highest number of fellows have been inducted globally at one time. Congratulations to all the new fellows and awardees. Thank you so much.
Thank you so much, ma'am. I would request all the PFA fellows to please come on the stage for the official photograph.
I would once again congratulate all the 125 fellows who have been inducted today, all the college awardees, all the student awardees, and in case if anyone's name is missed out or has come late, can please come on the podium to receive the award. Thank you.
Hello. So now we will continue with our lectures.
Everybody is requested to kindly return the gowns at the place where you received them. Everybody is requested to kindly return the gowns at the place where you received them.
कहाँ हैं आप? आए नहीं आप? अच्छा 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 ओ अरे मैंने सुबह ही उठ के करे, हम तो कोई यही लोग करते हैं हमसे, वो मतलब मैं तो बस चेहरा मोहरा मामला है। माम मा, उसने तो उस जगह सबको भेज दिया। क्या व्हील चेयर से ले जाना है? अच्छा तभी हुई। हम्म हम्म होगा नहीं। हाँ सही बात है, सही बात है। बिल
have to start with the lectures. See, the faculty is waiting. Now we will start with the lecture session. For the first session of today, I would like to invite Dr. Pinky Mathur ma'am. She is a maxillofacial prosthodontist, and the topic for today's lecture is Conquering the Art and Science of Porcelain Laminates and Veneers.
पर ये कनेक्टेड नहीं है यहाँ। हाँ, स्टार्ट कर दीजिए।
Okay. So a very good morning all. So I'm here to talk about conquering the art and science of laminate and veneers. So basically, laminate and veneers, we had a very good workshop yesterday, went really very well. Now why laminate and veneers? Because it is a time for aesthetic dentistry and everybody wants about aesthetics, everybody wants that smile designing. So here we are moving from this tradition of ghungta to everything being out of the ghungta. So that is the reason why we are so much into smile designing and we are so much into aesthetics. You see all these big actors and actresses, what have they done? Something called as laminate and veneers. Now my next question is, what is the difference between laminate and veneers? What you do on your Aadhaar card is laminate, and what you do on your book when we were smaller to cover them are simple as veneers. So laminates are something which is not going to correct your shade but only cover up your defect, and veneers is something which is going to cover up your shade, give you the beautiful colors, and it is of course thicker. So here today when I'm talking, it's something called as Hollywood Smiles before, and now India is really practicing it because it's trending. So I would like to do it without the mic because I think very few of them are here. So basically, to understand laminate and veneers, we need to make it a long-standing restoration. Now, how is that going to be a long-standing restoration if you're going to easily going to be able to come up with the failures? So indication and a certain treatment. So here you have this case where the first indication is if you have a diastema closure. If you need to close your diastema, in that case, you need to put up a laminate veneer. The second indication is if you have something, if you can see this case here, she has a discolored tooth, so this is corrected very well with the help of this laminate. Second, the next indication is if you have stained teeth, correcting your teeth with the help of these veneers going to help you get up or get accustomed to the bone out teeth. So doing these cases with laminate veneers is a big yes. Second, these cases, but you should also know where to put them. That is the main reason why I'm talking about indication here. So indications is a very, very important criteria, a very, very important parameter because you should know where the laminates and veneers needs to be done. Next, if there's crowding, minor crowding, you think this patient is going to get an ortho treatment if he has just one single tooth is crowded, because this patient just came to me and said, I just don't want to get ortho done. I just need something to correct my smell and did it with veneers. Next, to correct spacings. Correcting spacing is also very, very important. So here, as I said, you can use good amount of laminates in such cases. And then again, another indication here, as you can see, the first one is a very good picture of laminates where you don't have to correct the shade, and the second one when the shade was corrected, so we put a thicker material like a veneer. So of course you should know where to do and where not to do. If it's a case like this patient came up to me and said that I need this crown to be placed, of course I cannot change the crown to a veneer. So if I have a crown which has to be replaced, it has to be replaced with a crown, and if there's a veneer, a fake composite veneer, it needs to be done with a veneer. So here is the photograph of the patient who very well had a nice smile done. I changed her crowns and the lateral was a veneer. She was happy. Here, as in another contraindication in this case, as you can see here, there are proximal caries present here. Very well present here. So here, in this case, I would not go in for a veneer. That's on. I'll just hold it in my hand. Yeah. Okay, this is working. Yeah. Okay. So here in this case, if I have a case like this, of course I cannot do a veneer here because I know that this tooth needs RC treatment. There's the color of the obturating material which is going to come. So this case we corrected with a crown and a veneer on the lateral tooth because she needed a nice smile designing here, and also over here on the central we put a veneer, so this was a crown. So you should of course know, not that if a veneer has been suggested, so in all cases you go in for laminate and veneers. Now this case is an absolute contraindication for a laminate veneer because the diastema here is very big. So in cases like this, you do not do laminate veneers, you replace this with, you do ortho treatment, and you can do a laminate here for the cases in the lateral. So moving ahead, what we did in this case was, this was corrected with a slight ortho help. Here in this case, in these canines, because she was having laterals missing, we gave her a laminate in a lateral shape, and this was corrected with ortho. So going ahead, the next step here is the diagnostic closure. The first thing, whenever you start with laminate veneers, it should be diagnosis, because you cannot be doing veneers for cases like this. As I already said, this is a case which has periodontitis, it has malformations. So this case is an absolute no to put in the laminate and veneers. Going ahead, we used a smile designing software for this patient, and when we showed him, he himself was not happy because the teeth look massively big here. He himself suggested the idea, and these cases are not an indication for veneers. So the main next problem here is talking about bond failures. Bond failures is one main criteria which is causing your veneers to fail in a lot of cases. So before you start knowing about bond failure, you need to know about the anatomy. The first thing, enamel has more of organic substance and dentine has somewhat inorganic and organic together. So the water content in dentine is always more. So because the water content is more, whenever we are going to do an etching, we are going to also work with a surface which has water included in it. So here when we go and when we talk about enamel, we are going to have a surface which is more of a hydroxyapatite. So here you can see the, whenever you are going to do etching, there is going to be formation of resin tags which is going to increase the surface area. Hence here we mandatorily want you to be in the enamel when you talk about etching. So have you ever come across cases when you have done a laminate veneer or a composite restoration and the patient comes back to you and says that I have major sensitivity? So the reason lies here, it's not because the sensitivity is due to you not doing your work properly or you being a bekar dentist, but the reason here is because you have not followed the constraint of using of the material. If you are in the dentine, you have to change your bonding agent. You are not going to etch when you are working in the dentine. If you are working in the enamel, please etch, because when you are in the enamel, you are going to work on resin tags. You have to form resin tags, you are going to work on hydroxyapatites, which is in very less quantity when you are talking about the dentine. So when you talk about the dentine, whenever there is a preparation of, you have shavings which collects on the dentinal tubules, which is called as the smear layer. So this smear layer is something which we don't want to get removed, because there is liquid inside the dentinal tubules which is going to move inside and outside due to pressure of whatever material you're going to use for bonding. So hence we just modify the smear layer, modify the hybrid layer, and hence the type of bonding agent is important. We do not etch the dentine, and to take care of this situation we have something called as a primer. So it is highly suggested that you use the etching techniques and use the denting bonding agent which has good amount of primer in it. So the most suggested one which I generally use is the one which is all in one, the universal primers, and you should try to see if you have MDP in them. So as I said, which system you should use for your veneers, you should use something called a selective etch. You do not etch the dentine. What you can do is etch the enamel part of it, and whatever the dentine part is, directly use your single bond systems or the 7th generation system. As I said, MDP monomer has to be used, so please check if you have MDP in your bonding systems. Also, because you have to be in enamel, we had a very great workshop today. I had around 25 participants in my workshop, so it went really well. So there I have taught you all to make all these guides and everything. So yes, of course, you use these guides so that you do not overcut. You are there in the enamel, you don't cut extra. So now adhesive and cohesive failures, you might have failure in the cement itself, you might have failures where the bond is coming out of your whatever restorative material you used. So these failures have to be taken care of if whatever principles I have told you to be in the dentine, if you follow those principles, I'm 100% sure that you're not going to have failures. If you are in the enamel, that case is for laminate veneers. If you have crossed the enamel and you have reached into the dentine, that case is not indicated for veneers. So this is a case which kept on coming to me a lot of times with failed restoration, failed fractured veneers. The only problem here was the old composite resins weren't removed. So this case, this is what I did. The only thing I did is just change her bonding material. I just changed the type of generation of bond that I used here. Okay, now coming down to the cement, it's a very normal query which a lot of people ask me, that what cement am I supposed to use when I talk about ceramic veneers. So the cement I would always suggest is go in for light curing cements. Reason why not you go in for self cure or dual cure, because you might say okay, dual cure ka zamana hai, why am I using something primitive. Basically when you talk about dual cure cements or you talk about self cure cements, they have a lot of amines in them which is going to bother or might change the color of the veneers, because the veneers are very, very thin, right? We are working in the thickness of 0.7 to 0.8 mm. So anything from inside might show through. And also the working time, very, very important. You need to remove that excess cement. You need that good amount of time to place it, because once it's done, it's done. So hence always use a light curing cement when it comes to a veneer. Also, I would strictly suggest, as yesterday in my workshop, whenever you, all of you all who made these chair side laminates, of course the temporary ones, no polishing, no finishing inside the mouth. All the finishing and polishing has to be done out. Of course, when you start with your work, shade is the first thing that you do. You always select your shade first. Now for this case which I did, it had a lot of other problems. A few veneers were put, a few posts and cores were done. Now this case came to me like this, where it was unbelievable to see a quack do a post and core with acrylic. But this is how we corrected this case. This tooth could have been used with a veneer, but here of course a post and core, clown landings. I had a periodontist who came in for this. Next is material selection. Also, as I said, the thickness of the laminate or the thickness of the veneer actually decides what kind of indication it is standing for. If it is a laminate, as I told you, it's going to be thinner. It has to be used only to pick up the defects, like you have malformed teeth or worn out teeth. So of course I don't want my laminate to be so transparent that it shows everything from inside. So, but if I have laminates which are reinforced with particles of alumina, silica or whatever other than that, it's going to of course cause some opacity to come into it. So hence, depending on this, I'm going to select my material. So if I have to do only a case like this, where I do only diastema closures, I'm going to use a laminate or a veneer which is going to be thin, feldspathic type, which I don't need them to be really strong or really thick to cover up the defect. I just need them to build that area which is missing from the mouth. The second one, where I go in for more opaque veneers, you can also go in for zirconia veneers, but I am not very fond of zirconia veneers because you have to be very exacting with the shade and the opacity. So if I do a case like this, I can of course go in with a zirconia veneer because it has to cover up this defect. So hence, your laminate veneers are about etching when you are in the enamel. After etching, the next thing you do, you rinse it thoroughly, of course, to remove the rest of the etchant. You apply bonding agents. After bonding agent, another important step here is applying hydrofluoric acid to your laminate. Of course, the surface treatment of the laminates. Am I done with 20 minutes? No, right? Just 5 minutes more, yeah. And then you cure your bonding agent. If in case you are talking about cases where you are going to come in contact with the teeth which are a part of fluorosis, what do you do in those cases? So teeth which are affected with fluorosis, I would advise that you go in for doubling the etching time. Also give night guards to the patient. Giving night guards, if you feel the patient has parafunctional habit, is very, very important. And coming to the end of it, your preparation should be exact. You should have preparations without undercuts. The preparations should be very precise. A 3-planar preparations, use all the armamentarium which has been given, and I'm sure you're not going to encounter any failures. So it's of course you have to change the way you look at things. Thank you very much. This is my contact ID. If there's any doubt, you can of course contact. Thank you.
Thank you so much, ma'am, for such a wonderful session. Please wait for the next lecture. For the next lecture, I would like to invite Dr. Satnam Singh, sir. Topic is medical emergencies in the dental office, early diagnosis and treatment modalities. Over to you, sir.
Hello. A very good afternoon. I'm Dr. Satnam. I'm thankful to the committee for giving me the opportunity to talk on this. So I'm discussing something about the medical emergency in dental practice. Why I choose this lecture? Because this is a dental conference. This is one kind of review. We all know our seniors and the experienced dental practitioners. They all know about all these things. This is just one kind of a review or the reminder that what can happen when you are treating your patients and how you will manage those emergencies which can be there in your dental practice. So an emergency is a medical condition that demands your immediate attention and good management to enhance the successful outcomes. These emergencies can be life-threatening for the patients and needs to be aware of the help to prevent the preventable injuries, illness, or even death. Death can also occur as a complication in your dental operatory. So your aim should be to minimize the consequences of unavoidable emergencies. So in medical emergencies, signs and symptoms are more important than reaching the actual diagnosis in emergency conditions. So your aim should be to control and minimize damage in a short time frame. When there is any emergency, you have to act quickly. Your staff or you should know that what you have to do in the case of emergency. So this was a long back paper that was published in Journal of American Dental Association. They studied the 30,000 patients and they found that syncope was the major complication in a dental practice. Mild allergic reaction, angina, postural hypotension, seizures, asthmatic attack, hyperventilation, epinephrine shock, or whatever the emergencies are there in the medical practice or in the surgical practice, that can also happen in your dental clinic. So what kind of procedures that can lead to the complications? So obviously the tooth section is the most common procedure where you will find the complications. Then pulp extirpation and root canal treatment. Any procedure, patient can have any complications. That depends on the level of the patient anxiety or what the patient is thinking or any medical condition of the patient. So which kind of group which are more prone to medical emergencies? These are specifically geriatric population due to the physiological changes of the age, or they might have illness, or they might have taking some drugs for their illness. Pregnant females, so you should remember that when you are treating the pregnant female patients, you are treating the two lives, two persons, not the single. Special need patients, that the patient who are suffering from syndromes in where there is a multiple organ involvement. So these need special attentions. Or medically compromised individuals who are taking medications, for example, hypertensive, diabetic mellitus, some may have hypothyroidism, hyperparathyroidism. You have to be very much careful in these kind of patients. So what kind of a situation that can emerge in your dental clinics? These are the few conditions which can be there in your dental clinics. You have to diagnose which condition is this. So you can treat them according to that. If patient is having unconsciousness, just think about the syncope, then orthostatic hypotension, acute adrenaline insufficiency. If patient is having some respiratory distress, then think about the airway obstruction, that there may be some airway obstruction, hyperventilation, patient may be suffering from the asthma, that attack can be there in your dental operatory, or patient can have heart failure or acute pulmonary edema. If patient is having altered consciousness but he is not unconscious, then you can think about the hypoglycemia, low blood sugar level, thyroid gland dysfunction, cerebrovascular accident may be there. In cerebrovascular accidents, patient may not go into full unconsciousness. Patient may have seizure, drug overdose, that may be due to epileptic fits or maybe allergy. Chest pain, that can lead to angina or acute myocardial infarction, or sudden cardiac arrest may be there. There are few reported cases in the literature where patient ever died on the dental chair. So how you plan your medical emergency in your dental clinics? All the healthcare professionals may have to deal with medical emergencies. They should know that how to manage the medical emergencies which can be there in your dental clinics. So medical emergencies in dental practice are rare. These are rares. That's why sometimes we are not very much serious about all these things. So when they occur, they can be life-threatening and potentially catastrophic for all the concerns. So how to approach the medical emergencies? First, you have to involve the assessment first. Your patient's possible risk-based current medical history. Medical history is very important. Then scheduling of the treatment time, pre-dental treatment, what kind of treatment he has taken at that time, or was there any emergency or any condition he was suffering, or it is noted. The second thing is to recognize, assess and manage the emergency. You should be aware and you should know that how to recognize the different kind of emergencies. You should know that different signs and symptoms where they are leading. The third is the training in BLS. This is a very important. You all should be trained for this basic life support course. If you have not done, please do it. This is compulsory basically. So in your practice, there should be a training to you, and your staff should be trained that how to use the equipment or how to use the drugs which are available there in your dental clinic for the emergency. For example, if your assistant don't know that how to open the oxygen cylinder, that does not mean you can't waste your time. The last is documentation and reviewing the incidents. You should document all the things, what has happened to the patient, what kind of medication you have given, what has happened to the patient, or you have to review the cards or the past medical history of that patient if somebody has written in the previous visit. So I will discuss a few of them which are commonly seen in our practice. Syncope, this we all know that it is an inadequate cerebral perfusion. The patient may feel pallor, sweating, patient may have cold, clammy skin, dilated pupil, nausea, vomiting. All these are the signs and symptoms of the syncope. So for the treatment, keep calm, don't be so much hurry when you diagnose that it is a syncope. Lay the patient flat, keep the legs at the higher level than the head. Loosen all the tight clothes, especially around the neck. Record the vitals, because vitals are important. Once the pulse and the blood pressure returns to the normal, slowly raise the patient. Don't raise the patient immediately to the reclined position. So anti-tendon work position is most favorable, in which your head should be at the lower level than your feet or the legs, so that there is a pulling back towards the blood pulling towards the heart or the brain. So epileptic seizure may be there. The patient with epilepsy, if the patient is already diagnosed case of the epileptics, they have to take their normal doses early before the treatments. Epileptic patient, sometimes they don't tell you that we are suffering from this disease, or if the attack occurs in your dental clinics, sometimes it is very difficult to diagnose. So what are the signs symptoms which you can see when the patient is having epileptic attack? There may be frothing from the mouth and urinary incontinency. The seizure typically lasts a few seconds. The patient may then become floppy, but remains unconscious. After a variable time, the patient regain consciousness, but he may be very much confused. So sudden loss of consciousness, the patient becomes rigid, falls, may give a cry and becomes cyanosed with time. After a few seconds, there are jerking movements. Patient may have jerking movements of the limbs. The tongue may be bitten. You have to take care of this. The patient don't have this kind of tongue bite, because that will cause the bleeding, and that can cause the aspiration. So the treatment in the seizures, during a seizure, try to ensure that the patient is not a risk from injury to the tongue or cheek or soft tissue in the oral cavity. But make not attempt to anything in mouth or between the teeth. Don't put anything between the teeth and the mouth unnecessary. Do not attempt to restrain the convulsive movement. Don't try to control the movements. Remove all the dental instruments from the oral cavity within the confines of the patient to protect him from any possible injury. That may be air rotor, your filling instruments, extraction forceps instruments, syringes, so that there should not be any injury to the patient, because patient is doing all the things involuntary. If the patient in the dental chair, manage that patient in the dental chair. Don't try to shift into the bed or the other room. First stabilize it, then you can shift it to your emergency room. Maintain the airway. If the fits are not under control, then you can go for these diazepam as well as razepam. We'll discuss about the doses in the later stage. The other emergency can be due to asthma. The known case of the asthma, they just carry their inhaler with them. So if patient is feeling uncomfortable, you can tell the patient to have that. In the severe cases, you have to go for intravenous hydrocortisone, place the patient in a semi-reclined position, or oxygen is must in these kind of cases. If the patient is having hypoglycemic shock, that is mostly seen in early onset of diabetes patients. Most of the patients who come to the dental pediatry or in the medical, they just omit their morning meal. So they think that the doctor will do some routine investigation or the tests, or they don't require the breakfast. They miss, then that can lead into the hypoglycemia. So what are the signs and symptoms of hypoglycemia? Shaking and trembling. Patient may the shaking and trembling of their hands and the face. Sweating, headache, difficulty in concentration, aggression or confusion, fitting, seizures or unconsciousness. For the treatment of this hypoglycemia, if the patient is conscious, you can give him any sugary candies or sugar, glucose you can give him orally. If patient is in unconscious condition and you just check the blood sugar level, it is in the lower side, then you have to give 30 to 50% of the dextrose IV to control it, or you can go with injection glucagon if still the level is in the lower side. Coming to anaphylaxis, this anaphylaxis is a severe life-threatening condition, but this can, mostly this is occur when you are going for IV antibiotic therapies. So in anaphylaxis, in general, the more rapid the onset of the reaction, the more serious it will be. Symptoms can develop within minutes, and early effective treatment may be life-saving. You have to act immediately. You have to diagnose that patient is having anaphylactic reaction. You have to act immediately to control it. First line is hydrocortisone. You can give IV hydrocortisone to control this. If still there is issue, then you have to go for injection adrenaline to control all the things. If patient is having respiratory obstruction, because we are working inside the oral cavity, so patient they can swallow your, if you are doing root canal treatment, they can swallow the reamer and files, or if you are doing the crown and other bridge work, that can be swallowed by the patients. So dental patients are susceptible to choking with potential risk of aspiration of prosthesis or endodontic instruments. Local anesthesia may diminish, because we are giving the local anesthesia in the oral cavity, that diminish the normal protective pharyngeal reflexes, that also possess an additional risk, because patient don't feel that what is happening, so he or she can aspirate easily. So what are the different signs and symptoms of respiratory obstructions? The patient may cough or splutter. They may complain of difficulty breathing, will do violent attempts to breathe. He will try to breathe because there is obstructions, so he will try to breathe. Breathing may become noisy or hazy. They may develop the paradoxical chest or abdominal movements. Patient will try to breathe, so that will lead to the chest or abdominal movements. He needs required basically this air. They may become cyanosed or loss of consciousness. So what is the management of this respiratory obstruction? In case of aspiration, allow the patient to cough vigorously. Tell the patient to cough regularly. Encourage the patient to cough if conscious. If they are unable to cough but remain conscious, then sharp back blow should be delivered. You can give the sharp back blow to the patient so that something that pushes and that remove throw that whatever is in their throat or in the oral cavity. The treatment of choking patient involves removing any visual. If the foreign body is visual in the oral cavity, you can remove it with your forceps. You can use your artery forceps, or you have the Magel's forceps that is most commonly used by the anesthesia people, so that you can just pick it and remove it with your instrument in a direct vision. Additional attempts and dislodge the object may be made by the Heimlich maneuver. In Heimlich maneuver, we all know that you have to put your hands below the C5 press and you have to give the jerking, so that back pressure can just throw whatever there in the esophagus or in the pharynx that out. So what kind of armamentarium we should have in our dental practice? When we start our dental practice, it's mandatory that you should have few armamentariums to manage the emergency, or few drugs in your dental clinics or in any hospitals. So BP instrument, we all know that we should have stethoscope. Pulse oximeter is also mandatory in these days after this COVID. Intravenous cannula, it should be there in your dental clinic. Emergency tray containing all the emergency drugs. Oxygen cylinder or emergency number should be there. If you are not able to manage, you should have one emergency number of a tertiary care or the nearby hospital with you, so that you can call some emergency team from there. So these are the mandatory drugs: adrenaline, nitroglycerin, histamine, we all know, oxygen, bronchodilators. Sportive drugs, you should have this anticonvulsant diazepam. Morphine is for pain control. Methoxamine, 30 to 50% dextro. Dextro should be there in your dental clinic. Hydrocortisone, it is a very important drug. Atropine, non-injectables, respiratory stimulant, ammonia. Antihypoglycemic, sugar, candies, or you may have glucose in your clinic, or antihypertension, nifedipine. That can control the blood pressure. So what are the different techniques to administer injectable drugs? You can give the drug intravenous in emergency, or you can give intramuscular. You can also give by sublingual route. Intravenous onset of action is approximately 20 seconds. This is the fastest route to control the emergency or give the drug. The 100% availability of the drug is there in your body. Intramuscular may be mid-deltoid region of the upper arm. Anterolateral aspect of the thigh. Anterolateral aspect of thigh is having the greatest vascularity. So upper outer quadrant of the gluteal region, that is, we normally use this for intramuscular injections. Other sides, tongue or floor of the mouth. Tongue is also highly vascular organ, so the drug will absorb in a very fast or in a quick way, so that when we required it. Intranasal sprays are available in these days, which can also act in a very fast way through the intranasal mucosa. Or we can give endotracheally, endotracheal drugs. Inhalers are most commonly used, the endotracheal. So coming to little bit of the drugs, what kind of drugs these are and what are the doses. First is adrenaline. We all know it is mostly used in acute allergic reactions. This is the life-saving drug. So it is a potent bronchodilator, histamine blocking action that increases the heart rate, output, and coronary blood flow. So the dose of adrenaline is 0.3 to 0.5 ml subcutaneously intramuscular, 1 raised to 1000. So histamine blocker, they are phenethylamine. Patient is having mild allergy or feel some allergic condition, we can give this phenyramine 10 milligram per ml IM or IV. Most commonly in the emergencies, we use in intravenous. So nitroglycerin, this is a drug which should be there in your clinic. So tablet nitroglycerin 0.4 milligrams sublingually, or we can spray it in the oral cavity, or the nasal spray is also available in the market for emergency. Oxygen, this has to be there in your clinic, 5 to 6 liter per minute through a nasal hood or the mask we can give if patient is having the requirement of oxygen. Then bronchodilators, these are in the form of the inhaler, should be there in your dental clinic. If patient is having some, asthmatic attack, or that you can use this. Salbutamol is most commonly used. Then the anticonvulsants, if the patient is having any epileptic fit, or so you can give this diazepam or the midazolam IV or IM to control the uncontrolled epileptic disease. You can give it in the initial stages so that you can shift the patient to the emergency. Then analgesics, if the patient is having pain or other thing. Morphine is most commonly used when patient is having any cardiac pain, case either angina or in the myocardial infarctions. This is a drug of choice. Or antihypoglycemic, I have already told that 30 to 50% dextrosolution IV is a choice when patient is unconscious, or if the patient is conscious, you can go with the sugar candies or drink or the fruit juices to raise the blood sugar level of that patient. So corticosteroid hydrocortisone is a very important drug that should be there in your dental clinic. And antihypertensives, nitroglycerin sublingually, if patient is the blood pressure is increased and you just want to control it intraoperatively or in an emergency condition, so you can use all these two drugs. These are very easy to use. Then anticholinergics, atropine, that is called in case of the bradycardia, if the patient is having syncope and he or she is not so much recovering, you can give this atropine to raise the heart rate. If the patient is in syncope and not responding, we all know that spirit of ammonia or normal spirit we can use. This act as an irritant, and that can causes the patient to wake up. So there are few rules which you can remember. This is 10A, which you can remember that what should be there in dental clinic. These are simple things which you can remember, and you can check very easily that whether these things are there or not in my dental clinics. So these are 10A. First is the airway. Airway means oxygen should be there. Adrenaline, adrenocorticosteroids, hydrocortisone, aminophylline, then antihistamines, atropine, anticonvulsant, diazepam, then ammonia, antihypertensive, antihyperglycemics. So just remember this 10A so that you should know that all these things are there in your dental operatory. So coming to, this is a very important slide in which most of the complications which we can avoid when we assess the patients in a proper way. We take the medical history, we know that these kind of problems are with the patients, so you can adjust your dental treatment or the appointments. So first is to recognize the patient's level of anxiety. Just recognize how much anxious is the patient, he or she is willing, or how much is the level of their anxiety. Then recognize the patient degree of medical risk. Just see what kind of medications he or she is taking. So is there any need to alter the medications, or you need to consult the concerned doctor who has prescribed those medications. Pre-medicate at evening before. If patient is anxious, you can give the anti-anxiolytic drugs 1 day before your surgery. Pre-medicate immediately before the dental appointments. You can pre-medicate the patients 1 or 2 hours before your dental treatment. You can give painkillers, anti-anxiolytics, so that patient anxiety level is reduced. Early morning appointments, we all know that these are the patient tolerate very well. Minimize the waiting time to the patients. Administer adequate pain control. Pain has to be controlled. Your anesthesia should be properly working. The post-operative conversation regarding completion of the treatment. Just give all the instructions to the patient, whatever they are required, what you do have to do after your surgery, and what kind of medications you have to do. If you stop some medication, tell the patient and when you have to start those medications. So my carry home message is that history taking is still the most important aspect of patient examination. Don't avoid taking the history. So always try to take the history, or complete history of the patient should be taken before the treatment. Maintain and check your armamentarium regularly. You have to check your, whatever the emergency things are there, check regularly, so they should be there, or they are not in the expired state. Periodically check your emergency drugs, whether they are available or they are expired. Display a chart of available drugs with their indication, dose and routes, so that if there is any emergency, so your whatever the person, your attendant or the other is available there, he or she should help you to administer that in the emergency conditions. So update your emergency care knowledge regularly. Just try to study, or try to attend the CD programs, others which are there for your better well-being. So thank you very much. Thank you for your patient learning.
Thank you, sir, for your wonderful presentation. Next, I would like to invite Dr. Poonam ma'am for her presentation on implant failures.
Yes. A very good afternoon to all of you. Before starting my introduction, I would like to thank you, the 12th World Dental Science Organization, the Headquartered Academy, the Department of Periodontology, especially the Nandlal sir, who has given me the opportunity to speak on this wonderful platform of KGMC. Myself, Dr. Poonam Malik, I am a prosthodontist and implantologist, practicing clinicians. I have been a professor with the dental colleges, and now I am more into my practice and would like to distribute my knowledge and share my clinical knowledge with all of you. Good afternoon once again. So whenever I'll be talking about dental implants, the topic is more related to the failures. So whenever we put an implant, what does it comes in our mind? Yes, we have done it today. And the next day, what comes in? There is a difference between the perception and the reality of what we are facing today. Everything is changing, the world is changing. We have been through the epidemic of corona. Because of that, we have been facing a lot of issues today with the patients which we were not be able to see beforehand. So there is a lot of difference between the perception, what we see and what we do, and the real life is totally different. So let us learn from this difference today. Failures are always a pathways to the success, that what I have learned in my clinical practice. It is not that you have failed in your life, make a backseat, moved to to a different scenario. No, take failures as one of your success stepping and move ahead with it. There are a lot of clinical studies which have been done on dental implant failures, and would like to share those knowledge in the form of what is the final conclusion made with them. The biological healing and integration process, despite the recent advancement, has been changing. They have been hampered with the local and the systemic factors which could be resulting in the problems, especially the implant failures. For implant surgeon, therefore, it becomes a critical factor to study what are the systemic problems, go through the history taking, go through more, devote more time in the diagnosis rather than jumping into the treatment plan. According to the 2020 PISA Italy consensus, the implant quality scale have been divided into 4 major categories, that is the success, satisfactory survival, compromise survival and the failure rate. Success, how it has been judged radiographically, to be very much specific, 2 mm of the radiographic bone loss from the initial surgery or the initial stability period. Satisfactory survival, it is from 2 to 4 mm of the radiographic bone loss. Still it is satisfactory. Compromised below the 4 mm, more than 4 mm makes you enter into the failure zone. So, according to that, the classification have been made that shows the biological failures. It can be come in the stages of early or the primary stages, or the late or the secondary, that we see it whenever we load the processes. The second classification, it says the mechanical failures. The third one, iatrogenic, very common. Angulations. We are more into the surgical part. Whenever patients comes in, we just look into the bone part and start placing implants. And when it comes to the prosthetic rehabilitations, we end into failures. So this is one of the commonest reasons of the failures that we have been seeing today. That is the angulation and alignment, and especially the nerve damage. Patient keeps on complaining regarding the pain in the jaws, or lastly, it is the inadequate patient adaptation. Phonetics has been harmed. Again, the prosthetic comes into the face. Aesthetics has been harmed in. Bone loss is there. Again, the prosthetic part, and finally leading into the psychological problems to the patients. So there are a lot of failures that we come across. It is very difficult to cover them in 20-minute job, but I'll try to do a justification in 2 forms. We have been learning implant to be a very simpler form. In the implant, fixture is there and the abutment part. So we have been divided, I have divided the failures in the 2 zones as well. The brain mark was very wonderful person who has invented implants, and because of which I am here today. So he has a highest success rate, quoting to around like 99.9 success. But we as a clinician have been modifying the implants according to the patient mode, and there comes the success, there comes the failure rate. Today, according to many of the studies, 4.3% after 5 years and 10 years. Many clinician and many doctor promises lifelong warranty. I don't believe in lifelong warranty. We will not end we'll be ending our life one day. So lifelong is never longing. Always there have been studies which have been conducted which says 10 years follow-up period. According to the 10 years follow-up period, there are more frequent, around 26.4 rate, that is the connection related problems, that is the screw loosening. Again, what we are talking about, the prosthetic part. And the second one is 9% restoration, that is the cementation or loss of retention, that comes from the fixture part. So these are the most common failures that we come across, either in 5 years period or 10 years period, that what the studies have come to in conclusion. So first is the implant loosening or the fractures. It has been categorized in 4 stages: screw loosening, screw fracture, abutment fracture and the fixture fracture. What is screw loosening? In a very simpler word, if you continuously apply repeated loads which the implant cannot bear upon. Why? Because it's natural tooth. It's not a natural tooth. It is just replacing the natural tooth. Natural tooth comes in one go or in one body type. But here the implant and the body is connected with a screw. So it is a 2-piece one. That's why we always say that excessive load cannot be bared upon. Or what you can say, that excessive load leads to loosening of the screw. So whenever we see the excessive load, this is what it happens. Abutment fracture. Abutment fractures happens again because of the repeated and excessive load. We are just moving to this one word, excessive loading, that is happening because the abutment has been supporting the processes and the support has been provided only with the help of the screw. The process is broken and may or may not accompany by a screw fracture. Here what we call is the prosthetic failure, that is the abutment failure. The third one comes in the fixture failures due to again the same reason, excessive loading one, but now it is failing at the fixture part. This we see at the end of 10 years, and the other two failures we start seeing the patient keeps on complaining of loosening of the screw or loosening of the crown, right, or not able to chew from that side, and the patient complains of that he or she is having continuous pain whenever he tries to apply the stress. Why? Because he is continuously applying stresses. You have not gone into the theory of the patient, that patient is having a bruxism, patient is having multiple periodontal losses. So go through the diagnostic part why those teeth has been lost and apply the same during your practice. So the fixture fracture is the last one that we face in. This is the fixture fracture. Again it comes around after 10 to 12 years. The second is the causes. So what are the major causes that I have just talked about? The various load that have been imposed upon the implant. The lateral pressure. An implant is not a friendly one for the lateral pressure. So whenever we apply lateral pressure, it hardly generates the load. Everything is coming laterally, right, like bombarding yourself. Second, cantilevers. We give a longer cantilever, again a prosthetic failure which has not been planned before the surgery. Overloading. So the continuous load has been applied. The implant, we have not studied the buccolingual width of the implant, and we have either played a wider implant or narrower implant. In both the cases we are applying the excess load to it, and overloading again results into the failures. Fatigueness. Fatigueness is normally been seen in the form of an X-ray. Can you see this? This is a lighter load repeatedly been applied, and we can see it in the form of craters, ripple marks in the failures. That comes with the continuous loading that has been applied, and around 10 to 12 years of if the patient, normally whenever an implant patient comes in, he says it has been fixed. He reports you either after 5 years or 2 years, but you have to explain to the patient it is not fixed, you have to come for follow-ups. If he does not come for follow-ups, if he comes for follow-ups, you can see it into the X-rays, generate the X-rays. If not, then you will see it according to ripple marks after 5 to 7 years with the continuous loading part. Gap. This is the another commonest problem. Some of the implant patients, what we have seen in the most of day-to-day practice, they get fixtures done and get the abutment part or the crowning part done from somewhere else, or the same company is not been providing or not there, then the screw is being replaced. There where comes the problem of the gap in connection fixtures. Every company is patent with their screws, every company is patent with their abutment part. So always look into the same part of the fixture and the abutment body. The screw bearing surface, it's very, here we look around. Yeah. There is the load has been concentrated, and the most taper, the surface contact makes the tensile force against the screw act as a pressure on the fixture and the abutment. If this connection is not proper, again the load has been generated, leading to the implant failures. Gap in the connection, fixture, abutment, and screw, leading to what happens basically. We cannot see it at the micro levels, but yes, screw loosening starts in. Where we can, why does it happen? It happens because of the micro movement, micro tear, or in the sink down, etc., causing to the loosening and the fracture of the implants. The third is the misconnections. In the panoramic, we should always evaluate when we are fixing the implant and the body. We should evaluate whether the connection is fixed or it is misconnected. This has been evaluated very well, and if it is not, then it leads to again the surface to surface contact is not there, and leading to, sorry for that, this is lead to small amount of force may lead micro movements, because an implant body has to be passively fitted with your abutment. If it is not passively fitted, it leads to micro movements, and finally the micro movements leads to overloading of the bone, leading to the implant failures. Bone loss. Bone loss again happens because of the same reasons, either of the overloading or the most common pass is peri-implantitis. Why does the natural teeth fail? We never place an implant in a normal teeth. The failure is because either of the periodontitis, not keeping it well, gum diseases. So this is another one of the commonest reasons, especially in India, where teeth have been not taken care of. So in those cases also we should look upon why does the teeth have failed, and proper clearance and proper cleaning manner and follow-up should be provided to those kind of patients. Prosthetic design, which we we always overlook it. We are overconfident, right? We have placed the implants and everything goes well. No, the prosthetic part comes in before. We have to start from top down the movement. Here the role of the prosthetic comes into being. So the prosthetic problems either again in the form of abutment screw or in the form of abutment, this part fails in. The causes again the chewing, biting, again overloading. The screw is loosening, damaging of the internal screw, finally losing to the screw fracture, fracture of the abutment, and hex slip screws in. Screw loosening starts in with the masticatory forces causing the damages in the internal screw threads of the fixture, leading to the screw fractures, and finally the abutment fractures in. Hex slips out and there the hex fractures in. This is the way it looks like it. A normal hex where the abutment fixed into the implant body, and here it is a crushed one. So this is finally the result. The screw loosening, fixture screw thread crushing in, screw fracture, abutment fracture, finally the screw hex slips down. So how to overcome these implant fixtures and abutment issues? 3 R's: removal, replacement, or going for retreatment. How to do the removal? Whenever we place an implant, we are very happy. We are just on the top of the ground, and the moment, and we have placed the processes, everything is done, and after 2-3 years, patient comes in with the problem. Screw fracture. How to remove it? Nowadays we are moved ahead of the technologies. So here comes the role of the easy screw removal kit. This is readily available, very easy to use it, that is the ESR kit. This helps us to remove the screw part very easily and in a conventional way. They have a reverse driver and the screw removal drill. So they have proper drill for screw fracture removal, screw thread reshaping, abutment fracture, and it is very easy to use it. We try to remove it with an explorer, not done. We leave it like that. But if we start using these type of instrument which helps us makes our practice easy, it becomes easy to do all these procedures as well. So take failures as your stepping stone towards success. That's why these type of kits have been invented. Fixture removal. The fixture removal can again be treated with the help. Earlier in the past, we used to remove the fixture with the help of the trephine burr. The most common problem with the trephine burr is that we are removing the excess amount of the bone along with the implant. So came the role of EFR kit. It's very easy to use it, and here the loss of the bone has also been less. So again, this kit has a proper step and very easy to use, as similar as to the ones we use it in our day-to-day practices, the implant kits. So what is the learning objective? I have faced it, I have learned it. You should also put it into your mind. Every failure is just another step closer to your win. Never stop trying in. Recommendations, according to diagnosis, very important. Move ahead with the treatment planning, finally the execution, and lastly, very important part is the maintenance phase. I love doing implants, I love doing a patient making smile. It is not age bound, it's only your ethical work, it is only your knowledge sharing part. Every person, whether 25 years, whether 65 years, whether an old age lady, very cute one, and edentulous patient. Everybody can have it, but don't think that failures will make you stop anyway. Don't stop anyway. I keep it in mind satisfaction from both the point of view, from the clinician point of the view, from the patient point of view. The satisfaction should be at the priority, but keeping in mind what is good for that patient is important. I am very thankful for all my students yesterday also and today also, because of which I am standing here today. And thanks again to my mentors. Sir joined late. I would like to thank Sir department from the Department of Periodontology. And you can join me again next week on 23rd of August for having more insight of the fundamentals of implantology. Thank you for all for the patience hearing.
Thank you, ma'am. Next, I would like to invite Dr. Athreya Rajgopal, sir. Sir is an eminent oral and maxillofacial surgeon, internationally renowned facial cosmetic surgeon, and his topic for today's lecture is facial aesthetics.
Thank you. Okay, very good afternoon, everyone. And first of all, a round of congratulations to all the fellows who have passed out today. And it's a great achievement for all of you. And getting it from an organization like PFA, I mean, nothing can be better. And secondly, I would like to thank Cynodent, especially Dr. Anmol and Dr. Ashish for making this possible, so that we are all here and we are all here learning and learning something new with so much of knowledge being shared on the stage. So I take that privilege to thank them again for having me here as well. So facial aesthetics, when we talk about, facial aesthetics is a very broad spectrum term. When we talk about aesthetics, it is got a lot of things that you would want to learn, which basically means not just toxins, fillers and threads and beautification. There's a lot of surgical work also that we do to get the best results for our patients. Yeah, I don't have too much of time. Because of the paucity of time, I'm just going to give you in brief what all we can do with aesthetics, so that it can open some horizons and some spectrums for you. We had a brilliant hands-on session yesterday, and we were able to throw more insight on each topic, but I'm just going to keep it very brief today, and so that you can at least understand what all is a part of aesthetics. Now, every time I show this slide, I always say, you know, this is just a study which I don't agree with at all. It basically says that women age faster than men. Every time I say this, I don't believe in this fact. Why? Because there are a lot of reasons behind it. The skincare routine is something that women take very seriously, men don't. And when we age, men age much faster than women on any given day, we age by the second and by the minute, nothing changes that. So it's just because of the anatomical structures that men tend to, look their age a little longer, but when it collapses, they tend to look 5 to 10 years older than their age, and it's a known fact. So this study, which was published 10 years back, almost 2014, doesn't stand a chance in today's time. Why do we age? We age because of something which is continuous. We lose fat on the face. Now on the face, the fat is something which is very, very important. When we lose volume from the face, we tend to age much faster. So in total, there are 14 fat pads on each side of the face, and when these fat pads collapse, that is the time we start aging, and it is a constant process. In this duration, what happens is the retaining ligaments which hold these fat pads in their position tends to collapse much faster. It's actually the attachment of the bone to the soft tissue, which is the muscles, and when this collapses, that is the time we age much, much faster. So our aim when we do aesthetics is to give back volume so that these retaining ligaments, 8 in number in total, can actually retain in their position way longer. The triangles of aging are no secrets. It basically says that when we are young, there is more volume in the temples and the midface rather than the jawline, and our aim in restoration of aesthetics is to give back volume to the midface and the temples so that the jawline appears thinner or narrower. And that is why if you see an aging face, it always looks oval rather than the younger face, which has a jawline which is more refined. In a younger face, you will always see a jawline which is way more refined. Now, what is aesthetics? There are a lot of components of aesthetics. There's the use of minimally invasive or non-surgical aesthetics. The term is not non-surgical aesthetics. It is minimally invasive aesthetics. Because for all these, most of these you will have to use injectables, like the use of toxins, fillers, threads, blood derivatives, lasers is a major topic, microneedling, and then there is surgical aesthetics as well. A lot of us think aesthetics is only about the injectable, about toxins, fillers, and all these things. Well, it's a way bigger topic, and there's a lot more to learn here. Like, for example, these days we do a lot of feminization or masculinization surgery. Just showing you simple examples of this. For this patient, we have done all these procedures. Rhinoplasty, surgical. Can you see the nose, which is looking narrower? Bat ear correction. This male also had a ear which was too prominent, so reducing that. Lip reduction. Placing implants in the jawline and the chin. These are implants that we are placing so that we can give him a masculine jawline. Then doing submental liposuction so that we can actually trim off that excess tissue from the chin. And I'll show you tons of these. So it's not just about aesthetics in the form of non-surgical aesthetics, you have to give results to your patients. And that takes a lot more of effort and a bigger mind frame. I always say open your mind frame. Aesthetics is a very big broad spectrum term. And apart from this, we've done a lot of body procedures also, but that's how it is. Coming on to toxins. Toxins, I call it the poison that heal. It basically means that you have a vial which neuromodulates the muscles. You need to dilute it with 2.5 ml of normal saline if it's a 100-unit vial. Once you dilute it, you are able to inject it with the use of insulin syringes. Every mark on that syringe means 1 unit. In toxin terminologies, we talk about units. In fillers, we primarily talk about mLs, how many we are using. So basically, toxins work by stopping the release of acetylcholine from the neuromuscular receptors so the muscles don't contract. What other things can we use toxins for? Probably TMDs, atypical facial pain, neuralgias, muscle movement disorders, which is known as dystonia. Before we start this thing in whatever pictures, I'm going to keep more pictures so that you can actually see the befores and afters and understand what we are doing here rather than giving you more of theory, because nobody is going to learn in an hour's time. But you should know what you can achieve when we are talking about aesthetics. So yes, the most important thing is learn when to say no. A lot of patients who come in, ask for unrealistic expectations, and those cannot be achieved. These are simple, straightforward cases that you can see the forehead wrinkles can be reduced, and I always say the term is you use toxin to relax muscles, not paralyze it. Okay, because it's a wrong terminology. Imagine you've come to me for treatment and I say I'm going to paralyze your forehead muscles. You're not going to come back to me again, right? So the terminology is relaxation of the muscles. That is where it can be a hyperactive muscles, it can be a hypertrophy, you can use it in any of these conditions. In this case, pretty much the same case, only difference is I have injected fillers into the glabellar lines because they became static. Otherwise, it's the pretty much the same thing that we are doing for every other case. Dimpled chin can be reduced with the use of hyperactive mentalis, hyperactive masseters, temporalis, all these muscles. Gummy smiles, we've all seen cases of gummy smiles, right? There are two reasons why this primarily happens, skeletal and dental. In skeletal point of view, we are basically talking about vertical maxillary excess. If we are talking about vertical maxillary excess, most of us would want to advise the patient on an orthognathic surgery, primarily a Leafort 1, and when you're setting back the maxilla, you actually have to give a counter to the mandible, so we'll have to cut the mandible with a BSSO and get proper occlusion to reduce your gummy smiles. How many patients will be willing to undergo a bi-jaw surgery to reduce a gummy smile? Very few. Till date, just by counseling the patient for a gummy smile, I have got a case series of only 8 patients, only 8. But when I started using the toxin, my case series went up. Why? Because if you see the before and after, this is just done with the use of 5 units of toxin bilaterally, the gummy smile came down by almost 5 millimeters. It's a motivating tool for the patient. So my numbers kept on going up. By using toxin, patients want permanent correction. So those numbers went up to 32 who got orthognathic surgery for a gummy smile. The point is known as the Yancey's point, where the 3 muscles, the zygomaticus minor, minor, levator labia superioris, and the iliac nasi come in close proximity. They don't bisect each other, but come in close proximity. So when you're injecting the neuromodulator, it basically relaxes this muscle. So the smile doesn't go up too much. In this case, if you see, this case I did almost 12 years back. There's a difference here. So I did 2 sessions here of 5 units of toxin every 14 days. As I mentioned yesterday as well, the peak effect of the toxin comes in 14 days time. Okay. So in 28 days, I had given 2 shots, so 10 units bilaterally. So the smile, if you see, the patient was happy, but eventually there was a problem there. If you see, the muscle tonicities were lost, the patient was not able to pout, or in simple terms, was having something and the food was popping out. So I had over-relaxed the toxin. So I studied this much more in depth. This is one study that I referred to. This is the largest study in the world, actually, studied over the largest duration. It's a PubMed indexed article. If you want, you can refer it. So a lot of things you will come to know with this article. The other options are small surgical corrections. You know, if the patient's occlusion is fine, they don't have a short upper lip, a simple vestibular incision to cut more of mucosal tissue rather than attach gingiva, and these results are permanent. All of you can do it. It's just a 10-minute job. This is not going to change, right? So patient tends to smile, and that's where the smile is going to be. We use it for a lot of other cases as well, like hyperhidrosis, sweaty palms, sweaty axillas, face. A lot of people sweat on the face, so yeah, you can use the toxin for it. Neuralgia, I give a lot of toxin during my initial phase where the patient is on medication, because the neuralgia is starting from trigger zones. If you give extraoral shots of toxins into these trigger zones, the frequency and intensity of pain tends to go down. In TMDs, I have got a case series of almost 450 patients to tell you that acute TMDs, when the patient is on spasm, reducing the tonicity, and even in full mouth implant cases, wherever I do a full mouth implant case on the day, if it needs to be immediately loaded, I obviously give about 80 units of toxin to 90 units of toxin to the temporalis and masseter, because it reduces the bite force by 25%. That is a good kickstart to your implant journey. In TMDs or bruxism or all these parafunctional habits, it does the same thing. It basically relaxes the muscles, so the patient bite forces goes down. And it really helps the patient. You can't keep the patient on muscle relaxant for months and months to go. So it helps these patients out. These are the points where we inject the toxin. We use it for a lot of atypical facial pain and migraines, like frontal migraines, parietal, temporal, occipital, even scalenus muscles and trapezius, we tend to inject it. Now, how do we volumize? There are only 2 ways to volumize static wrinkles. What are static wrinkles? Which are at rest. Now, there are only 2 ways to volumize, in the sense you can either use fillers or you can use the patient's own fat. We're going to talk about both. Fillers, multiple brands are available. It is made up of polysaccharide. The commonest filler that you would use will have hyaluronic acid. And please make sure that the fillers that you use are FD and FD approved and have a CE certificate. Otherwise, you are not supposed to use those products, because they are not eligible to be used on your patients. Not going to go into details of this, how we synthesize fillers, but you should understand that the fillers are cross-linked and have 2 phases. Most of the fillers are biphasic. That means they have a gel form. For a gel form, they need a carrier. So that is why it is a biphasic gel. You have to understand the flow, and the most important thing is whenever you get onto fillers, you have to understand the G prime and the extrusion forces for the fillers. A higher G prime is preferred. There are two types of forces that affect the fillers, which are primarily torsional and compressional forces. But the techniques of injections are the most important. How do you inject fillers? The most common techniques are retrograde linear threads, which is basically you're injecting while you're coming out from the defect, fanning, which is one point of entry, multiple retrogrades, serial punctures, aliquots, or boluses. Cross-hatching is obsolete, so we don't use it anymore. The worst thing to do is place your filler too superficial. Epidermal filler placement is actually considered to be absolutely wrong. The good thing is you have an antidote for fillers while you don't for the toxin. So if you've injected toxin onto a patient and overdone it, there is no way that you can get your toxin out. You'll just have to bear with the patient for the next 4 months because the toxin lasts for about 4 to 6 months. Or you can shut your practice and stay at home for 4 months because the patient is going to trouble you. Okay, so what is the most important vessel on the face? Facial artery, right? It is the second branch of the external carotid artery. It takes an S-shaped curve, comes in front of the masseter, also known as the anesthetic artery, gives out about 8 branches on the face. Why is it so important? Because when you're injecting fillers, you should know one thing, that you should know where not to inject. If you know where not to inject, that is where you're doing the right thing. So that will only come once you're able to train well. As I always mention, multiple fellows of mine are actually dissecting cadavers more than getting onto patients straight away. And after that, they don't need any revision or anything like that. It's imbibed in their mind and they know what not to do. So those who attended yesterday will not speak. I just want to ask a very simple question. How old does she look? I know who attended yesterday. So, yes. How old does she look? Come on. 48. Wow. Yeah, you're close. Very nice. Tell me, come on. Maybe slightly closer. She's 72. Okay. She's 72. She came in for drooping corners of the mouth, and if you see, the corners are at an angle to the jawline. Now, I'm going to show you something. The same day evening, she came back with this. She kept on colic because my filler had entered the vessel. Nobody shows complications. I'm going to show you tons of complications if you want. The filler enters the vessel, and this is what it does. It blocks the vasculature. There are two types of vascular supply there. What are the two types of vessels that you will find? We're not talking about capillaries. We're talking about veins, and we're talking about arteries, right? If it's a venous vascular occlusion means an emboli which has entered the vessel. So if it's venous, it will come up over a period of 3 to 4 hours, just like in this case. If it is arterial, it will cause immediate pain, severe pain, just like a sharp neuralgic pain, and it will bloat up completely, immediately on the right in front of you. That is arterial vascular occlusion. That is dangerous, way more dangerous. So you need to have your hynidase, which is an antidote, immediately ready to inject these patients. Same day evening, I called her back at around 11:45 at night and injected hynidase. And if you see the result of the after, that is after overcoming the vascular occlusion. And that's how you're supposed to deal with it. You're going to find complications around the corner. You should just know how to treat them and get over them. Young male, if you see mid-face treated with about 3.5 ml of fillers, the same male, if you can see, he had a very fat mid-face, so we've just given him a little bit of prominence. Same male came in for chin correction, did not want a genioplasty, eventually landed up getting one last year. This photo is from almost 5 years back. Can you see the nose to chin angle? It's got a very retrognathic profile. See the nose to chin angle now. Done with about 3 ml of fillers. If you see, the nose to chin angle gets better. Can you appreciate the difference? Yeah, that's what it is. You can actually, and fillers, the results are instant. You will see the results then and there. In a week's time, the filler hydrates and looks better. Temple fillers, not for beginners because it tends to, it's got a lot of vasculature, so we tend to do temple fillers and mid-face fillers. Need a little more experience. These are threads that we are actually building up. These are cork threads, aggressive threads. We are actually building up the temples and those areas to actually give a stable base. We do this for the entire face and neck as well, to recontour. Then there are other kinds of threads that you can use, which are primarily mono threads. These are small, non-aggressive threads. Some of you who attended the workshop yesterday got to see a live demo of it, and that's how it works. It believes in area-specific tightening. and you can use it in combination in variety of areas of the face. These are cork threads which are a little more aggressive. You can use one point of entry or multiple. You can lift up the entire face with it. These are 100 mm threads or even longer. So from one point of entry you can do multiple approaches, and you actually lift up the entire face with this. I'm going to show you a little more. So it's a long presentation. I'm just going to rush through it a little more. If you can see the before and after, she only came in for the nasolabial, but if you ask me, I would have done about 4 ml of fillers for the mid face to make it look better. She eventually went back with just 1 ml of filler and about 10 cork threads bilaterally. She was happy with it, but she said, I'll come back for more. It's all about how much the patient can spend also. These are expensive procedures, okay? She eventually did come back and referred a lot of patients for a correction. This is my own technique. I call it the triple vector lift. One is suprazygomatic, one is subzygomatic, one is from the jawline, and I have a quadrangular lift where we lift it from the jawline as well. Same lady. If you see how this thread works, one point of entry, and if you see the one point of entry goes in through all the subcutaneous tissue, bypasses your masseter, your facial artery, all those vasculatures, but these vasculatures are very down below. They are below your subcutaneous tissue. So once you put this thread inside, they work by a pulling mechanism. If you see, once I pull it, the entire tissue will lateralize with it. So that's how I will end up lateralizing the entire face. And you can tuck it in that position. So if you see, she's a doctor herself. Look at her face, which was rounder and ovalish, and all done naturally with the use of threads and some deoxycholic acid. She has a profile now, which she can actually appreciate. We also do a lot of tear trough fillers and all those things. This is the technique which is known as fanning. One point of entry, multiple passes with retrograde linear threads, and you tend to, fill up those hollow spaces, dark circles, and all those tissue deformities that you can actually, relate to. So you inject while you're coming out from the defect, rather than injecting while going into the defect. And it's a very simple, straightforward technique. There's no science here. I mean, except for understanding which level of tissue to place the filler, there's nothing else than that. It's that simple. Another one, if you see the before and after, these are immediate corrections. Another one, the only thing is this is done with a needle rather than a cannula, and also the zygoma I've done with the filler. Lip fillers are a little different. Lip are very important. When you deal with the lips, you have to deal with the entire face, because you can't give lips which are not matching the facial profile. On Indian faces, sharper lips make a big difference. So all these are lip pigmentations and lip fillers. These are very routine things. This is a cleft lip, so eventually I had to do a fat graft for this young girl. I gave them some shape or structure that makes him look like a lip. This is a complication that was sent, so basically it required surgery, because it was almost 1.5 months after the filler case. Now you can also do something like lip reductions, which are also very simple, straightforward. A lot of Indian young males will have this. They have a very hefty upper lip, so you can actually let go of that. A very important thing in aesthetic surgery is buccal fat removal. Buccal fat removal comes at a very important structure. It is a deep fat pad, and when you remove this buccal fat pad, you actually want to reduce half of this buccal fat rather than the entire fat. How does this work? I'll show you. It works in a very subtle way. It gives a profile change which you will not be able to explain, but it will be there. And you can combine it with other aesthetic surgery techniques, or with non-surgical or minimally invasive techniques as well. Small incision, safeguarding the Stenson's duct, go through the deep fat plane, harvest it, and remove half of the fat. It's a very simple chair-based procedure. How does it work? It works like this. This young girl thought she had a very round-looking face, and do you see the difference there? There is a difference that you can appreciate. Yes or no? Yes, right? It's subtle. It's not aggressive, but at the same time, there is a difference which this young girl wanted, and we have combined it with other procedures as well. Now, you can do rhinoplasties, or you can do non-surgical rhinoplasties as well. Non-surgical rhinoplasties are just known as nose corrections. Those are not rhinoplasties. Rhinoplasty has to be surgical. Okay? So you can combine it with the use of cork threads, rhinoplasty threads, fillers, and that's how it makes the difference. It gives an elevation, it gives a camouflage to the nose and the tip and the dorsum. Now this lady, I had to do a lot more. She did not have time for a surgical rhinoplasty because she's got an important work profile. So the one thing that she complained about is nose looks the most prominent on her entire face, and the face looks very, very narrow. So what we did was, we tried with rhinoplasty threads, she was not very happy. So I ended up taking her for a facial fat grafting and alarplasty and nasal augmentation with fat grafts. I took some fat from her belly, and if you can see, I'm filling up her nose with some fat. And I filled up the entire face and did a small alarplasty to reduce the width of the nose as well. You want to see how she looks? That's how she looks. Okay? Looks better? That's how you can make a difference. Your treatment plan needs to be inspired. You know, you should be clear in your mind what will make a difference. Remember her? The ones we were putting long threads? Yeah? She came back. She came back after 2 years. And look at what we did for her. We did a rhinoplasty, a facelift, fat grafting, and that's how she looks before she left. And yes, she was happy. And she's been continuously sending her family members for a lot of treatments. And that's how it is. When your patients trust you, they will eventually refer. So coming on to some surgical things that we do, I'm going to rush through this. Just male facelifts are completely different from a female facelift. Patient like this cannot be dealt with a non-surgical technique. Why? Because if you see, the tissue has lost texture and a lot of volume. So we have to treat it surgically. This is, if you can see, this is 4 weeks post the facelift. The scar is hardly visible, and if you can see, that's how you want to treat such cases. These are all surgical cases to make a difference, to change the entire profile. Is there a difference that you can see? Considerable difference, right? How is it done? Well, I'll show you. That's how we harvest fat. This is another patient. You can use the belly, or you can use the inner portion of your thigh. That's pretty safe. Why is there too much of RBC content? Because this lady had 7 stents in her heart, had 1 round of MI, and was on a lot of blood thinners, but she wanted her face to look good. So I could not add adrenaline to my tumescent, so that is why I only saline as tumescent. And then the submental lipo, which is done like this, removing the fat from the double chin and all those areas, stubborn areas. Again, the same. And then the easiest part is injecting. That anyone can do. All of you can do. Even this you can do. So if you can see the before and after, you're just changing the profile to make it look better. These are surgical. This is an Australian patient. We get a lot of such patients who come in and fly off in about 2 weeks' time, 3 weeks' time. If you can see, the difference is, this is a surgical facelift. A preauricular incision extending to the postauricular region, a small incision into the submental area for platysma application. And if you see, this is the SMAS, which we have to dissect. This is known as SMASectomy, and pull it back and attach it to a higher level so that the plane looks higher lifted. I do a lot of fat grafting because it's all because of volume loss. So you have to give back volume to the midface and the temple so that these patients look younger at the end of the facelift. And that's the injecting of the fat after the facelift has been done. Once you are closing, you basically want to just tuck it in with a little bit of fat for the midface. This is micro fat. Okay. How does she look? This is immediate post-op. That's how she looks. That's how she looks. See a difference? These are surgical cases, okay? And they come in asking for corrections which can last. Another one, she's about 58, but she looks much older. Look at the number of procedures we have planned: face and neck lift, platysma application, blepharoplasty, lip lift, forehead reduction, genioplasty, facial fat grafting, or in about 5.5 hours. These are all the incisions which we have marked. This is the dissection and the incision for the facelift. This is the excess tissue after the dissection. We cut this tissue off and place it in another plane. This is the forehead reduction because she had a wider forehead, so we want to narrow down the forehead a little. This is the genioplasty. It's a 25-minute job with a piezotome. This is a blepharoplasty, bilateral. You can do an upper and lower lid. In this case, she only needed an upper lid. That's how she looks on the 3rd day. And in 1 month, she was ready to go off in 1 week's time, and she was very happy. She's an Australian patient. And that's how we do fat grafting. You filter the fat, and it's ready to inject. Injection, all of you can do. The techniques remain the same, like fillers, temples, mid-face, everything remains the same. A lot of males come in to get this done. If you see the tired-looking face goes off, there is nourishment because the stem cells from the fat are the best stem cells to have. So it gives adipose-derived stem cells, which actually nourishes the face and whatever part of the body that you use. In this case, It was a failed case of fat grafting, so I had to redo it and use facial fat graft with a macro graft rather than micro. Then there are a lot of blood derivatives that you can use in the form of PRP. I don't use. I use a lot of GFC and more so PRF. Why it helps is because it's based on low centrifugation rate. How it helps is it will rejuvenate naturally over a period of time. It lasts for about 12 to 14 days. Then there are pigmentation issues which you can use lasers. Like in this case, we've used Q-switch lasers. It reduces a lot of pigmentation, but for this we'll require a lot of time. We don't have time. Hair, we do a lot of transplants. And so I'm not going to get into the details, I'm just going to run through it. But transplants actually can change lives. Okay? Hair transplants, this was my Prof, okay? And he was my Prof who came in for a transplant 10 years back. 3,500 grafts, recipient area. Patient's own hair is the most important, and when you can do that, that is the best thing. But the patients have to take care of it. A lot of these patients wear patches, and actually they damage more. So this patient used to wear a patch. If you can see, he lost more hair than what he had after wearing a patch. And these are his own hair, right? In 10 months' time, you get the best results. Look at this young patient with 3,800 grafts, FUE, bio-FUE. This is own hair. Yes, hair transplants, transgender surgeries. We do a lot of transgender surgeries. Mostly, a lot of males come in for a transgender facial feminization surgery. We do almost 2 or 3 a month. And if you see, hair transplant or the forehead is one of those things that actually is very important. So making a female pattern hairline, doing things like a beard graft, these are all transplanted beard grafts, doing eyebrow grafts using different techniques like a plasmo regenerative technique to resurface. Now coming on to some of the cases, you have to mix and match. You have to know everything. Just because you are trained in one procedure, that doesn't mean you can deliver results with everything. Till the time you are not trained well, you will not be able to deliver results. The aim is to make the patient look what they are at their own age, but a better them. Don't promise them something that you can't deliver. Look at all these pre and posts. There are almost 8 to 10 procedures done for them at a repeated interval. Sharper jawline, sharper mid-face. This one was a tough one. Combining them, making the face look what she wanted, non-surgically. This was not done surgically. Is something that was tougher. And if you can imagine, we have done 58 cog threads, 200 mono threads, about 8 ml of fillers, 2 sessions of deoxycholic acid, and that's all we did for her. Lots of such patients, who come in repeatedly. Now, it's important to open your mind frame. When we train our doctors as well, if you can see, this was a case that we did last month. This young male had been operated twice. Look at his craniofacial, he had a craniofacial fibrous dysplasia. Everywhere. It was widespread. So I had to open up his entire thing, I had to shave his cranium off. This is all his irregular cranium, which we had shaved off to give some symmetry, put some graft in the frontal area because the frontal bone was completely gone. Okay? And apart from this, planning the osteotomies, just like an orthognathic surgery. See his cranium, that's his state. And I want you to see what we did for him. These are osteotomies to the jaw, to the mandible, to the zygoma, to the chin. Just coming on to the last bit of it, last 2 minutes I would take. Now these are the L-shape osteotomies for the angle to make his angle look normal. Look at his post-operative result. Looks better? And this is just in 2 weeks' time before he left. So these are all cases that can make a difference, that can help the patients. These are also all aesthetic procedures, these are all cosmetic procedures, right? So I would like to conclude by saying you should know what you're doing, you should train well, you should use good products, your patient selection should be apt, and if these are right, you will be doing a good job. There is no shortcut in aesthetics, it's a very long drawn procedure, you will have to train well. Open your mind frame, it's not a very short mind frame, don't believe social media too much. It is not just about social media, what you see on social media is just half true. It's true when you do it in person. And this is without filters, okay? Life doesn't move on with filters. Life moves on with what you can deliver to your patients. Your patients will come back only if you are doing a good job. Without that, they will not come back. So yeah, thank you for a patient listening.
Thank you so much, sir, for wonderful session. Before moving to the next lecture, we would like to invite Dr. Nandlal, sir, Dr. Pavitra Rastogi, sir, Dr. Ruchi, ma'am, Dr. Pankaj, sir, Dr. Ashish, sir, to felicitate our speakers. I would like to invite Dr. Pinky Mathur, ma'am, for felicitation. Thank you, ma'am. Now I would like to invite Dr. Satnam, sir, for felicitation.
Yes, ma'am, you can.
Now I would like to invite Dr. Poonam Malik, ma'am, for felicitation. Thank you, ma'am. I would like to invite Dr. Atharya, sir, for felicitation. Thank you, sir. Now I would like to invite Dr. Garima Podar, ma'am, for felicitation. Thank you, ma'am. Now I would like to invite Dr. Jasnit Singh Kalra, sir, for felicitation. Thank you, sir. Thank you, ma'am. Now we will continue with the lectures. For the next lecture, I would like to invite Dr. Garima Podar, ma'am. She is a faculty at Dental Department of Shanti Memorial Super Specialty Hospital, Cuttack, Odisha.
Good afternoon, everyone. Am I audible? So, the topic for today which I would be presenting is top tips for predictable root canal treatment. And when I landed at the airport at Lucknow, I was greeted with this, "Muskuraiye, aap Lucknow mein hai. Smile, you are in Lucknow." So, I want all of you to smile, be happy, and I want that to be, evident, from here on the stage, because we have more than one reason to smile today. One, we are in Lucknow, yes. Two, you all got inducted along with me with the PFA fellowship, which brings me to take this opportunity to thank the PFA Academy, PFA, the Cynodent organization, Dr. Anmol and his amazing team, and KGMU to have me over here. So, thank you so much for this opportunity. I really look forward to this small 25-30 minute presentation where I would like to discuss small tips and tricks for the root canal treatment. I know it's a small time, but trust me, if you can take back 2 or 3 good tips which you would be able to apply in your clinical practices, I think it's a win-win situation for everyone. So, let's get started. So, that's me. I am a practitioner, a hardcore clinician, but having a passion for teaching. Also, I am a certified silver member of the Style Italiano Endodontic group, and I have been conducting a lot of workshops and lecturing throughout the globe. And what I teach, I usually am so passionate about root canal treatment that I definitely would like to, distribute and share my 2 cents about the root canal treatment practices, how we could acquire the advancements and make our clinical practices more worthy. Now, the first and foremost, this is not only for a root canal treatment, but for any dental procedure which we are doing, be it pediatric or anything. It's the fear of pain. So, you must have seen, whether in a clinical setup or in an academic institution, what is that one thing which the patient dreads? It's a dental treatment. And why are the patients so scared of dental treatments? Because of the fear of pain. And it's a vicious cycle. Pain leads to fear, fear leads to more pain. Now, I would like to show you some gadget and tools which would be helpful in erasing or abolishing or diminishing the pain. So, I am talking about a little bit of one tip and trick which could make your endo practice or your dental practice of giving a local anesthesia painless. So, first and foremost, I would like to highlight about this product called the Star Pen. It is an anesthesia delivery device, and this particular device is having multiple benefits. One, cross contamination is less. It has a soothing music which helps to soothe and ease out the patient, and at the same time you are using a thin gauge of needle, and yes, it has aspiration facility also. So, trust me, this was a practice builder and a game changer in my clinic. When I started using this product, I was so happy because my patients would multiply, because they would refer more patients. Oh, inki clinic mein jaiye, yahan pe pain kam hota hai. So, that is one. Two, if you are giving an infiltration and you are doing, let's say, endo for a maxillary arch, you are doing endo for a maxillary molar, and you do not have a device like that, I would suggest that using your insulin needle, your insulin syringes, which is like a 30 gauge and small gauge needle, it is really helpful. And here I would like to give you a tip that for your root canal treatments, there is no need to give a proper block for the maxillary arch. Only a buccal infiltration in most of the cases is sufficient. Yes, for a mandibular you would need a profound block, and then sometimes intrapulpal also. And if you have a gadget like this, you can aspirate also, you can give those blocks, And you know, we are using those big vials in our clinic in which we just, you know, plunge one needle for, I don't know, months together, and then we are just using it again and again. So you would be able to reduce the chances of cross-contamination and infection in your operatory. Now, a very important topic about endo, we all do radiographs in our clinic, but sadly sometimes we do not understand that radiographs in your normal dentistry versus radiographs in your endo practice are a bit different. And how are they different? I've written an article about the importance of tube shift technique in endo. It is freely available on the Style Italiano Endodontic website also. If you want, you can go and read. Now, what I'm trying to say basically is, you know, when I started my practice, I passed out and I started my practice in 2005, I would do a lot of lower anteriors and I would be like, oh, very happy. Lower anterior has come, it will be a piece of cake. One drop, I reach inside the canal, I would do a good root canal treatment, I will fill it up, it looks great on the x-rays. And boom, after 6 months, I was seeing a lot of my mandibular anteriors getting failed. And I was wondering what is happening. And then I realized that a basic small thing which I was not doing correct. And that is, I was just taking a straight view radiograph and there was superimposition of two canals over each other, the buccal and the lingual, and I was not aware whether this anterior tooth is having a single canal or it's having two canals. So my next tip, a very simple tip, but if you make it a practice in your clinic to take at least 2 good preoperative radiographs for an endo tooth, one from a straight angulation and the second one by a 20-degree, 15 to 20-degree tube shift, you would be able to separate those parallel canals which are superimposed on each other, and you would be able to view them properly on your preoperative radiograph. Simple. So let's have a look. Now have a look at the left-hand side pre-op image, which is a you know, a straight view image, and here what I can see is a single line on the tooth. The moment I make an angulation of around 15 degrees, I am able to appreciate two canals better. So it's a 1-to-1 anatomy. And if I leave one of those canals, I leave behind so many bacteria inside, and chances of a relapse or a reinfection is increased multifolds, right? So it would be more evident on the post-op. So have a look over here. That was the pre-op. It looks beautiful. But the moment I make an angulation, I would realize, oh, there were two canals in this particular tooth. And if with this practice you would realize that, you know, if you make that habit of taking at least 2 to 3 good preoperative radiographs, you would realize you have seen so many mandibular anteriors, laterals, you know, and canines having more than one canal. Similarly, with the canine having 2-1, we always think canines, oh, 1. I want to show you one very interesting case, one of the most unique mandibular premolar which I have done. Now have a look over here. When I see this tooth, what can I see? I can see a pinpoint exposure, generalized adhesion, and then there is a deep radiolucent line. And then at one point at the coronal third, I see that the deep line fades out, and it fades out, and then all I can see is splits, a little bit of crisscross of mesh of canals. All right. So that point at which that deep radiolucent line diminishes and breaks into different branches, that is the point of fast break. So in radiograph in endodontics, you have to read your x-rays well. When you read, you would be able to you know, understand a lot of things. For example, in this case, I was in doubts because in the straight view radiograph, I could not understand much. So I made angulated radiographs. And in this particular case, actually this was tooth number 44 with 2 roots and each root having 2 canals each. So it was a case of 4-4 anatomy. So there was, imagine, a mandibular premolar with 4 canals inside. So I made a mental note exactly how much I would be shaping, how slender my preps would be, etc. And what we could do is 2 buccal and 2 lingual canals. I always work under a microscope, but even if you're not working with a microscope, if you are using your radiographs well, you would be able to avoid missing those canals really well. So this is the case. So it looks like a squid, 4 different canals. So imagine if I would not have understood that there are multiple canals, I would have made a very small microscopic axis and I would have easily avoided other canals. But then it would have landed with a failure. So this is the 19-month follow-up for this particular case, and I have a 3-year follow-up for this particular case. And this made me realize that premolars are not that simple. They are enigmatic and there could be multiple canals, different canal configurations. Now, let me give you a quick tip about access opening for anteriors. Now, have a look at this diagram. Over here you can see there is a central incisor, and where do we make the outline for our central incisor? The point where the cingulum ends, in the middle third, right? And this is how it looks. Now this one I would call the conventional axis. Now how about I take that axis a bit up and make it an incisal axis. Now if I take my axis opening a little above, little higher, I would be able to have some benefits. And what are those? Why am I advocating that go for an incisal axis? Because when you do that incisal axis, your files would drop inside the canal more straight. It would not have to follow too much of curvature, number one. Number two, you would save a lot of bulk of dentine in that area, in the bulky part of the tooth. And as it is, if you're planning for a full coverage crown, we would be chopping off 2 millimeter of the incisal margins. So if my axis opening is a bit above, I would be able to retain a lot of sound dentine structure. So for anteriors, nowadays what I've done a modification is my outline forms are a bit more incisal. Let us talk about something which is a game changer in endodontics, and that is ultrasonics in endo. So ultrasonics has multiple benefits for access cavity refinement. There are so many good kits. This one from Woodpecker is very, very genuinely, decently and very minimally priced. And trust me, what I do is, I do my gross access cavity preparations with the help of your handpiece and burr, and then I keep it aside and I use my ultrasonic tips for final refinement of the canal walls, for troughing of the isthmus area, for locating all those extra canals which might be there, for removal of pulp stones, etc. And there are further more kits which are there, and this, for instance, this is a Dr. Talal's endo kit, and this one is beautiful whether you want to do endodontic activation of the irrigating solutions, or you want to remove a metal or a fiber post, or you want to remove that pulp stone. All you have to do is, you should be having an ultrasonic scaler unit in your clinic which is having compatibility with these tips, and all you do at that time is that you can switch off the water for better visibility, and at a lower speed you use these tips, and then you can irrigate or flush out with the help of water to get the debris flushed off and for cooling purpose of the tooth. Now for activation of my irrigating solutions also, I always rely upon ultrasonics. So you could use a standalone ultrasonic device, or you could use any activation tips, attach it to your ultrasonic scaler, and boom, you would be having a great activation of your sodium hypochlorite, etc. So for instance, I am using this scaler, but you can use any damn scaler which is having an endo mode in it, and you can buy the tips and start using them. Let me show you a video about a post removal. Now when we are removing a metallic post versus when we are removing a fiber post, the steps are different. So with a metal post, what we do is, this is my post, all I need to do is I need to use an ultrasonic tip without water. I would just go around the post and keep on removing the bonding or the luting cement which is there or whatever adhesive was used, and sometimes it just on lateral side of the post, if I get a catch, the post pops out in no time. So let's have a look. So over here my post is dancing. This is a ultrasonic tip without any diamond coating, and all I did was I just found a good catch and I applied ultrasonic vibrations and the post just pops out. Sometimes the post might be very difficult to pull out and it would not be this easy, and it would not take this less time, but it's more conservative and we have a lot of control in our hand. So let me just show you another case. I want to share one small case. Now, this was a case which was referred to me by a female colleague in my same city, and heads up, she told me it's a case of a lawyer. And whenever a lawyer is involved, boom, I am super, alert. So I would be like, boss, isko theek karna hai. Because whatever it is, I do not want to get on the wrong side of lawyers. So anyways, now this patient had a history of some sort of aesthetic correction, smile designing about a decade back, 10 years back. So you can see some composites on the anteriors. Now, I'll come back to this picture later, but I want to show you the pre-op. Now, if you see the pre-op, I was stunned because there was no root canal. There was just a screw post which was inserted inside the tooth just to take some anchorage, and a composite buildup was done over that. Now, because I do not use any screw post in my inventory, there is no unit to unlock it. So I had to rely upon ultrasonics because I know that so much of aggressive post screwing has been done. Now, if I want to save this tooth, I would have to be patient. This particular screw post I removed with the help of ultrasonics, and it took a lot of time, but we could do a decent job. If you look at the post-op, you would be able to realize that we could remove the screw post with minimal dentine loss, and then I replaced that area, I utilized that area again by using a fiber post in its place, so that we had to take some anchorage. And because for 10 years there was no endo, there was wide apex, there was so much of periapical pathology that I had to go for an MTA plug in this particular case. Let's go back to the previous slide. So what I did in this case is, because the patient was having her hearings in the code, I did not remove the buccal aspect. Only from the palatal side I took access, and I started removing the cement which was around that particular post. It took me some time, it took me good 45 minutes, but I could remove the screw post, it was out, and we could do some justice. This is the workflow. This was the cemented screw, then I removed it. There is some cement still remaining inside the canal, we cleared it. Then in the middle picture you can see an MTA plug was given. On top of it, for 1 or 2 millimeters, I gave a layer of thermoplasticized GP just to fill up that space, and then we went ahead with a fiber post and SDR flowable composite. And then I handed over my patient to the referring dentist. I always make a point that after my endo, we refer the patient to the referring dentist back. And this is the screw post, how it looked. For 10 years, the patient was having this. This is how it looked under the microscope. You can see the open apex there. You can see after removal of the post, there was some of the cements which were lying, and we had to clean them with ultrasonics. MTA plug, moist cotton, and then thermoplasticized GP. And from here to here, this patient had an anterior open bite. The prosthetic work was done by the colleague who had referred, and we had a happy lawyer patient. I emphasize lawyer patient because trust me, now I know where to go if I have any trouble in future. Let me show you a video demonstration about access cavity preparation in a mandibular molar. Now this is a tooth which I have just done for demo purpose, and if you understand the landmarks, this is the central point from which we would be gaining access. This is my mesiobuccal cusp, my mesiolingual cusp, and my distal cusp over here. So what I would be doing is, I would take my round burr, or I could take an endo-access burr, and I would be going and taking the first penetration from the central point. If your tooth is having caries, then it would be a caries driven access, but in standard cases, this is where I would be going. Over here where my pointer is right now, underneath that space, I would be finding my distal canal, and my outline would be either rectangular or a little bit of trapezoidal outline for the mandibular molar. So here I took the first ditch and I go inside. Now what I do during my access preparations is, I do not go full depth in one go. What I do instead is, I know that my mesiobuccal would be located at a certain point and distal at a certain point. What I do is, I keep on joining the dots. So I would keep on going from one corner to the other where I want my outline to be, and simultaneously I would keep on going down. And then I would be able to remove the roof, do the de-roofing, it would get lifted up like a lid. Simple. So trust me, one more tip, de-roofing very, very important, because I do a lot of referred practice and we get a lot of retreatment cases, and I see that root canal hua hua hai, but de-roofing is not done. So you remove that roof, and below that there would be a lot of tissue tags, there would be a lot of pulpal tissue, right? And then simultaneously irrigate. For irrigation, sodium hypochlorite is still the gold standard. Do not keep on using only your normal saline, because it just does mechanical flushing. And what am I doing over here? I am using my ultrasonic tip. I just switched off the water of the ultrasonic tip, and I am doing the final refinement of the walls, removing the overhangs and cleaning the isthmus area with ultrasonic tips. So that gives me a lot of control, because if I would do the same thing with my handpiece and burr, it would be too aggressive. And these days all we talk about is conservative dentistry. We want more conservation of dentine structure, right? So this is where you should have your conservative approach. And see, this is my ultrasonic tip, and I am trying to trough the corners, and I am trying to remove all the irregularities in the wall. And why am I doing that? I am doing that because I do not want my instruments to get stuck on to the walls when I am doing the instrumentation and shaping. So I want that chances of separation or breakage of files should also be minimized. And this tooth had a middle mesial also, and I could find and instrument and shape 5 canals in this particular tooth. Another tip, coronal flaring. How many of you do endo? Raise your hands. Okay, great. So if you're doing endo, after access cavity preparation, in my opinion, there is no need to take that K file and start exploring and going till the working length. Us time, our canals are super thin and tight. Instead, what I do is, my access prep is done. All I would do is, I'll take a coronal flaring file and I would shape the coronal third. So once you have widened the coronal third, now you irrigate, you use your sodium hypochlorite, and at this point you would take your 8 or 10 number K file and then introduce it inside the canal. And you would see that you are having a safe procedure, and at the same time you save some time also. So another tip, coronal flaring, very important. And why is it important? Because it leads to safe progression of files inside the canals. And at the same time, it also helps in elimination of interferences which my instrument might come across. So one such file which I use, but there is no hard and fast rule. If you are comfortable with any other pre-flaring file, go ahead. For instance, I am using the one flare from Micromega. it has a cross section of 2509. So imagine, it is a very great balance of widening, but at the same time we conserve a lot of pericervical dentine. So that is why I use one flare. It has a 17 millimeter long length and the cutting distance is around 13 millimeter. And till what length to pre-flare? So there, like, you know, during my workshops, I'll go from here on 30th, I'm having a workshop at my center. So the first question a beginner asks, ma'am, till where should I pre-flare? Very simple. From your coronal orifice, your coronal third would be around 4 millimeters, plus or minus 1 millimeter, right? So, and from the occlusal level, it would be the height of your crown of your molar up till the CJ is around 9 to 10 millimeters. So 9 to 10 millimeters plus those 4 millimeters. So your rubber stopper sets at the cuspal height. From there, if you are shaping up till 13 or 14 millimeters, it's okay, right? So this is how much we pre-flare. Another very important thing, because I see a lot of students also here in the audience, you know, when you're shaping, whether you're using hand instruments or you're using rotary instruments, go for anti-curvature filing. So what is anti-curvature filing? When we are applying the strokes which are away and outside. So we are trying to preserve the danger zone, which is the inner side of the root canal. So this on the left hand side, if you see, is an unprepared root, and you can see the bulky part is the outside part and the inner side of the root is very slender. So if I shape at the expense of the inner side, I would further thin out the canal, and chances of a perforation, of stripping, of furcal involvement is higher. So a very simple tip, always go for anti-curvature filing. So different diagrams all saying the same story, try to preserve the danger zone and shape at the expense of the bulky or the soft, the safe area. And once your coronal third is prepared, you inserted your K file till the working length, you took the working length determination, and then you make sure that your 10 number file is smooth and loose in the canal. After this, what you have to do is you create a smooth glide path. Once you have created that smooth gliding tunnel inside the canal, then you can use any file system, any rotary file, with heavy chances that you would not break it inside the canal. But yes, do not keep on overusing your file systems again and again, because in India we do that. So you have to create a good glide path, and for that there are a lot of files in the market. For instance, like a 1G file, or it could be like any other file from different companies. Or I could give you another tip and trick, which is using a gyromatic handpiece called a K400. Now what is a K400? It is simply a handpiece which you attach to your micromotor, and then you can attach your simple K files or reamers on it, and then it becomes a motorized file. So if you want, if you're a beginner, you do not want to invest in endomotors, etc. right away, or you are a seasoned practitioner and you're dealing with a lot of difficult cases where you want to create a glide path, you can use a K400, simply attach your 10, 15, 20 number file onto that handpiece, and then you could do the shaping. Now, why this and why not with hands? Because with your hands, you can be very aggressive, and it's like a 360-degree movement. But with a gyromatic handpiece, it has a set rotation of 30-degree clockwise, 30-degree counterclockwise. So it's clockwise, counterclockwise, and 30 degrees how much? It's like little teasing movement inside the canal. As simple as that. So let me show you a case video. Can I have the audio, please? I'll go back because the music is also too good. Now this is a case of tooth number 14, in which one of the canal was very difficult to navigate. So all I did was I prepared a glide path of that particular canal with the help of K400, and then I could do whatever I want. So this canal was straight and very easy to find, but the palatal canal of that particular tooth, I got stuck at the apical third, and then I had to bend and navigate, and I had to scout a little bit. And I could find the canal, but the curvature was too risky. So once I found the canal, what I decided was, okay, henceforth I would introduce the file with the help of K400. And with the help of K400, I could have a more controlled motion, and I was using it at a smaller speed, and I could navigate both. Ultimately, later on the canal straightened out, and we did ultrasonic activation with Endo Ultra in this particular case, and this is how it looked under my microscope. The technique of obturation was warm vertical compaction with the help of EQV. And one more thing about radiographs. See over here, it looks like an apical delta which was formed on the angulated radiograph. I shifted the view and I could see that the angles were changing, which means that it was not a periapical flow, it was not an overflow, but it was indeed an apical delta. So always read your radiographs well. That is very important. One more. I hope the claps was to appreciate and not to say go, you are running out of time. So I have only one or two tips more, because I'm happy that the clapping was not to shoo me away. So always recapitulate. Yes, you have a heavy practice, you have 5 patients waiting in your practice, and ab to fatafat karna hai. And jab fatafat karna hai, what do? We rush. And we want to squeeze our treatment, we want to reduce the treatment time, right? So where do we reduce the time? We start shaping and filing very hastily, and that is where the problems arise. So we have done the shaping, and now I want to obturate, and my working length was 20 millimeter, and now my working length is 18 millimeter. What happened? Because I was not recapitulating. And what is recapitulation? Recapitulation is nothing. You have to go back to one size smaller file again and again to maintain the patency of the canal till the correct working length. So what we are doing is, I shaped till 15 number, I'll go back to 10 number. Again, introduce my 10 number till the working length and then proceed forward. So that is recapitulation. Very simple stuff. Some people will go out and say, oh, very basic lecture did not tell me anything. The idea of a successful root canal treatment, trust me, is in the basics. You make your basics correct, the advance will come automatically to you. So that is recapitulation. It helps in maintaining the patency, it helps in effective debridement, it helps in prevention of ledge formation, and it helps in effective obturation till the proper working length. And I have total 11 tips. I am at tip number 10. According to me, this is one of the most important tip I would like to give about splits. Now, how many of you actually love endo and have been doing premolars and you get a 1-2 anatomy or like splits? Some of them would be there, right? So, sir, you must be finding it sometimes tricky that when I'm shaping those canals, somehow we are able to shape it. But then when we are trying to obturate, it goes in one canal with ease, but in the other one, it just does not go, right? So with hit and trial, I developed this technique, which is, I find it very effective. What I do is, because see, our files are metallic, so they are stiff. So somehow in the split, the files would go easily. But the gutta percha material being soft, it bends and it does not go. So out of the 2 splits, all the time, One split is very easy and straightforward, but the other one we have to negotiate, right? So what I do usually is, once my shaping is complete, I take a paper point and I block the easy canal with the paper point. Now the only way available for my material to go is the difficult one, the other split. So now I would take a master cone, coat it with the sealer, or whichever technique you have. If you're doing a bioceramic, you inject the bioceramic in that split and then put the master cone, confirming with the radiograph. Now the difficult split is obturated, is having the master cone in place. Now you replace the paper point, you pull out the paper point and replace that split with a cone with sealer, and done. Now you can proceed in whichever way you want. So a very simple trick, but I find it very easy. So I did this case also with the same technique, another tooth number 4-4 with 1-2 anatomy. We could fill a lateral also here, and it was because we did a lot of ultrasonic activation and relied upon proper irrigating solutions in correct sequence. These were the workhorses I used. We have less time. Oh, I want to show you this case, and why I'll tell you. I was lecturing in Delhi, and Delhi is my Maika. My parents live there. And after the lecture, I was packing my bags, and boom, my father fractured a tooth, and he was having a long span bridge. So I had to, seek permission, request a friend, open up a clinic, and what we found was tooth number, 3-4 had fractured. But along with that, there was a long span bridge which had cracked, and below this, there was this taurodont tooth, second premolar. Now, boss, this was a nightmare for me because already the crown prep was done. The tooth was the crown structure was small. I wanted to preserve the crown as much as possible, the coronal part of the tooth. Crown we had sacrificed, we were going for a new prosthesis. But I had one thing in mind, that I have to do as conservative endo for this tooth. But the next split over here, it was a nightmare to negotiate. So what I did was, I used the paper point method which I just explained, and I did a very conservative preparation, and I used bioceramic sealer and a single cone technique for this particular case. And this is me. And after this case, the remark I get from my father is, do you take so much of time for each and every patient of yours? Because I had to keep my mouth open for so long, because I worked with rubber dam in each and every case, and he had to be cooperative. But we could actually get away with skinny preparations, and then I referred the patient to another doctor in Delhi, and I caught my flight and went back. Similar, another 1-2 anatomy, same funda applied. This was a caries driven axis. I tried to be as conservative in this case as possible. And when we are talking about endo, I think irrigation is the boss. What we clean is very important. So you clean the root canal system thoroughly, because now we have a lot of micro CT images, but otherwise also there are so many researchers who have given us this knowledge that it is not a root canal, but it's a root canal system. So when you start looking at your canals as root canal systems, you would understand that it's not only 1, 2, 3 or 4 canal. It could be having isthmus, laterals, delta, loops, etc. So similarly, these are the images by Dr. Marco Versiani, who has given us so much of valuable knowledge about the intricate root canal system anatomy which could be there. So clinically, let us correlate. See this, there is a mid-root lateral in the distal, in the mesial canal, distal canal, and there are so many laterals here. Similarly, there could be a C-shaped anatomy. If it is a C-shaped tooth, you have to pay attention to irrigation. For your organic debris, I would like to use sodium hypochlorite concentrated. For my inorganic debris, I would like to use 17% EDTA solution. Or it could be a premolar with so many laterals. So we understand that there could be accessible or inaccessible spaces inside the root canal system. So you have to develop an irrigation protocol which is predictable and nice. So 35% of the canal inside may not be touched with the file. So you rely upon your irrigating system and then you activate. And when we talk about ultrasonics, you would realize that, you know, with ultrasonics there is a lot of acoustic streaming and microbubbling which is happening, and that is why it leads to a good. I would like to take an opportunity to invite you all to this fabulous congress which is going to be held in Athens, Greece on 28th and 29th of September. You could take this opportunity to explore the wonderful country Greece and the city Athens, and at the same time the good part is that it is a combined endo-resto congress. Dr. Nikam, could you take a picture here? Yeah. So definitely from, and stalwarts like from Dr. Steve Buchanan to Filippo Cardinali to Fabio Gorni, you name those people and they are going to be there at this particular congress. So oh my God, my laptop just now. Okay. So ये इसके ऊपर से खसक गया ना, मैंने तो बोला ही था इसको हटा दो, नहीं क्या टूट गया। एक बार लगा दो लास्ट 2 स्लाइड्स में से, पहले भी बोला था मैंने इसके ऊपर। Imagine your MacBook falling off from the dais. I got saved. So these are my social media handles, or you could email me. I have my workshops by the name of Endologics, and this is my Style Italiano Endodontic family. Along with them, we do a lot of knowledge sharing on social media also. Thank you so much for a patient hearing. It's okay. Actually, वो laptop के ऊपर रखा था ना, just creating problem. Slide कर.
Thank you so much, ma'am, for such a wonderful session. Now I would like to invite Dr. Abraham Johnson, sir. He is an assistant professor, School of Medico-Legal Studies, National Forensic Sciences University, Ministry of Home Affairs, Government of India, Gujarat. I would like to invite you, sir.
Hello. 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 One. Am I audible? Hello. Yeah. Okay. So, very good afternoon to one and all. It's indeed a privilege and honor to be here for this 12th World Dental Science and Oral Health Conference. Firstly, I would like to congratulate all the fellows and thank you. I would like to thank Dr. Anmol Bagaria and her team for organizing this wonderful conference. Now, I won't take much of the time, but I'll be taking you through a different journey. I'm not a clinician, but a forensic dentist. You might be taught about forensic dentistry in your UG or maybe in PG. So I'll be taking you through a journey in forensics. So I come from the land of Gujarat. Greetings from the National Forensic Science University. We come directly under the Ministry of Home Affairs, central part. This is the laboratory where I practice. We do a lot of academic work. We do a lot of training. Specifically, we are into the caseworks. So when we talk about forensic dentistry, it's nothing new in the concept, but it's the branch of that dentistry that leads to the investigation. We are actually helping the law enforcement agencies. We work with the judicial officers, we work with police, and we try to investigate the case. Now, as a dentist, right from our first year of BDS, we are taught about basics of dentistry, basics of dental anatomy, and yes, teeth is very unique in nature in terms of its robust appearance. We have done a lot of work in understanding its uniqueness. Teeth as such is very resistant in nature. It is resistant when we talk about mechanically, chemically, biologically. These are the photographs what we have taken after the due experimental work what we have done. We have exposed it to different types of acidic environment as well as the fire cases. So right from our anatomy to histology, also incorporating the radiology, dentists play a major important role in investigation through dentistry. Now the first mode of investigation, whenever a law enforcement officer or the investigating officer goes to the scene of incident, this is the first mode of identification, what he does. He just looks here and there and tries for visual identification. And we are fortunate enough to see different types of human remains when we talk about mass disaster, Mangalore plane air crash, WTC World Trade Attack Center, and Uttarakhand flood, right from mutilated bodies to skeletonized bodies. Craniofacial structure play an important role. And yes, the first thing what we do is documentation. Documentation through photography, documentation through sketching, documentation through writing notes. After due documentation, we do the detailed biological profiling based upon the requisition received from the IOs. So either it is determining the sex or understanding the age of the person, ancestry, stature, DNA, so on. Now, as I said, the investigating officer is the first one who goes to the scene of incident and goes for visual identification. But we are fortunate as a dentist community, or else I would say the dental community, because the highest body in the law enforcement agency, that is Interpol, has identified the role of dentists in investigation. So that is the reason dental structures are considered as primary identifiers. I was one of the Indian representative to participate for the DVI workshop or DVI conference at Singapore in the Interpol, and where they have clearly narrated that fingerprints, DNA and dental plays a major important role. So we have touched, we have utilized dental structures right from our first year of UG. But today I'll be taking you through a different journey that is called digital forensic dentistry. When we talk about basic research practices as a UG student or a PG student, this is what we do. We try to understand the dental structure, read certain papers and derive our, I would say, get our equations done. But when we talk about advanced research practices, when from the forensic perspective, we are understanding the facial recognition part, the facial morphology, the taphonomical part. These days, everyone wants to upgrade themselves in every sector. When we talk about oral medicine, radiology, oral pathology, we are talking about next level of dentistry. We are talking about robotic surgeries in our medicine practices. We are talking about the 3D prosthetics in our prosto or the orthotics. We are talking about the artificial intelligence in the radiology department. And so we do also promote digital dentistry in forensics through new practices, that is incorporating 3D technology, or when we talk about machine learning, artificial intelligence. Now, why do we need digital concepts in forensics? We should be happy with our conventional technology. No. These days, even the law enforcement agency wants quick, rapid results. Because yes, as one Dr. Garima mentioned about, she was scared when she had to do the treatment of a lawyer. And this is what we normally do. We go to the courts and we have to submit our reports to the judicial officers. So it should be quick in nature, better in accuracy, ease of sharing. When we talk about better in quality, they are related to scientific evaluation. When we talk about world as such, be it in UK, US, Australia, any kind of well-developed countries or even developing countries, when I participated as an Indian representative to the Interpol meeting, we had a delegation from Nepal, we had a delegation from Sri Lanka, we had a delegation from Bangladesh who talked about the digitization aspect of forensic odontology. And yes, I was being invited to participate at the Visual Technology Research Group. It is one of the forensic network of UK, and we discussed about our practices, what we do in our country, in our university. So when we talk about forensic dentistry or digital forensic dentistry, the first mode of, I would say, the methodology is comparative dental identification. You are comparing something. You are comparing with the antemortem records. But yes, we do have Some challenges. At times we don't maintain our dental records. We make a lot of fake records, right? So at that time we go for reconstructive identification when we don't have records, when we don't have a solid scientific records. We are in a position to estimate the age, gender, race and other traits through dental structures. Forensic dental assessment is one of a major tool in India. What we do a lot of cases for Sports Authority of India, for different bodies in understanding the age. And age is an important parameter for civil criminal cases. And as a dentist, we have always done a clinical assessment, when specifically in the pedo department. So clinically, we have understood the age, radiologically, histologically, we have done. And when we talk about the advanced practices, when we talk about the new technologies we use, OPGs, we use CBCTs, we are using the CT scanning technology to understand the age through different radiological techniques. The second parameter for investigation or for identification is determining the sex of an individual, which is an important parameter. The reason is when we give a statement to the police officer that Sahab, the dental remains or the remains belongs to male, their 50% of their work is reduced. Instead of searching both the male and female records, they are now just searching the male records. So we are actually helping the agencies. So yes, we know right from our first year, we are taught about the anatomy, the dental anatomy, and yes, we are in a position to identify accurately up to 75% with the help of the teeth itself. And when we talk about the craniofacial structure, the bones, it's 95%. We do a lot of studies in terms of not only morphologically, we understand radiologically from the ortho perspective also. We have digitized the specimen in understanding through the CT analysis or through the radiological analysis when comparing it to the morphological. As I said, today I'll be talking you from a different perspective, not from a clinical perspective. Now this is one of the major area for forensic dentistry, I would say. This is very fascinating to the press media. It clearly catches it comes in the newspaper that yes, there is a bite mark normally involved in sexual assault cases. Bite marks are found in even domestic violence cases. We see different kinds of bite marks. We have seen not only human bite marks, we also analyze animal bite marks. So bite marks are common in these cases, and as a dentist, when we venture into this area, we are actually helping the judiciary system and the society. There's one such case wherein this was a female lady from outside. She came to Goa for just for vacation, and that's how there were men who attacked that lady and severe bite marks on her body. Through basic digital documentation, photography, we were able to close the case. As I said, it's just not about photography, it's also about radiography. We use our oral medicine principles, that is CBCT, and we are able to do a comparative analysis understanding which animal has bitten. Now, because that's also a crime. Yes, we do a lot of non-invasive technology work in terms of rugoscopy, or I would say the chelioscopy, the lip print analysis, to understand, appreciate the patterns. As I said, advanced imaging is one such area where we work through CBCT, CT analysis, because forensic evidences and human cadavers can be scanned at any period of time. We don't have to open up. And secondly, we can visualize the structures both from outside as well as from the inside. So that is one such methodology where we use CT scanning technology. This we use a surface scanning technology for digitizing the human remains, which is brought to the department. With the help of radiologists, we do a lot of image segmentation because we have a new concept called virtual autopsy. Without cutting open the body, we are in a position to understand the cause and the manner of the death. So where again a forensic dentist can be involved in the entire team. So we do a lot of segmentation of the structures and to appreciate it visually. After 3D scanning, we have ventured into the 3D printing, a digital area. We have printed a single tooth in different manner using different technologies. So that's one specific case for which we had utilized CT scanning technology. We have printed it and then utilized for the biological profiling. As you understand, for forensic cases are very crucial in nature. We can't play with that structure. So we create a lot of copies to understand, to analyze. We have prepared different models for visualization, both from the 3D imaging perspective and 3D printing perspective, from the skull, from the face, from the palm. And later we utilize it for the analysis, doing a lot of digital analysis in terms of linear measurement, circumferential measurement, surface contour, and so on. Now, one of the major challenges in forensics is we get a lot of fragmented cases, specifically when we talk about disasters, when we talk about when the evidence are being smashed so that the identity is not being revealed. So the conventionally what the forensic scientists or the forensic medical experts they used to do, they used to use cyanoacrylates or adhesives to join the specimen, which at times creates a problem for biological analysis when we talk about DNA. So we came up with a concept called reconstructive forensics, and we digitize each and every small fragments and utilize the method what we have been learned in CAD/CAM technology or through prosthodontics. We utilize the 3D technologies to reconstruct the specimen. So we have reconstructed the broken tooth, the mandible, the skeletal structures, and later we utilize all these structures for the forensic profiling part. And yes, we have received, as an academician, we make sure that whatever we are submitting to the court, it's valid scientifically. So we do a lot of experimental work first and then publish the data. Now again, when we talk about forensic superimposition, now this skull is my own replica. I got myself CT scan and then prepared the 3D printed replica. Just to understand whether the forensic superimposition can be utilized or not in forensic investigation, because for the very first time in UK in 1954, the forensic superimposition was taken up. And very recently, when we talk about in Maharashtra, the Shinabura case, there again the forensic superimposition was taken up, but the judiciary officers had challenged the technique. When we talk about the next technique, apart from forensic superimposition, we do a lot of forensic reconstruction work. I would say we get a case every month to 3 months. Recently, we have completed a case from Delhi Police and one from Gujarat Police. I'll be showcasing that specific case. So again, I would like to say that whatever we are giving to the judicial officers or to the legal fraternity, it has to be very, very scientific in nature. Otherwise, we are again questioned. Now, when we talk about the digitization of forensic practices, now we were the first one not only to venture into 3D forensics, but we have developed a specific app mainly on virtual reality. Now, as young minds, we like new inventions, new innovative works. So we came up with a new tool that's that's a forensic software mainly we have designed for the police officers so that they can get themselves trained in forensic dentistry with the basic understanding of human bones and the body. So they don't have to visit the crime scene or the scene of incident on a regular basis. That's how we can preserve the scene and we can promote the teaching and training in best possible manner. So one such case I would talk. The first case which was referred to us for reconstructive forensic was long back in 2018, where a police officer had brutally killed his own wife. And because there were a lot of skeletal and dental sample, got a call from the Joint Director State Forensic Science Lab that, doctor, there is some skeletal remains as well as dental remain. Can you help? I said, yes, let me come to the scene of incident. We did certain morphological examination, we did the radiological examination, and there for the very first time we digitized every specimen, created, reconstructed the tooth and did the profiling, and we were in a position to identify the gender, or I would say the sex of the specimen, a major breakthrough in that specific case. Second such case which was referred to us from Maharashtra, a decomposed body, and there they wanted to identify who the person is. So as I said, when we talk about forensic odontologists, we are in a better position to say who the person is, Mr. XYZ. So we did the proper maceration of the specimen, we did the digitization of the specimen both in the imaging format as well as the printing format, and then we did the 3D facial superimposition, and we were in a position to identify who the person is, and through a positive identification. So that's how one more case was closed. This case was referred to us from the eastern part of India, that's Tripura, where from the scene of incident they recovered a denture. Now again, when we talk about the denture, we always think from a clinical perspective, but when it was given to us for investigation, we had to inform who kiska denture hai, whether the person is male or female, what would be the tentative age. Based upon our knowledge and expertise from the prosto part, we first digitized the specimen, and then we were able to provide the report to the director. We were in a position to identify, yes, the denture belonged to male based upon these criteria. This was a very recent case referred from the investigation agency, as you know, the Intelligence Bureau. So they were suspecting of one such terrorist. So this kind of an image we received. So again, how can a forensic dentist help? We know the facial structure in a best possible manner. So we did the image enhancement. We did a lot of forensic facial reconstruction through 2D sketching part. And when we released this specific image, it was identified by the Intelligence Bureau people. I'm not able to. Thanks. Okay. This is the last case which was referred just a month back from Gujarat itself, from Gujarat police. They identified a skull and a mandible, and it was referred to us. We did the entire digital documentation, we printed, and we were able to create the face based upon the inputs received from the IO. The face was prepared, and yes, that led to a proper identification. So when we talk about the good part of forensic dentistry, there are some challenges in digitalization part also. The first part is the financial cost. Now when we talk about CBCT, when we talk about CT analysis, when we talk about 3D softwares, every technology has some kind of cost involved. So a lot of financial costs are being involved. At the same time, there is some kind of temporary loss of productivity. The reason is because we get ourselves, we try to learn that technology, we try to understand, we give more time. So it's like that, it's like better to go for a conventional way rather to work on the digital manner. So there is some kind of temporary loss of productivity, and yes, because when we are sharing some kind of digital data to the offices, there is always chances of privacy and security concern. So again, with this I would like to conclude by saying the digital forensic odontologist, or I would say digital forensic dentist, are competent enough because they have amount of knowledge in terms of craniofacial structures. They are truthful, they do a lot of scientific evaluation, scientific analysis, and yes, as a dentist we have a keen observation. Whenever we talk to people, the first thing what we do is we look at their dentition. Okay, whether there is some kind of spacing, whether it is well aligned or not. So we have a lot of observational skill, and we work on some kind of instrumentation to develop our analytical skills. Communication is one such medium, an important parameter for a forensic expert because they have a lot of conversation with the local officers of their jurisdiction. And yes, innovation. Innovation is important. You cannot hold with your conventional theories, conventional techniques. So with this, I would like to conclude and by saying digital technologies could revolutionize and reshape the forensic world with appropriate knowledge and utilization of digital techniques. Innovative approaches can be implemented for specific identification in any kind of forensic cases. Thank you for patience listening, and I'm open for any such questions. Thank you.
Thank you, sir, for wonderful presentation. Before proceed to the next lecture, I would like to invite Dr. Anmol Bagaria ma'am, Dr. Ashish Chandra sir, Dr. Pankaj Patel sir, Dr. Ruchi Patel ma'am on the stage. I would like to invite Dr. Abraham Johnson sir for felicitation. Thank you, sir. I would like to invite Dr. Neha Navid ma'am for felicitation. Thank you, ma'am. I would like to invite Dr. Piyush Shivhare sir for felicitation. Thank you so much, sir. Now I would like to invite Dr. Divij Kular sir for felicitation. Thank you, sir. Thank you, sir. Thank you, ma'am. And I request all the delegates, if they want to go for high tea, they can. So. So we are now again start with the next lecture. I would like to invite Dr. Jasneet Kalra sir. He is an eminent prosthodontist and implantologist. Welcome you, sir.
check. Yeah. So we have passed a lovely afternoon now. A very good evening, everyone. I wholeheartedly thank Cynodent and PFA for all the fellows. Myself, I'm Dr. Jasneet Singh Kalra. I will be speaking on my favorite topic, for which I even held a workshop yesterday, which would be predictability on guided bone regeneration. So I hail from the capital city, and this is what we generally do in our practice. So I've been training and mentoring graduates in the field of dental implantology, and it's been almost 4 to 5 years I've been doing that. I travel abroad and pan-India for all the implant courses and workshops. Basically, I talk more on implant prosthetics being a prosthodontist. Most of the surgeries are done by myself. It's a wake-up call before you guys sleep. All right. Yeah. So my name is Dr. Jasneet Singh Kalra. I've done my diplomat from WCOI, Japan. I am indebted to ITS Dental College for whatever prosthodontic skill I have today. I'm key opinion leader with several implant companies. I've been extensively trained for hard and soft tissue grafting by Guy Slick, consultant with many dental clinics in and around NCR, and I'm the premium owner of 2 dental setup, which is in New Delhi. So I'll be covering my topic under the following contents. Let us start. So what do we want? We all are living in this perfect world with all the perfect things around us, and we want a perfect or an easy, I would say an ideal patient coming to us. Ideal cases like these, wherein we have a 3/6 missing tooth, and with that what we look for? We look for rehab, because implant is one thing we talk about today, correct? So just almost 2 minutes back I was sitting with Dr. Krishna. We were talking about if someone says re-implantation, gone are those days we talk about natural tooth. We talk only and only about implants. So seeing a edentulous single site, I would always plan go ahead and do my osteotomy, open up a regular flap, osteodensification, further on place my implant. I usually submerge my implant by 0.5 to 1 millimeters so that whatever remodeling needs to be taken place, and further on my closure. Prosthetics, in prosthetics we generally don't use gingival formers or healing abutments. We customize or move our soft tissue as much as possible. Post that, impressions, open tray, I'm a very old school thought. Either I do digital today, which is with the help of scan bodies, or otherwise I go with open tray transfers most of the time. And finally the processes. Isn't it a simple case? Yeah. And by the end, it takes me generally 35 to 40 minutes. I'm minting good 40 to 50K and we all are happy. But the life is not that easy, correct? Whenever we are expecting a mutton or a chicken biryani, this is what we are served in the platter. So what does this mean? What are we served? So cases like these, you move ahead with any kind of osteotomies, you see a buccal dehiscence or fenestration, and you land up, you have to do something, maybe play with the bone, do a regular GBR or any kind of augmentation. Or nowadays I get cases like these. I have got a new terminology in my clinic, which is known as titanium tattoo. So these titanium tattoos are very regular today. We need to see, guys, what are the 3D implant placement today, and accordingly we see these cases has to go down. It is very, very important. Or maybe a rehab like this. See, whenever a patient comes to our setup, they do not just come for an awesome surgical skill. What they need is a replacement of a tooth. And whenever we talk about the replacement of a tooth, cases like these, I would not do implants at all. Rather, I am again, as a old school thought, I would go and give a FDPs, because that saves, give a better purpose rather than giving a prosthesis like these. Or wherein we have external or internal resorption and less of interradicular bone. So we need to manage these cases. So what is the rationale of socket grafting? So as soon as we extract a tooth, we place a graft, we wait for certain amount of time so that we get a decent bone to place our implant. That is a regular case is what I do generally. So bone graft or collagen, which is a combination of graft and type 2, type 3 collagen, is what I generally use in my clinics. So, or maybe the anterior cases. In anterior cases, we know the bundle bone is roughly 0.5 to 1 millimeters. I would do grafting and proceed ahead and do my implant placements. So these are the reasons why we generally do grafting, and these are the regular cases what we see with horizontal and vertical bone losses. Furthermore, first let us start with how do we classify a socket. We generally classify, given by Young and Kim et al., by type 1, 2, 3, 4, wherein 4 wall, 3 wall, 2 wall or single wall defects. So first we have to recognize these effects. So what are these 10 keys to successful aesthetics? So aesthetic risk assessment we need to assess in any of the patients. Either we need to go with a tomographic planning or we go with a CBCT planning. Furthermore, atraumatic tooth extraction, very, very important. I have stopped using elevators in my clinic. Generally what I use are luxators, periotomes or a socket shield technique, which is my atraumatic tooth extraction. A 3D implant placement, your implant should be placed in a perfect 3D implant placement, only then we can expect a better results. So it is not the prosthodontist solely who is dependent on giving the right processes. Even it is a treating surgeon who is placing the implant in the right position, that is very, very important. Narrower versus wider implant, bone gap versus bone graft, facial gingival grafting. Either we do a facial FGG graft or maybe a CT grafting so that we can add on bulk to the soft tissue. We customize the impression coping, and wherever possible, the final restoration should be a screw retained crown so that the access hole is conducive in those cases. So we'll start with the socket shield technique, which is a paradigm shift today. What we do in this technique is very simple. So we generally don't extract the tooth as a whole entity. We split it into two parts. The labio-palatal part, we remove the palatal bone. Now, as soon as I'm removing a palatal bone, so the case becomes a very simple, a socket guided implant placement, and my implant will be completely a 3D implant placement. So in this case, we have split the root into two halves. We will remove the complete palatal root once we have done that, and it will come along with the gutta-perca. Whatever apical pathology is there, we need to remove that with the help of curettage, and we move ahead with our osteotomy side. Densification, and this is the kind of soft tissue what we are looking for. We need a good, healthy, keratinized soft tissue. That is very, very important. And furthermore, my implant placement, which is now 3D implant placement or my socket guided implant placement in the right implant, in the right 3D position. That's my final result. So audience over here, can you tell me, or can you, which kind of crown is this on 2-1? Any idea? Let us show this picture more now. Anyone? Any guesses? Wild guesses we know about crowns. I hope still we have a lot of dentists sitting here now. No, 2-1 is a, 2-1 is a crown, because I'm showing that case. Which kind of crown is it? Is it a PFM or it's an all ceramic crown? Any guesses? Yeah. So basically it's a screw retained PFM crown. I don't straight away go with exorbitant E-maxes and zirconia, which is very popular nowadays. But if we know how to place the right implant under the shoulder, you can take off all the metal hue or the greyish hue which comes in. So that's a regular PFM crown, and it's a screw retained one. It is not a cement retained crown. Okay. So yes, there is a difference between what? A ridge preservation and ridge augmentation. So this is the case which I showed you was ridge preservation. Let us understand how do we augment the bone. The secret is the right planning. We need to have the strategic planning in our cases. What are the certain factors which are dependent on these bone growth? So these are three factors. We need to know the extraction site. We need to know about the bone graft, what all grafts are available in the market, what is conducive in what all cases, and which graft will work best in my case, and the technique. So a little brief about the grafts: auto, allo, DFDBs and FDBs, xenografts and allopras from different origins, right? So generally nowadays what we are using are xenografts, which are either the coralline, bovine or porcine origin grafts. Furthermore, what are the three significance in a bone graft? This is very, very important. So guys, once you are starting, you'll start the practice of guided bone regeneration or grafting, you need to know these three determinants, out of which the most important determinant is osteogenic potential, which Dada once he came into our team and he did that. And that osteogenic potential is generally given by autograft.
Other than that, I need to have any kind of osteoinduction or osteoconduction in my graft. Only then we would have successful cases. Only then we were able to have the World Cup after 1983. All right, so these are the classifications of different grafts and what are the sources and origin of these. So what is the key to predictable socket grafting? Majorly depend upon these 4S or specifically on this PASS principle, which says a primary wound coverage, space maintenance, angiogenesis and stability. All these 4 factors should be in conjunction with your surgery. You will have a better results. So basic socket grafting we have already discussed. I'll skip on to this case and we'll move on. Once we have done a collagen placement, we would wait for at least 10 weeks and then I would find a bone like these. So I would today I would do a immediate implant more, but earlier I used to do a lot of delayed implant placements. So while training any graduate initially for the cases, I would always say do as much as possible delayed implant placement. Because once you have better cases in your lobby, it will always be better for your success. So in this case, straight away implant placement with osteodensification. I use a lot of denser burrs to densify my site and at the same time I get a lot of autografts, plus I'm able to expand by more as much as possible. Further on my prosthetic placement and again a screw retained PFM. Again, I haven't gone with any semen retained Emax or a zirconia prosthesis. When to use collagen membrane? Very, very important. Not all the grafts requires collagen membrane in each and every case. So going back to the same classification, wherein you have any defect other than a 4-wall defect, you need to use a collagen membrane. Whether you are using a rigid non-resorbable membrane or you are using a flexible resorbable membranes. So how to place a membrane? This is how we were taught earlier. We have to tuck in like a bed sheet, pull it and then put it. It is not that simple. Trust me on that. The day you'll handle that membrane, it is so slimy, in that feel, it is not that easy how to stabilize it. There are certain techniques how to stabilize these membranes. Earlier, this is how we used to do it. The entire graft used to go off and then the results was moe, right? We don't want any moe after knowing all the right techniques. Next is little bit about barrier membranes. We need non-resorbable membranes generally when we have a 2-wall defect or maybe a 1-wall defect wherein we need to reconstruct more. But the cases where we have a 3-wall defect, that means there's a single wall missing, I generally go for a collagen membranes. So a case wherein I had a narrow ridge, we opened up a flap, we give a mid-crestal incision with clavicular or maybe any releasing incision, open up a flap. Seeing a good side, you see it's a very narrow ridge, roughly 2 to 3 millimeters. We went ahead, flattened the ridge and started with our osteotomy. We did the implants. The implant, after the implant placement, you can see one of the implant is completely inside the bone, but the gray hue is visible. And another one, we almost have 3 to 4 threads which were exposed. That means we have to cover it up with any kind of graft. So first thing in the grafting, we need to do something known as, we have to decortication. We have to punch in few holes so that we get a mechanical anchorage at our site. So this is how we started. So if you see that rounded pores near to the site of your implant placement, that is decortication. Post that, I would harvest my autograft. There's so many ways how we can harvest our autograft. I'll come on to that. So this is the way by which I've used a Geisslich scraper to shave off the bone, the autogenous bone. And then I've placed it on where my implant was exposed, or this was the first bone which comes in contact with the implant. Post that, we overfill the graft. But the graft should not be compactly packed. If the graft is compactly packed, you will not have better angiogenesis. It should be loosely packed but overdo your graft because resorption is going to be more. Further on, we use membrane tacks to tug up the membrane. So collagen membrane was used, type 3. We just pulled it from buccal to lingual end, and with the help of membrane tacks, we were able to stabilize it. Post that, we covered up the site with resorbable sutures. So what is that principle of GTR? It is very simple. A membrane has 2 sides. One is the rough side, the other one is the smooth side. The smooth side, basically, it helps in fibroblast attachment, and the rough side, it helps in osteoblast attachment. So that's a simple principle. You have to exclude both the cells, the bone forming or the osteoblast cells and the tissue forming the fibroblast cells. These are the 2 sides of the membrane. The smoother side should be towards the tissue, whereas the rough side it should be towards the bone. Coming on to the next clinical case. So again, immediate extraction, implant placement. There was a buccal bone defect, or you can see the buccal bone, it completely fractured in this case. We went ahead, we took the autograft, or we scraped the site, placed the autograft completely onto the site where my implant was exposed, covered it up with xenograft, and then did my membrane stabilization. Here in this case, the suture which I have used is a apically positioned horizontal mattress suture by which we have stabilized the entire membrane. So that is what, if you see the last suture which is placed into the apical side, that is a suture which is holding on to my membrane. If this entire structure can be taken care of, we can predict a better bone formation at least after 4 to 6 months. So a non-resorbable membrane, generally we have these two membranes which are available in the market, DPTFEs and EPTFEs, which are extensive and are dense PTFE membranes. So again, the two sides, the soft side and the hard side, which is my rough side, and in between there is a titanium mesh or foil. Again, a case wherein there was one fold missing the first premolar. Generally we have it in the aesthetic zone, and the female who have a broader smile, you will see up till the mesial side of the first molar comes under the aesthetic zone. So in this case, can you see that buccal dehiscence or a C-shaped curvature? So we need not the prime duty was not only to place an implant and rehabilitate this, but we have to take care of this buccal dehiscence also. If we are not able to do that, we won't do justice to our patient. So we went ahead, did a guided implant surgery just to take a punch hole because it was a very narrow space mesodistally. We did that. Post that, I opened up a full thickness flap, exposed my bone, placed my implant using densification, and installed my implant. Once my implant was placed, can you see that grayish hue? That means it requires some kind of GBR. So we went ahead, did decortication. Post decortication, we have placed the membrane, stabilized, did our grafting, and this was the result. And then we placed the membrane, stabilizing sutures, and we started from there. We ended here almost after 4 to 6 months. Further on, we went on to prosthetic phase. Now if you see in this particular picture, the entire C-shaped deformity was no more. We were able to take care of it just by doing a regular GBR procedure. And that's the final prosthesis. Again, a screw retained PFM. It is not any kind of all ceramic crowns, although we do a lot of all ceramic crowns now. A next case of anterior implant placement, there was a lot of bone loss, vertical as well. You see, according to radiologists, if I could do flattening up to 10 millimeters, only then I would get a flattened bone to place my implant. But then it wouldn't be in a conducive 3D implant placement. We went ahead, we did osteodensification, implant placement, and the threads were exposed. Again, the same regular principle, we have to cover it up with autografts, xenografts, stabilize the membrane, and we were able to complete this case. So what are the autograft harvesting units? Very, very important. It is not about showing the surgery, it is all about you need to know what all instruments are available in the market which would really help you. Out of one which I use generally is my bone scrapers. There are two types of bone scrapers which are available, the plastic or the disposable ones or the metal ones. The metal ones need to be sharpened with Arkansas stone after at least 4 to 5 surgeries. So it's always better you use the disposable ones because those are more sharper. Or the refined drills which are generally used to remove an implant or cut the bone. I use these drills to remove the bone, piezoelectric units or a simple bone rongers. We have bone rongers in our operatories every now and then. So indirect sinus lift. So in these cases, we have so many options how to go ahead with the case. You can use denser burrs, you can use osteotomes, magnetic mallets. I generally use denser burrs to go ahead and do my indirect sinus lifts. After the LA, we opened up a site. There was approximately 5.3 mm of vertical bone height. Then we went ahead, opened up a flap with my guide drill and my Lindemann drill. I was at least short of 1 millimeters. From there on, introduced the denser and I start lifting my site. Post lifting the site, we have placed bone graft. You can see the patency of my bone graft. This is basically any kind of tenting or umbrella effect what you see. That is how you can be sure that your membrane is absolutely patent. Once we have done that, we place our implants. And now this is covered from all the 4 sides with the bone. A second case wherein I'm showing you a video of direct sinus lift, how to do best or how to go about with the direct sinus lift. A video will show you. So in this we generally make a lateral window, and through this lateral window there are specialized curettes. We keep on separating the Schneiderian membrane from the underlying bone, and we keep on pushing it away as much as possible. And then we introduce the bone graft, opening up a full thickness flap. The blade which I generally use in each of my surgeries, it has to be a 15C blade. And then with these diamond drills, we start preparing the lateral window. So once this lateral window has been prepared, we'll move on and we'll intrude the sinus, and we'll start separating the sinus or the Schneiderian membrane. And we have to be very, very gentle once we are using these kind of instruments or curettes. Now you can see with Valsalva, my membrane is absolutely intact. I have a very special way of separating or lifting my membrane. I straight away do not put my bone graft. I use a collagen membrane, which I'll be introducing now, and with the help of that collagen membrane, I'll be separating my Schneiderian membrane completely. First we'll be drilling, keeping our membrane absolutely separate from our drilling sites. And you can use stoppers. If you have to go 2 to 3 millimeters only, you have to be very careful. You cannot puncture the Schneiderian membrane at all. Now with the help of this collagen membrane, I'm lifting my Schneiderian membrane completely. So I use generally 2 membranes, or what I do is first side I use my membrane, place my graft, and then I use collagen onto the top. Like in this case, taking up the bone graft in completely, and then finally I'll cover up the side with the help of collagen. The implants which I have used here is from Dentium. Those are the bright implants which I recently introduced, very active implants. And you can see a good primary stability of approximately 40 to 45 Newton centimeter, which is good enough for immediate immediate loading also. But since it was a complete sinus augmentation, I prefer doing a delayed loading. So in both the implants, we got a very decent initial torque. So after this, whatever window we have created, I'm closing this with the help of collagen instead of using a collagen membrane. So this collagen has got bone graft and type 3 collagen. So we'll completely condense this or push this onto our window, and it will be completely closed. The soft tissue needs some type 2, type 3 collagen. Only then it won't creep inside the hard tissue. And then the sutures. Generally I do layered suturing. I've stopped doing regular interrupted sutures. And finally, a case wherein there was maxillary internal resorption. We went ahead, we did collagen, with implant placement, autozeno, and we closed the site. Again, a case, I'll just show you the prosthetic part of it. The surgical part is absolutely same. We did all the implant placement, and then after 16 weeks of healing, we were able to achieve this kind of emergence profile. So for any, especially in case of 1121 missing, we need a broader emergence profile to get a better results. Post that, we went ahead and did open tear transfer. We went ahead and did the jig trials. Jig trials were absolutely perfect. What we planned here was a good, my titanium customized abutment, and onto the top a Emax crown. But my access hole was again onto the palatal side. So wherever possible, I try placing my implant as palatal as possible to get a conducive screw channel. And that was the final smile of my patient. We started from here. This is with the customized abutment. And we ended here. So it's not only about implant placement. It has to be a better prosthetic result which our patients are looking for. A final case wherein the lower anteriors are generally placed one implant if there is 3141 missing, because the inter-implant distance has to be taken care of. So generally there is a mesial cantilever what we give in those cases. So again, my implant should be at least 3 to 5 millimeters from the CEJ or the plant contour. It has to be between 3 to 5 millimeters. The same concept, first autograft, xenograft and the membrane. And finally, this is my last case, video just to show you how do we do vertical augmentation also using Thorey's technique. So for a predictable guided bone regeneration or any kind of regeneration, you need to know what are the basics and in what case what works. It is not only the GB or the membrane or the graft would work. So in these cases, what we did is we basically harvested the bone shell from the molar side and we have placed it onto our anterior mandibular anterior side. The lingual flap was completely raised so that only then I can have a better closure or approximation. So removing the bone shell from the premolar side. And from the side you have removed the bone shell, it's always better to place a graft and a membrane so that the bone can be regenerated in that area. And the screws by which we are able to stabilize, these are osteosynthetic screws. This is it. So we stabilize the entire bone shell with the help of these screws. And a regular GBR after placing the shells. And you need to use a resorbable sutures in these cases. Thank you so much. Every ending is a new beginning. You can connect with me on social media. Thank you.
Thank you, sir, for such a wonderful session. Now, I would like to invite Dr. Ruchi Patel, ma'am. She is all the way from Kenya, and ma'am, you are such a wonderful personality. Topic for this session is the oral microbiome and its role in systemic disease and sleep medicine.
Testing. Hello? Hi. Hello? Is it on? Okay, great. Hello, everyone. Thank you so much for waiting into the afternoon. I know that after those gulab jamuns, I'm definitely struggling to stay awake, so hopefully I'll keep this a little bit more lighthearted for you. My name is Dr. Ruchi Patel Sahi, and although I am a dentist, like a lot of the amazing restorative clinicians, it's a little bit of an offbeat lecture on what I feel undergraduates miss out in training and what a lot of us as dental practitioners are not giving enough importance to. So we're going to be talking a little bit about the oral microbiome and sleep medicine, which is my speciality. So this is how I thought I'm going to capture your intrigue. This is me after graduating from dental school. Beautiful picture here, and I was not in good health. Borderline diabetic, hormonal issues, you know, as long as you could say, and definitely overweight. And I just didn't feel healthy. And after studying dentistry, as you all know, we're virtually medical practitioners. So how could I be like this and preach health to my patients? I went on to do a degree with the American Academy of Aesthetic Medicine, kind of in a pledge to figure out how I could get healthy. And what I did find, I'm going to talk about in this lecture because it's a very personal journey. I'm here to talk to you about it because I am an outcome of what I've gone through. And I believe to make yourselves authentic practitioners, you need to understand this as well. So let's get started. Some facts. In 2018, Harvard University did this study that came up with 5 healthy habits that could add 12 to 14 years to your life expectancy. No surprises here. Eating healthy, exercising, maintaining a healthy body weight, not smoking, and not drinking too much alcohol. But what a lot of people didn't know was having a healthy mouth can actually increase your life expectancy by up to 10 years, and having a healthy airway can increase your life expectancy by another 15. So hold on a second, what are we saying here? That actually just the development and health of your mouth can actually increase the life expectancy of all those go-to combined. That is a big, big undertaking you as dental professionals have for your patients. So I practice holistic dentistry, and no, it's not alternative dentistry. Holistic dentistry is encompassing total body health. And I know you have great clinicians here in the periodontology department who talk about systemic disease and inflammation, which is what I'm going to talk about today. We have the soft tissue in the mouth and we have the hard tissue. And for the practitioners who focus on hard tissue, fantastic. We need to do that. But I feel so often the soft tissues, or why we got there in the first place, is something that's quite underrated in clinical practice. So we want to look at the root cause, not just how do we replace this missing tooth. Hold on a second. Why does this patient at this age, if it's not something to do with trauma, even have this problem in the first place? Let's put pause on fixing the missing tooth. Let's fix the reason, and you can actually change this patient's life. So when you're in your mother's womb, you're completely sterile. There's no bacteria in and around you. As soon as you're born, down the birth canal, C-section, whatever, you start to accumulate bacteria. What we have found is when you are the adult that you are today, the number of bacteria in and around you outweigh your genes by 360 to 1. So in medicine, when we were only looking at genetics, only looking at family history, why do we get diabetes? Why do we get disease? We were missing a trick because the microbial genome was getting ignored. And there's a group of pioneering biological medics in the US who said, okay, if you're correct, let's forget about genetics for a second. Let's see what happens when we start to play with this microbial genome. And something was born called the gut microbiome. Everybody here probably knows it. Digestion is key. If you've got a good gut, you've got a second brain, all of that. But did dentists know that you have direct access into the beginning of the gut all the way down to the other end, and the oral microbiome can harvest the most amount of pathogens than anywhere in the human body? This is very relevant. So the mouth really is the gateway to your body. As you know,
A healthy mouth can really get you what you need, and there's broken it up into two sections here. One is about the oral microbiome, which is my specialty, but the other one is also my specialty, which is about airway, which is getting the correct amount of oxygen at night when you sleep, and sleep medicine as dentists, which is something that very few dental schools even currently are being taught. So we're going to start by talking about this mouth-body connection, and I do know that a lot of dentists know the basics. We know about a heart condition and perio. We know that it affects diabetes in a bidirectional relationship, but the slightly more unknown things are research that was done shows that people with chronic gum disease have, for more than 10 years, have a 70% higher risk of dementia and Alzheimer's. I'm going to expand on that. Harvard University in PubMed released a paper, 20 years in research, that said dementia and Alzheimer patients had bacteria from the oral microbiome, and they said they had gum disease. So this is now showing we're going a lot deeper. A lot of us don't look at respiratory disease as a link to periodontal issues. Cancers is definitely a huge one, and rheumatoid arthritis. So there has been this flood of scientific data that your oral health does impact your physical health, and it is actually being rewritten as we speak. But let's go back a little bit. As early as the 5th century, you heard from Hippocrates, all disease begins in the gut. Let's look at 1891. A microbiologist named Miller published a paper that says the human mouth is the focus of infection. Obviously, that skyrocketed into the focal infection era. Then in the 1911, an English physician, William Hunter, said oral sepsis as a cause of disease and blamed dentistry for chronic disease. Moving forward, 2011, the United Nations for the first time ever associated oral disease with significant morbidity. This is only the second time ever that it has brought up in a UN summit, the first one being AIDS. So, cardiovascular disease. This is something that as a dentist still shocks me today. The statistics, 50% of heart attacks are triggered by bacteria in the mouth. Does anyone here know someone who's had a heart attack? 50% is triggered by bacteria in the mouth. That is a statistic that is too harrowing to ignore. People with gum disease are 3 times more likely to die from a stroke and twice as likely to die from a heart attack. This is from the Mayo Clinic. We know how, but how much do we screen this with our patients? Diabetes. Diabetes with bleeding gums increases your risk of premature death by 400 to 700%. Not something to be messed with. Of course, we know about the bidirectional relationship where inflammation can exacerbate diabetes, and diabetes is also a root cause. But this is something that I feel a lot of undergraduates probably wouldn't have touched on, which is respiratory infections. Poor oral hygiene can increase the risk of pneumonia and respiratory infections. This is you as a dental practitioner looking into your patient's mouth and giving them a risk factor for diseases that are life-threatening. So let's look here at, in 2021, this was very relevant during the time of COVID, and it suggested that patients with gum disease were actually 9 times more likely to die from COVID-19. And they also found that people with periodontal disease were at least 3 times more likely to be admitted into ICU and 4.5 times more likely to require a ventilator. It's very serious. Rheumatoid arthritis. As we have inflammation in the gums, and this inflammation travels in your arterial blood supply and reaches certain parts of your body, the same inflammation can mean that rheumatoid arthritis has a direct link to periodontal disease. And there was a paper that is studying this link in such a way to say that rheumatoid arthritis can even be treated, prevented, or cured by maintaining the oral microbiome in the first place. This is the research that is happening currently. We also know about issues in pregnancy and gum disease and periodontology, so we know about that. This is something else, cancers. Researchers, again at Harvard, found that people with a history of gum disease actually have a 43% higher risk of esophageal cancer and a 52% higher risk of stomach cancer than people with healthier gums. That is more than half. 52%
are at higher risk. That is a big deal. So I want to put this a little bit in perspective for you. I know you've seen lots of amazing clinicians fixing lots of serious problems. However, if as a dental practitioner, you are not taking the time to fully diagnose the effect of the periodontal, the soft tissues and the periodontal disease with your patients, we are saying that young men under 50 with advanced perio are 2.5 times more likely to die prematurely and 3 times more likely to die from heart disease than those with healthy mouths. So it shouldn't be brush and floss to save your teeth, it should be to save your life. I want to talk about sleeping, which is the second part of my specialty, and it's always about the airway. We all know about yoga, we all know about pranayama. A lot of us understand the power of oxygen, the power of breath, why it's so vital for your organs. But do you know at night when you're sleeping, this is when your body needs the highest level of oxygen, and it needs it in a pattern of sleep that's called uninterrupted sleep. Any form of interruption in your sleep means there's a slight drop in oxygen in your brain. Suddenly your parasympathetic and sympathetic nervous system starts to fire up, and via neurotransmitters it starts to send signals to wake the organs up, so to speak. When this happens, your body goes into overdrive. And what is happening is you are not falling into REM sleep. If you are not falling into REM sleep, then your body is slowly deteriorating. And as we age, we then start to worry, oh, I'm getting older. But 20 years of interrupted sleep means your body has got 20 years of a deficit of oxygen that could have been prevented. And how could it have been prevented? By dental practitioners. You have first access into the airway, and you really need to understand the importance of what you're looking at. So we have so much in life we need to think about. We're not thinking about how we're breathing and why we're breathing. But as you all know, the evolution of the airway starts way before, in utero, even before you're born, and develops at every stage. When it gets compromised, when the development gets compromised, this is where we start to see changes that can actually affect our entire health. I'm going to talk about why it's so important, but if you look at the child's generation, every time you see a malocclusion, a lot of the times you're just seeing a malocclusion. You're not talking about how is this child sleeping. And actually what will come about is the pressures of the soft tissue are actually what determine malocclusion in developing dentition. So if you're not looking at the soft tissue and you're not intervening, then you're not increasing oxygen in these children, and they will be a victim to it. So snoring, gasping for air, these are actual signs of struggling to breathe. These are not the joke that it once was, my partner snores, it's irritating. This is an actual interrupted sleep cycle. So drop in oxygen and excess of neurotransmitters, and it sends everything haywire. So the earlier in life we experience this, the more the negative impact will be later on into our older age. Dentists, you really can help your patients breathe better during sleep. So what we want is this optimal airway. You're looking at wider jaws, the tongue tone, the tongue in the correct position in the mouth. This is what improves nasal breathing. You get proper nitric oxide oxygen exchange, and you get restful sleep. This is the key slide, to be honest. The jaws, the lips and the cheek, the tongue, how you swallow and how you chew at an early age will actually determine how the jaws develop. And if you are not getting ideal development, you are getting malocclusion. A lot of dentists I'm still seeing today are telling children, parents of children, wait until the child is 12. Wait until the child is 12 and come back to me. We'll refer to ortho, we'll create some space, and we'll give you a beautiful dentition. 12 is too late. The jaw is fully formed. What about the incorrect soft tissues that you can correct from the age of 3? What happens when you put the tongue in the correct position? This child starts to breathe better at night. Aside from the behavioral issues which I'll come to, they actually get a chance to develop their jaw effectively and prevent malocclusion in the first place. The World Dental Federation in 2019
actually said this: universities and national dental associations to provide students and dentists with basic knowledge regarding the important role of dentistry in preventing and treating sleep-related breathing disorders, in particular, early detection in children and the prevention of the late onset forms. It is the duty of care of any dentist to actually be screening for sleep-related breathing disorders. I wonder how many dental practices actually have a sleep medicine questionnaire in their waiting room attached. It is a duty of care, and you need to widen your knowledge on this because it is becoming more and more relevant. Research has indicated that 9 out of 10 children have at least one outward symptom of sleep-disordered breathing. As we get older, there's an increased likelihood of breathing through the mouth. Did you know that mouth breathing is a sleep-related breathing disorder, which means literally if you fall asleep and your lips are not closed, you're getting a decrease in oxygen and you're not falling into REM sleep. That's a big problem. People over 40 anyway are 6 times more likely to spend more than 50% of their time sleeping with their mouth open. And mouth breathing makes it 2.5 times more difficult to breathe the correct way. And this is the key. Everyone said, well, how did you do it after you were a dentist? It's an important adjunct to losing weight, for your metabolism, for your neurotransmitters to balance. It is absolutely vital that you sleep effectively. So what do dentists want? What do we want? What do you want as people? You want full-on nasal breathing. We want 24/7 nasal breathing so that we can increase oxygen saturation and you can fall into this REM sleep. So it could, you know, this is what I tell a lot of my parents, but it could even apply to you. Do you or your children snore? Do they grind their teeth? Teeth grinding. Teeth grinding is the biggest underrated, looked at thing, because we tend to just take a beautiful impression and give the patient a night guard, but nobody's questioning why are they doing it in the first place. Stress doesn't cause it, stress exacerbates it. What causes it is the developmental soft tissues that we ignored in our patient, and there is something that actually all of you could be doing about it now. Children, behavioral issues, we'll come to that in a second. Bedwetting, anxiety in children, mental health issues, things like asthma and allergy becoming really big in our child population. Nobody is wondering where this is coming from, but we know it is coming from the fact that they're not getting enough oxygen and they're having a difficulty breathing. No, your child grinding their teeth during sleep is not normal. I hope none of you have ever said that before. And no, they will not grow out of it. Common is not normal. Have any of you had parents who have said, hey, guess what, my child grinds at night, is that okay? And you've said, oh, I'm sure it's okay. Once they're old enough, we'll give them a guard. It's not okay. It is a sign of soft tissue dysfunctionality, and you need to be addressing that. So, how do sleep-related breathing disorders affect behavioral issues? It interrupts the restorative sleep, there's a decrease in oxygen, and then you get poor function of the brain. I say this to all my parents. In 2012, a study was done that showed children with sleep-related breathing disorders were 40 to 100%, that's the category you're looking at, more likely to develop neurobehavioral problems by age 7 compared with children without breathing. So if you are telling parents there's nothing much to do until your child is older, just a routine, little clean, little sit on the chair, you're wrong. There's a lot more that you need to be looking at. The journey starts when the parent or your patient or the child is in the waiting room. How many of you have peeked out of your door and they're like this? Mouth breathing. You need 24/7 nasal breathing. Mouth breathing means you are suffering a sleep-related breathing disorder. That has been categorized. Now, how much you want to do about it, that's going to be up to you. When you're a chronic mouth breather, you start to notice this profile. So a lot of patients say to me, really? This is changing my face? So I don't know if you remember my pictures of, pre my journey. A lot of patients say, well, you don't even look like that. And no, I haven't had the pleasure of meeting the top facial aesthetician in Delhi yet, but I did correct my soft tissue issues. I was a grinder after dental school, and it completely changed my entire profile. So
Children that sleep like this, any of you to have children to come or know any children, take a picture of them. 2:30 a.m. in the midst of their deep sleep cycle. If they're like this child will have a malocclusion. If you can correct that, get them proper tongue position, proper lip seal, you can prevent a malocclusion. This is what this is about. So you can see how the profile changes from a mouth breather to a nose breather. It's not, everybody's beautiful. It's about functionality and health and giving you the correct growth of your jaws so that you experience that good health. So when we mouth breathe, once again, we know we get this kind of setback jaw, smaller airways, crooked nose, higher prevalence of asthma, higher prevalence of allergies. This is because everything is all constricted. When your tongue is not sitting on the roof of your mouth and it drops down, the jaw widens. And so what happens is you get this narrowing of the sinus. And this is where all the problems come from. So again, you could really be preventing this. Mouth breathing is also integral into the oral microbiome. You know that dry mouth causes so many issues with hard tissues, but it also causes so much in terms of inflammation in the mouth. This is what we need. Lips closed, tongue on the roof of the mouth, nasal breathing, day and night. Even during this entire lecture, this is how, no one is opening their mouth now, which is fantastic, but this is what you need to be doing, okay? Even if you're doing this consciously, at this stage in life, you are training your soft tissues. So I just want to connect the dots for you. A study that was published in all WH regions in 2020 said the top 2 reasons that patients go to a dentist is either they're in pain or they want to straighten teeth. Here are some of the things that I think are getting pushed to the side, okay? Bleeding gums, airway obstruction, mouth breathing, sleep disordered breathing, tongue or lip tie, tongue thrust, thumb sucking, nail biting, facial growth, lip incompetence, clenching, grinding, profile speech, dry mouth, bad breath, snoring. Now, I know some of you think, oh, I'm sure my patients talk about a few of these things, but the focus on these things is getting left behind when you're simply focusing on fixing the problem. This is more the root cause, and I urge a lot of you to look for treatment options for things like sleep-related breathing disorders. I myself am a myofunctional therapist. I have been doing it for 15 years. Myofunctional therapy works on increasing the strength of your muscles of your head and neck, and it can be used from birth all the way up into adulthood. When I say from birth, I mean removing pacifiers and giving children hard items to chew on so that you work on the myofunctional effectively, all the way up until adults, where we actually treat sleep apnea clients, which is obviously the more serious end of the spectrum of sleep-related breathing disorders. CPAP machine surgery, change your lifestyle a little bit. Those things are slight, but you need more work with muscles if you are really going to change the development of the structures of the face. So a little poem that I love: in order to smile, you have to feel good. In order to feel good, you need to sleep well. In order to sleep well, you have to breathe well. And in order to breathe well, you have to breathe healthy. And in order to breathe healthy, you have to nasal breathe. I hope that shed a little bit of light on what I do for you. It's too short a time to summarize it in a lot more scientific detail. But, you know, your life really depends on your mouth. And as practitioners of this day and age, really take that a little bit more seriously. Try and understand that you are going to be changing these patients' lives, even medically, even in the future, not just what you're doing with the problem that they walk into your clinic with. Thank you very much. These are some of my details, and thank you for listening on this late afternoon when everyone's super tired already.
Thank you, ma'am, for wonderful session. Now I would like to invite Dr. Neha Navid, ma'am. She is orthodontist, and topic for this session is 10 key orthodontic principles for smile excellence, balancing aesthetic and function.
कॉलर नहीं नहीं माइक play. Check. Good evening, everybody present here today. Let me start by introducing myself to you. I am Dr. Neha Naveed, a consultant orthodontist from Chennai, and it's been a privilege to be here and to be inducted here today. I would like to thank Dr. Anmol and the entire team of 12th World Dental Science and Oral Health Conference for giving me this prestigious platform in KGMU Lucknow and share my insights to all of you. And it's been a pleasure to be inducted as a fellow of PFA also today. And my journey with PFA actually began in 2018 when I was there at the convocation and I was honored with the undergraduate student award. So to be there and to be here as a fellow today, it's been quite a journey and it really does feel nice. And without much ado, I would like to start with the lecture. And the topic for today's lecture is 10 key orthodontic principles for smile excellence, balancing aesthetics and function. So as an orthodontist, I feel that to craft beautiful smiles, it's always an amalgamation of balancing both aesthetics and function. And I have always believed that orthodontics as a specialty, I would call it as the art and science of orthodontics. So it is not just, knowing the science behind what you do, knowing the sound scientific principles, but also you need to know that it's a lot about the aesthetic impact it has, and you need to also have an artistic eye towards whatever you do. They say you cannot treat what you cannot see, right? So it's just not about placing brackets and just moving the teeth, but you need to have an artistic eye, the smile that you aim to achieve, because most of the people who are here, they are coming to you not just for beautiful picture perfect smiles, but also for happy smiles. So it is always a mixture of both aesthetics and function. So to begin with, let's move forward. So what I would like to, so this is one picture of a patient that I had treated, and I find great pride in because this patient was delighted with their smile. And as doctors also, it does seem very satisfying, right? When your treatment that you do has a big transformative impact, it does leave a lasting impression on you as well as your patients. So to achieve such smiles, to gain the excellence in smiles, what are the principles that you need to follow? So when a patient walks to you, it's not just the clinical examination or the radiographic examination that you do. I always also do an aesthetic examination. So this is a very subjective thing, it's not a very objective thing, but still I have jotted down into points what are the things you need to keep in mind when you are doing this aesthetic examination. So the aesthetic examination is nothing but examining your patient's smile. So to break it down, so what is the anatomy of a smile? So when you look at a patient's smile, you have the two components basically, the pink aesthetics, the white aesthetics, that is your check. Yeah, I'll just use this. So I just said that there are two components of a smile, that is your teeth and your gingival scaffold. So the display zone of your smile is draped by your upper and lower lips.
So we are not just moving the teeth to the right position, but also you have a lot of soft tissue determinants in the display zone. So this is dictated by these 4 soft tissue factors: your intercommissural width, the lip thickness, the interlabial gap, the smile index, which is nothing but the ratio of the width of your smile to the height of your smile, and the gingival architecture. So in this lecture, I'm just going to talk about these 10 commandments of smile aesthetics, or in other words, what are the ideal characteristics of a smile, or what should be assessed in a smile. So moving on to the first point, which is the smile arc. The smile arc is nothing but the positions of your maxillary incisors in a vertical position. So this smile arc is defined by the contour of your incisal edges of your maxillary anterior teeth in relation to the curvature of your lower lip during a social smile. So generally, it can be categorized as a convex smile, a straight smile, or a reverse or an inverted smile. So what is actually aesthetic? It is the convex or the consonant smile arc, right? If you see the picture on the right-hand side, the straight smile arc or the inverted or the reverse smile arc doesn't really look very aesthetic, no matter how properly aligned it is. So this smile arc is a very important determinant. So what exactly happens here is the lateral incisor is always going to be 0.5 to 1 mm shorter than that of the central incisor. And this step, it varies between male and female. It's slightly more exaggerated in women than in men. So when, as a practitioner, how do you, modify this, or how do you come to terms with this smile arc? How do you modify it? So in this particular case, you can see the aesthetic impact that it has just in the changes of the vertical positioning of incisors, right? Nothing much was done. The teeth are fairly aligned, but just by altering the smile arc, you can see, like from the first picture to the final picture, it does have an impact, right? And in the current scenario, we do have a lot of digital softwares, for smile designing, which are an additional aid for us. And another tip on how to achieve this, especially with orthodontics, is we have this concept called as the smile arc protection. So this is a concept that we follow at the time of placing the brackets itself. So in the smile arc protection, when we place the central incisor brackets, we place it 1 millimeter more gingival than the canine brackets, and the laterals are somewhere in between. So instead of placing it exactly at the center of each tooth and achieving a straight occlusal plane, when we follow this way, where the central incisors are bonded slightly more gingivally, when the teeth get aligned, you get this proper consonant smile arc, right? So this is the first determinant of achieving an ideal smile. So when I showed the first picture, you can see now each commandment that I talk about, how you can correlate it to the picture that I've shown. This is a consonant smile arc, right? So the second one is the ratio and the symmetry of your central incisors. So there is an ideal height to width ratio. So ideally, it's supposed to be somewhere between 75 to 85%, which means, let's say the height of a central incisor is 10 millimeter. The width would be somewhere around 7.5 to 8.5 millimeter. When this ratio is altered, it gives rise to teeth looking more longer than natural or much shorter than natural. Both are not considered to be very aesthetic. So that is why the role of this ratio is important. And again, it differs, the preferences between male and female, because slightly more wider teeth are accepted by men, but women accept a slightly more longer teeth. And how does this play a role, this ratio? Because it's not just about aligning teeth, it's more about an interdisciplinary approach. If you feel that this ratio has been altered, you need to do adjunctive techniques, such as maybe a crown lengthening, a gingivoplasty, or even a build-up with composite. So to achieve that ideal smile, it's not just about, a single approach, but you need to think of it in a more multidisciplinary way. The third component that I'm talking about is the proportion between the teeth. So nothing that is out of proportion looks appealing, right? Proportion is a very important aspect. And if you've heard of this golden ratio, Anything that exists in nature, may it be a beautiful flower, or may it be, very renowned architectural buildings, or even the painting of Mona Lisa, anything that has been considered to be aesthetic follows this golden ratio or golden proportion. It is the same with our dentition also. So our teeth also follow this golden proportion, where if you see the ratio between each of these teeth that are visible in the display zone, they follow the 0.6:1 ratio, which means your central incisor appears to be 62%, a little more bigger than your lateral incisor. The same with the canine. I don't mean the entire mesiodistal width of canine, but just the display portion, because just the mesial half of canine is there. So even if this ratio is altered, it is going to alter your smile aesthetics. Let me explain it to you with a clinical scenario. So if you see this picture of this patient, you can see that this golden ratio is altered. You can see that the lateral incisor is much smaller in size. So this is not proportionate. So there are two ways that you can correct this. One reason, because of this lateral incisor being shown very minimally, can be because the lateral might be rotated. So by just derotating it, you can achieve this ideal golden ratio. Or it can also be that it's just smaller in size. So in such cases, you need to plan for, a veneer or a build-up, a composite build-up. So when you identify this only at the beginning of treatment, that's when you can plan for it and proceed for it and achieve your treatment goals towards the end of treatment. So just by altering that golden ratio, you can see that this patient has a more proportionate smile. Then again, back to this picture that I showed you, you can see, now you can appreciate that golden ratio being maintained here, right? Right from the central incisor to the canine, it just keeps proportionately varying. So the fourth one, here it's a very simple one, which is the presence of interdental spaces. So this commandment just says that any spaces are deemed to be unaesthetic. Nobody likes spaces between the dentition. And it's not just with it's not just from a dentist perspective, even the lay persons, they identify spaces and it's considered to be unaesthetic. And even according to, the keys of occlusion, the Andrew 6 keys of occlusion, one of the keys is absence of any kind of interdental spaces. So there should be tight contacts between all teeth, and particularly when it's affecting the display zone, that is the anterior teeth, it definitely needs to be corrected. And these are very simple cases which show that just by closure of the interdental spaces, what a great transformative impact it has. There has not been any major mechanics or any, complex treatment, but just by this simple thing, you can see that definitely it improves the aesthetics of the teeth. Now, the next one is the gingival architecture. As I told you in the beginning, we have the pink aesthetics and we have the white aesthetics. There's so much to talk about the white aesthetics as dentists, the proportions and, the position of the teeth, and there's so much. But also, the gingival architecture plays a very important role. So we do know that this terminology called gingival zenith, right? That is the highest point on the contour of every tooth on the gingival margin. So these gingival zeniths need to be leveled at a particular way for it to look aesthetic. So always the lateral incisors gingival margin is going to be 0.5 to 1 mm below that of the canines and that of the central incisors as well. So when this is not, in proper matching level, what do you do then? Like, let's see the picture on the right-hand side. You can see that there's a mismatch in the gingival level, right? Although when you see the incisal edges of the teeth, they are properly aligned. So this, again, is not going to look nice when a patient smiles. So there are different ways you can approach it. Either you can do a gingivoplasty of the lowest incisor and make the gingival levels match. Or you can either do an intrusion of a tooth so that that gingival level moves up and then do a restoration incisally. Or you can just do an extrusion of the longer tooth and do an enameloplasty. So all this differs case to case. So it is a very a case-by-case decision, and there's no hard and fast rule that this is what we need to do. So we need to actually examine and see where the fault lies so that you'll know how you can modify it. So it's not just the gingival levels or the zeniths, but also the amount of gingival exposure, most commonly called as gummy smiles, right? So a lot of patients come for treatment for gummy smiles as well. So Again, the gingival exposure is classified as a high smile, a medium smile, or a low smile, depending on how much gingiva is visible. Ideally, the entire length of your teeth need to be visible with your interdental papilla. So if anything more than that is visible, that's called as a gummy smile or a high smile. And anything lesser than that is called as a low smile. So anything more or less is not good, because when there is a low smile, it gives the perception of an aged appearance, right? It doesn't give a very youthful appearance to the smile. So therefore, we need to maintain this, and there are a lot of different treatments that can be done. As an orthodontist, what I would think of is intrusion of teeth, or maybe a gingivoplasty if the crowns are really small. So we need to again see what the etiology would be. So you can see the list of enumeration that I've done there about the etiology of gummy smile. It can be because of various factors apart from your teeth and gums. It can be because of your lips as well. When you have, an elevated lip curtain, some patients have hypermobility of the lips. So ideally, there is no vertical excess, or there is no short clinical crown height, but it's just because of the smile drape, the lip curtain. So in that cases, you need to again think of your facial aesthetics, such as Botox procedures. Or if there's a very thin lip, you can think of a filler. But again, it's always very important to see the etiology of the gummy smile, to not treat it in a very straightforward way. You need to treat it according to the etiology only. And again, when the reason is a low smile line, you need to again think of elongating the teeth. You need to increase the display of the teeth. The incisal display needs to be complete to give the youthful appearance. The 7th commandment for smile aesthetics are the buccal corridor space. Again, what are the buccal corridors? These are the lateral negative spaces, or the black triangles that you see at the corners of the mouth, at the intercommissurals of the mouth. So again, you have a wide buccal corridor, or you can have a narrow one, or a average intermediate one. So when you notice that there is a wide buccal corridor space, that is actually an indication that the arch can be expanded and patient can benefit and get a nice full toothy smile from it. Generally, the narrow buccal corridors, as you see in the picture, was not generally preferred until very recently, particularly in the US, where people like broad arch forms and they like that complete visibility of molar to molar teeth while smiling. But we stick to the average, where you don't have too much of buccal corridor excessive space. If it's there, then you know that you can expand the patient's dentition. The 8th commandment is about the midlines and tooth angulation. So dividing this into two things. First thing, you look at the midline. One can be the midline shift, or it can be the midline diastema. So the midline diastema, again, is one of the most common reason why people seek orthodontic treatment, because nobody likes a space at the center of their teeth. And there have been a lot of studies that have been done to compare the perception between, orthodontists, between general dentists and lay people regarding smile aesthetics. So any amount of midline diastema was deemed to be very unaesthetic and needs to be corrected. But when it comes to a midline deviation or a midline shift, right, most of the midline shifts were not noticeable by lay people, sometimes noticeable by general dentists and orthodontists. So when the midline shift is just bodily, let's say to the left or to the right of the facial midline, it's not considered a very big aesthetic problem. But if the same midline is angulated, that is easily identified by lay people, and people find it to be very unaesthetic. So from this we know that minimal, 1 to 2 millimeter of midline shift is not a problem, but if there is an angulation, as you can see in the pictures there, the 4 pictures that show you is just a midline shift to the left or to the right, which is not much perceivable. But when you see the midline being angulated, that is slightly, that is immediately noticeable, and that needs to be corrected. Now the second last commandment for smile aesthetic, which is the tooth color and anatomical shape. So a lot of patients, they come to asking for pearly white teeth, that they want white teeth and they want to do bleachings. But most of them don't realize that in a natural dentition, it is okay for the teeth to be slightly yellowish and progressively becomes more darker as the teeth go posteriorly. In the sense, the central incisors are the brightest teeth, the canines are slightly more yellowish, and as you go posteriorly, the teeth become more warmer in hue. So this actually is considered to be very natural and aesthetic because it gives that perception of depth to the smile, rather than if you see patients who have these crowns or veneers which are like white from premolar to premolar, you can see that it gives a very unnatural and artificial look. So that's where you need to, make your patient aware that in the natural dentition, the teeth slightly become yellowish as the teeth go progressively posteriorly. So that was about the tooth color. The anatomical shape, we did see about the golden proportion, we did see about the height-width ratio, but there's another thing that we need to look at is which are the connectors and contacts. So the contacts in the anterior teeth are going to have more surface area and slightly keeps reducing as you go posteriorly. And gingival to this, all the embrasures need to be filled with your interdental papilla. So this is the normal anatomy of the smile, of your contacts and your embrasures. But what happens if these embrasures are not filled by your interdental papilla? It can be because of various reasons such as bone loss, perio reasons, or it can also be because your teeth contacts are variable. So if you look at this particular case, the interdental papilla does not fill in the middle. You can see the midline. So that results in a black triangle. So this doesn't necessarily mean that the patient has bone loss or this is a sign of a periodontal issue. It can also be that the contact area has been altered. So if you see the contact area over there, it has like a point contact incisally. So the same thing, what you can do is if you do a little bit of an IPR, create some space over there and close it orthodontically, you can close these black triangles. So you don't really need to do a grafting procedure, it's just that you need to modify the shape and form of the tooth. That's why I told you you cannot treat what you cannot see. So all these are things we need to identify right from the diagnosis. That's when we need to spend the most amount of time examining the patient's teeth so that you know step by step how to correct each of it and progress with your treatment. Coming to the last commandment, which is not your teeth or your gingiva, it is the lip volume. And why does this play a very important role in smile aesthetics? So currently, if you see, according to the current standards, people do appreciate slightly voluminous lips with a little bit of a natural pout, right? Now, why is this lip volume important? Two aspects to look at it. When you're planning a case, let's say patient has a crowding of teeth, or let's say patient has proclination of teeth, and you plan for extractions, but you don't notice the lip. So if the lip volume is reduced and you plan for extractions in such a case, you're further worsening the patient's soft tissue profile, right? So that is why it's very important to notice this lip volume when you're planning for treatment. And let's say that the teeth are okay, they are crowded, but you can afford to procline it more. That can in fact help your lip volume. So when you're planning for space closures or moving the teeth back, always look at the lip volume, because both are proportional, directly proportional, the position of your incisors and the position of your lip. So when the lip is thinned out, as you can see in the picture at the bottom, the patient was treated without any extractions or pulling back the teeth. The teeth were slightly allowed to procline a little more, so it gave a better profile for the patient. And in the same way, if you see, this is a contrasting scenario as the case is on the right. If you can see that the lips are very prominent, and by just retracting the teeth, you are getting a more, an aesthetically pleasing profile when the lips go back to rest. So both are, correlated, the position of your incisors and the lips. And this is a very underrated aspect where people easily neglected the lip volume when you're planning for smile designing. So given the time constraints of like 20 minutes, this is all that I could try to fit into the lecture. And there's a lot that I could still talk about. But I would like to conclude after discussing about these 10 commandments, that any kind of smile transformation, if you see, you can see that all these 10 commandments need to be followed. So when you look at these, before and after pictures of patients' smiles, you can see, I've spoken about the smile arc, which you can see in the first picture. You can see the closure of interdental spaces. You can see the ideal display of your gingiva, the teeth, and that's the secret behind getting an aesthetically pleasing smile. And the closing remarks, I always believe good things take time. And as an orthodontist, you need to believe that, because, of course, you do know these are long procedures, and you, as well as your patient, needs to wait for a long period of time to see good results. These are not things that you see instantly. But as we know, there are no shortcuts to success. There's no easy way to success. And a lot goes into planning and executing things so that you can give that beautiful smile to your patients. Thank you very much for your patient listening. And you can connect with me on any of the social media platforms. I'm known by OrthoTales on Instagram. And you can also read my research work on ResearchGate. And feel free to reach out to me and discuss on anything you'd like to. Thank you very much.
Thank you so much, ma'am, for such a wonderful for such a wonderful session. Now, I would like to invite Dr. Dwij Khullar, sir. Topic for this session is full mouth rehabilitation, a peek into the future of dentistry.
Hello.
Okay, sir. Any problem?
Thank you. डालिए नहीं ऑडियो नहीं है ये क्या है इससे हो गया कनेक्ट कर दो उसको बस आप लगाओ आ जाना चाहिए नहीं पेन ड्राइव में नहीं मिल पाएगा सर क्या दिक्कत हो रहा है सर ये बोर्ड और के लैपटॉप में ले लूँ क्या? हाँ जी सर वही नहीं, पर मेरे पास किसी और का लैपटॉप है नहीं ना, पेन ड्राइव में भी नहीं है। अच्छा आ गया, बस 1 मिनट रुक जाओ। बढ़िया, थैंक यू भैया। Hello. Good evening everyone. I am Dr. Divij Khuller, and firstly I would like to thank Cynodent India for giving me the honor and the opportunity to share my views on full mouth rehabilitation with you all. Special thanks to Anmol ma'am and Ashish Chandra sir for giving me this opportunity. Now full mouth rehabilitation is something that is a little difficult to condense in 20 odd minutes, but let's see what we can do in this and make the best of this time. So just a little something about me. I completed my post-graduation from Savita Dental College, Chennai, and currently I hold the world record for being the only postgraduate student to have done 54 full mouth rehabilitations during his post-graduation. Now, thank you. Now these cases were not just tooth supported but tooth tissue, implants, full mouth implants, tooth implants, and over the course of these last 3 years, wherever I used to go for presentations, I felt that there is one thing that is lacking, one thing that everybody is very scared of, and that is full mouth rehabilitation in its own. So 20 minutes I can't teach you full mouth rehabilitation, but at least we can put the errors that we are doing to some light and then make sure that we don't commit the same mistakes. So just a little something about me more, that I also am a BPS specialist from Ivoclar, Switzerland. And now let's jump on to the main part of the presentation. So full mouth rehabilitation. Now the first question that comes to anybody's mind is that what, when and why. Like when would we want to do it, why would we want to do it, and how would we want to do it. So before I begin my presentation, let me just give you a bit of statistics. Post-COVID, 1 in 3 people are either a bruxer or a clencher, and this is not just gender oriented, so it's both male and female that are doing it, and not just age as well. So there are young people even who are 20 years old having the same issue, and it goes all the way up till adults who are 50 or 60. And I am backed by a lot of scientific presentations that state the same, and these articles are all over the internet, because some or the other stress is just causing this to increase. Now why is full mouth rehabilitation the future of dentistry? Because even if today you don't have cases that come to your clinic for full mouth rehabilitation, probably in the next 3 to 5 years you will be flooded with such cases. So you need to be well prepared, well in advance. So whenever a full mouth rehabilitation comes to your clinic, is that how you look at the patient? And is that the thought that comes to your head, that it's just going to rain money and nothing else now? But what if the cases that you are doing are just surviving for the next 3 to 4 years, and they come back again after again for repeats or some errors that you have done? So your aim as a prosthodontist or a general practitioner when you're doing a full mouth is not that to survive, but to make sure that it's successfully surviving. So the first common mistake that we do is that we as general practitioners, or even prosthodontists I would say, feel that a full mouth rehabilitation just means doing 28 teeth prep or the number of teeth and giving crowns on them. Now how many of us think that full mouth is that? Can I just have some hands in the air? That just do some crown cutting and restore all of them with teeth. Appreciate the honesty, but that's exactly what we don't have to do. Now the second mistake, now I'll explain why over the next couple of slides, but the second mistake is that we underestimate the importance of our anterior teeth quite a lot. Now how many of us have heard or said the same thing to our patients, that आगे के दांत दिखाने के हैं और पीछे के दांत खाने के हैं? Can we have some more hands in the air? आगे के दांत दिखाने के और पीछे के खाने के. But my friends, that's the most wrong statement that you could have heard in the entire evening. Now let me explain why. Because your front 6 teeth, canine to canine, are not just for looks. They are not just for incising. They are not just for eating your favorite biscuit, but they are to protect your posterior teeth from breaking. And when you are doing a full mouth rehabilitation, you need to know how much width or height your posterior teeth need to have. So these teeth are the ones that govern it. And how do they do that? There is some mechanism called as anterior guidance, which states that whenever we move our mandible forward, like whenever I want you all to just protrude your mandible forward for a second. Just glide your mandible in the forward direction. Whenever we protrude our mandible, only and only the tips of our lower anterior teeth glide over the upper centrals and laterals. And when we do that, all the other posterior teeth are completely disoccluded. And this is the mechanism that is present in all the individuals naturally, and this is something we want to mimic in our full mouths as well. Because when we do this, the posterior teeth are disoccluded, and that's how we protect our restorations from breakage. The other mechanism that we have is called as canine guidance, which means that whenever I take my mandible left or right, either directions, my mandible, only the canines are the ones in that direction that are touching, and all the other teeth are disoccluding. So does it make some sense to you all? Like, I want you all to just raise your hands in the air once. Now tell me honestly that how do we eat? Do we eat like this, or do we eat like this, like how cows eat? Is it like a crocodile that we eat, or is it like a cow? Cow? So how many of us honestly have given crowns and only checked some movement like this for a high point? I'm sure all of us. Have we ever checked for any other movements? So when we do this, how many of us have faced this issue that you have given a 3-unit PFM or a single crown also, and eventually the porcelain has fractured and the metal is exposed? Have you seen such cases? And it might have happened in one of the three, probably. Why is that? Have you ever thought, why is the porcelain chipping from just one crown? Because when you were giving the crown, you only checked for tap, tap, tap. Now this tap, tap, tap is called static. We have two types of occlusion. One is static and one is dynamic while we are chewing and eating. So we never settle the dynamic occlusion while we are checking for a crown, and that is the second biggest mistake that we do while we are committing to a full mouth. Now the third mistake, and by this I want you to know that you don't need to be a prosthodontist to take a Facebook record. How many of us have a Facebook at our center or our clinics? Or how many of us have recorded a Facebook ever? Okay. Do you feel that it's an important part while you're doing a full mouth rehabilitation? Is it? Okay, why is that? Okay, let's put some light to it. Is your maxilla a fixed part of your skull, or is it a movable part? Fixed part. And is it fixed in one parallel plane to the ground, or is there some angulation to it? So that's how our maxilla is. Most of the times, I would say 99% of the times, your maxilla is at an incline because it's the fixed part. Now when you are doing a normal mounting, now I'm sure all of us, BDS or MDS, whichever branch we specialize in, have done some mounting in our life. How? With a 3-point? How do we mount with a 3-point articulator? We pick up the wax from the floor, we make 3 blocks and put the cast on it, take the thread, and we just do the mounting. Am I correct? If we don't have the incisal pin, sometimes the matchstick that was there on the floor is used as an incisal pin as well. Am I correct? Now what is wrong when you do that? Observe. When you do a normal mounting, that's how your mounting comes up to be. Am I correct? But when you mount using a face bow, that's how your mounting looks like. Can you appreciate what I'm trying to say? It mimics the angle of your maxilla, and when you do that, you not only get the perfect smile arc that Dr. Nia Naveed was putting light on, but also at the same time, that problem of your porcelain chipping from your posterior restorations is taken care of. So that's the third mistake that you do. You don't take a Facebook record when you're doing a full mouth rehabilitation. Now just to put a little thought on this, Facebook records are not only for just full mouths, but also when you're doing a smile design case or when you are doing a bilateral FPD like in this case. So this is somewhat like a Facebook record looks like, and it's not a very tedious job. It's probably, if you've trained well, just 5 odd minutes, but it makes your job easy. Now let me stop here and ask you one other generic question. How many of us have faced this issue that the crowns that our lab gave were fitting perfectly on the articulator, but they were not fitting in the patient's mouth. Have you faced this issue that your crowns were sitting on the articulator beautifully, but when you place them in the patient's mouth, there is so much of open, and then you need to take it on your ego and start trimming it till that crown fits. Have we faced this issue? That's again because we did not take a Facebook record, we did not do the mounting properly, and the crowns were made in a horizontal plane, whereas they had to be made at an incline. So these small mistakes where you spend probably an hour or two to correct it clinically, at that time if you just take a 5-minute Facebook record, these errors will be sorted. Now the fourth mistake, this is one question because I lecture about full mouth rehabilitation in a lot of platforms, and this is one question that is commonly asked to me, that doc, which articulator can I use for a full mouth? Now the most common articulator that we use is that mean value articulator. Now how many of us feel that it can be used after this brief interaction of 5 minutes for a full mouth? Anybody? Can we use a mean value articulator for our full mouth rehabilitations? We cannot use a mean value articulator, but can we use these articulators that your local labs have? What is this? Have you seen this articulator on the left? Have you seen the one in the middle? These are not even mean value articulators, they are just some articulators. Can you use this for a full mouth? You cannot use any of these for a full mouth because of two basic main reasons. One, because they don't allow for a Facebook transfer, like I just explained that it's so important. And the second, now this is a little bit much of prosthetics, so I'll just give you a very brief of this. You cannot record or change the condylar guidances. Now I can't explain that in 5 minutes, but that is something that you need to do while you're doing a full mouth. So you need to use either a semi-adjustable or a fully adjustable articulator. Now the fifth mistake that we commonly do. How many of us, before I jump into this, let's just understand, how many of us understand this concept of maximum intercuspation and understand this concept of centric relation? Can we have our hands up in the air, please? Or are they both the same? Are they both the same? Is there some difference? What is the difference? Have you encountered a bruxer or a clencher in your clinic with flattened teeth ever? Practitioners here? Now whenever you have worn out teeth, you forget the maximum way that you were intercusping before, and your muscles tend to rest and they come either in a forward movement or you have a deep bite. Have you experienced this, that if there is flattening of teeth, what will happen to the bite? It will go down, it will go deep. If there is a bruxer, he will completely lose all intercuspation and his mandible will move forward and you will have something which is called an edge-to-edge bite. So this current bite that is there, that the patient has, is called his maximum intercuspation. That is, how is he biting at this instance. But does that mean that, is that his centric relation? What is the centric in a complete denture? Anybody? Let me break it down easily. We have all made complete dentures before. Anybody who has not made a complete denture ever? How many of us have seen these patients who turn into habitual class 3s? What's a habitual class 3? That when he has no teeth, he moves his mandible forward, something like this, and the minute you give him a complete denture, it slides back into a normal motion. Now this normal place where the patient's muscles are at rest is something which is called as a centric relation. So when you do a full mouth rehabilitation, you have to do it in a centric relation and not in a maximum intercuspation. Now a very brief of this, how do you do that? So there is this concept of deprogramming. Let me break it down easily to you. Suppose you've gone to the gym and you have taken some weights and you have lifted them. How many of us gym here? Can we have hands? Is it possible for you to hold on to that weight for the whole day? Even if it's a 1 kg weight, the minute you lift it, there is some amount of pressure that happens to your muscles and then eventually you have to drop it to come back to rest. So deprogramming is something similar which makes sure that your patient's muscles are at rest so that before you do a full mouth, you have his musculature at rest so that your crowns last longer. this is what a deprogrammer looks like. This is one kind of an anterior deprogrammer. There are multiple such where there are short, intermediate and long ones. This is something which is like an intermediate one. The main aim is to just drop that weight. And how do you do that? You put something in the middle so that your maxilla and mandible are apart and the muscles are now at rest. Now this, I want everybody to wake up, focus, because this is going to change the way you look at dentistry for the rest of your life. How many of us have done a case where we have raised the vertical dimension? Can I have some hands in the air? Any case where you have raised the VD? Any denture case where you might have played around with the articulator to raise something up and down? So have you raised the VD of any patient before in your clinic? What is the most common thing that we do? I'm sure senior practitioners here would have done some cases where you have raised the vertical dimension. So what's the most common thing that we do to raise the VD? What is the most common? Anybody? Have you seen this thing on the articulator? What is this thing called? Have you seen a line, a metal rod in the center of your articulator before? No, not the incisal pin. The incisal pin is the one that you replaced with the matchbox or the matchstick. There is something in the middle, that long slender thing. Incisal rods, come on. Have you seen this before in an article? Have you ever mounted before? So the thing that is there in the middle is called the incisal rod. So does it have these indentations or these markings there? It does. What is the easiest thing to do to raise the vertical dimension? Just open it and raise it 1, 1, 1. Is that how we do it commonly? Are we Prosto postgraduate students there at the back? So every incisal pin that you have or the incisal rod has these markings. There is a red in the middle which is 0. There is 5 on the top and 5 in the bottom. So what you do is, we usually open the articulating pin, raise it to 1, 1 level, thinking that that's raising my vertical dimension by 1, 1 mm. So when you do a full mouth rehabilitation, the maximum that you can raise your VD is by 5 millimeters. Now does that mean I open my articulator and I open this pin and I just raise it from that red all the way till up 5? Does it mean that I can do that? Is it the correct way to do that? Anybody? Let me explain what happens when you do something like that, so that even if you are not doing it now, tomorrow you don't make that same mistake. So like I had explained, our maxilla is at an incline, so that means our mandible is at an incline as well. Common sense, if the maxilla is at an incline, the mandible is too at an incline, which means that the anterior area, when you open your mouth, opens a bit more and the posterior opens a little less. I want you all to just open your mouth a bit. Everybody. Is your anterior space more or is it the same in upper and lower both? Anteriorly you open a bit more. Now I want you all to yawn as if this is a very boring lecture. Everybody just open your mouth big and yawn. I hope they don't get this on camera. So when you yawn, is your mandible moving a little back while you do that? When you open your mouth quite a lot, is there a backward motion of the mandible that happens? So let's understand what I'm trying to explain. If you arbitrarily just open this pin and raise your bite say by 3 millimeters, you are only raising your anterior bite on the articulator by 2 millimeters and posteriorly you are just raising it by 1 on the articulator. That's why when you make these crowns, they sit perfectly on the articulator but not in the patient's mouth. So how do you correctly do it? Let's put some height to this. Let's understand with the help of this one basic thing. So this, everybody on the screen, is an articulator and that pin that is there in the middle is the incisal pin I'm talking about. Now it makes sense? So all you have sometimes do is just open this black thing at the top and raise this pin up and down to raise the bite by 1, 2, 3, 4 or how much ever you want. Now when you do that, let's see what happens. Now understand this with the help of this animation. I want you all to just look here. Now this is a case where you have raised the bite by 1 millimeter. Okay, before we do that, let's understand very normally. When I talk about bite raise, what comes to your mind the first thing? Do you want to raise the bite with the way your posteriors are disoccluding, or do you want to do it anterior way? By raising the VD, do we want to get more space in the posteriors? That's normally what we feel, but let's understand what we are doing. When we are raising arbitrarily on the articulator, say 1 mm, observe your anterior teeth and posterior teeth have some amount of disocclusion. Look there very closely. Now let's assume you are not happy with the bite raise, so you ask your lab guy to just raise it by another mm, which is 2 millimeters. A little more space, but then again I'm not happy. I don't want my lab to get back to me saying that you didn't have enough clearance, so I ask them to raise it by another 1 millimeter. Still not happy, I ask them to raise by another millimeter. Ample space in the back, but is something happening to my anterior teeth as well? Is something happening? You want to see, have a look at this again. Now assume this is at 1 millimeter, at 2, at 3, at 4, and now at 5. I'm getting more space at the back, but my mandible moves backwards, so there is a lot more space in between my upper and lower central incisor as well. Does it make sense? No? Okay, let's understand once again. When you raise your bite, say just by 1 millimeter on the articulator, this is your scenario there. You do it again by just arbitrarily raising it by 2 mm. You get a little more space at the back, but your mandibular incisors start to drift back, because when you open your jaw, your mandible starts to go back. 3 mm again goes a little back, 4 another little, and then 5, yes, you go back furthermore. So this is not how you raise your bite. The biggest mistake when people do while they are trying to raise their VD is they do this. How do you do it the correct way? You deprogram the muscles, and that's the way you get your bite to perfection using a different method, which is not this. You always look at the VD raise by your anterior teeth, that how much space is there in my anterior teeth to get the overjet and the overbite corrected. What's overjet and overbite? Overjets basically my upper and lower teeth, central incisors need to have about 2 mm space, and overbites again my upper teeth just need to glide them by 2 mm. When I arbitrarily raise my bite, say again to 5 mm, can I get a perfect overjet overbite here in this scenario? I hope it starts making some sense. So you can't just raise your VD arbitrarily. So that's the biggest mistake that we do while we are doing a full mouth. So the next mistake is, and this comes even for single crowns. How many of us still believe that we have to do an intentional RCT when we are crowning a tooth? Can we have our hands up in the air? Every time I give a crown, I need to do a root canal. Why is that? Especially when you're doing a full mouth rehabilitation, you are talking about crowning 28 or 26 teeth. You don't do intentional root canals, because no matter how well your root canal is done, it makes the tooth brittle, and eventually after say 10 or 15 years the tooth breaks. Then what do? So you only do a root canal in a full mouth rehabilitation if you have exposed the tooth while you are prepping, or the patient is extremely sensitive in that one particular tooth. That doesn't mean you leave it like that. You use desensitizing agents while after you have prepped and in between your phase when you are giving temporaries. Now these desensitizing agents put a coat on the tooth, and they make sure that the dental tubules are sealed temporarily and the patient does not have sensitivity in that time before you have placed the final crowns. So never do intentional root canal treatment for all teeth on all 26 or 28 teeth. Now the 8th mistake that I had put some light on earlier was that how many of us, like we have discussed, have used this one articulating paper, or most of the times carbon paper as we do in our country, and we just ask the patient to tap, 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 and we check that whatever high point is there, we remove it, not knowing where to settle, what to settle, and we send the patient off. But we forget that that's not how the patient eats. The patient eats like a cow. We eat like a cow. So you not only have to settle the static occlusion, but also the dynamic occlusion while you are doing a full mouth rehabilitation, because that will make sure that your crowns are not chipping, the porcelain is not chipping, the zirconia is not breaking. So this is what I mean by static occlusion, tap, tap, tap. And on your right is the dynamic occlusion, where you move your mandible in laterotrusive and protrusive manners. The last thing that I would say, that whenever you do a full mouth rehabilitation, you haven't changed the bruxer or the clencher. You haven't cured the patient psychologically. You are a dentist at the end of the day. He'll still be a bruxer, he'll still be a clencher, so you need to protect the crowns that you have given, because like he broke his natural teeth, he will also break his crowns. So you do something which is called as a splint therapy. The splinting can be done different ways. The most common ones, an anterior repositioning splint that you give your patients to protect the crowns that you have now given and make sure that your full mouth lasts as long as it can. A very difficult topic to speak on in 20 minutes, but I hope you've taken at least 1 or 2 points back, at least taken some points that you were doing the wrong way, and I hope to see you soon to understand the right way of it. Let's just take another 5-10 odd minutes to put some cases out there so that you understand the treatment planning a bit more. Now this case that I will show you first is one of the dearest cases to me. I did this case when I was in my second year of post-graduation. Now this gentleman is 21 years old, and when he had walked to us, at the age of 21, he had walked to us like this. That's his front, that's his left, and that's his 45-degree. When he had gone before us to multiple dentists, rightly so, most of them said that we cannot give you crowns, we cannot put implants, you need to extract these teeth, whatever are remaining in the maxilla, and wear a complete denture at the age of 21. Now answer honestly, if something like this has to happen to you, would you wear a complete denture at 21 for the rest of your life? Would we? So then this patient happened to come to our clinic or our center at Savita, where we decided to do something different for him. Now before I say this, I want you to all understand one thing, that full mouth rehabilitation does not mean that you are a prosthodontist only that can do it well. Whenever you do a full mouth case, you need to look at all 8 branches that you have learned, be it perio, be it endo, be it prostho, be it ortho. Every clinical branch needs to be looked at so that you can get the best possible result. So in this case, if I would have just looked at it like a prosthodontist, probably I would have also said that let's just remove these teeth because they're not good enough for crowning or implants, let's just give a complete denture. This is how he had walked to us intraorally on day 1. So he had something which we call as a skeletal class 3, as we can see the mandibles protruded quite a lot, because of which his upper teeth were completely worn out. So if I would have just looked at it like a prosthodontist, like I explained, that would have been the treatment planning. But then I thought again and again, and we looked at it as a general dentist, and we decided to do something called a bilateral sagittal split. So we decided to do an orthognathic surgery for this patient. What is a bilateral sagittal split, anybody? BSSO is basically when you cut the mandible in 2 segments and take it back and you stitch it back so that you get the correction done. Something that we need to do when we have a surgical class 3 case. So I'll just run you by the pre-surgical workflow. Before that, this is the pre-operative maxilla and the pre-operative mandible right there in front of you. Correcting it in this particular bite would have been a disaster because whatever we did would fail. So in this case, the OPG was something like that, and the lateral ceph can show you how much the mandible was in a forward direction. So this is the pre-surgical workflow. We mounted the case using a phase bow. We did a mock surgery on the articulator, on a fully adjustable articulator. We made a splint after the mock surgery was done so that that guided us when we were doing the BSSO on the table to place the mandible in the exact position and stitch it back. Once the pre-surgical aspect was done, the same happened in the surgical part, and then once that healed, this is how he was just after surgery. So can you explain, can you just see that how much of teeth are now visible, how much of better options can we now do? Now the first thought that would come to anybody's mind would just, let's just take these teeth out and place implants. But at the age of 21, the best implant as a prosthodontist that I placed would also last only till 40, best to best 45. Then again at 45, all he has to do is remove and wear a complete denture. So how about we give him 10 odd years of fixed crowns till say 30, 31, another 20 by implants. They start to slowly fade away and fail. We convert that to a removable, and at the age of 60, 65 we finally give him a complete denture. Makes more sense? So we did something in the mandible which just required some amount of restorative care, just some amount of class 3s. The maxilla on the other hand was where we had to work a lot on. So we did cast posts in the maxilla. In some teeth we just did fiber reinforced posts, did a good prep, took a mass impression using 3-shape design, the temporaries as well as the finals. Did a good coping trial. The OPG at the stage of coping trial was this. Can you see these two metal plates in the mandible? That's post BSS, so to stabilize the mandible at the back. In the end, this is the centric that I could achieve. This case lasted for probably about 8-9 months, but I think they were worth it. Now let's just look at the difference in the smile that I could create by just thinking and looking at this case as a general dentist. The front profile, the side profile. Can you see the mandible go back? Thank you. And if you want to see a close-up of the same, something like this. Now we are short on time here, so I'd just like to show you one last case, which is also a challenging full mouth that I have just done. Another case that would require surgical aspect, but let's be honest, how many patients would opt for a surgery when they come to your clinic? Not everyone, so let's understand how do we manage such cases without a surgical aspect. Because showing simple full mouth cases is very easy, everybody can do that. So let's see here. This is a case of a lady who is 60 or 62, if I remember correctly. She had the similar thing but in a different direction. Can you observe the gummy smile? Can you see from the side profile the amount of maxilla that is there in the front? So this is a simple case of the mandible going back and a maxilla coming out a bit. Easy would be to just do surgery, get the maxilla in shape, probably do a bit of lip repositioning and get this. But 62 years, didn't want to go under the blade. So we just had very minimum scope to work on. This was her when she came to us on day 1. That's the closed bite. Can you observe no amount of teeth visibility in the lowers? That's just to show you a bit of opening. Now, if you just look at the top case, would you think that like I explained to you, that 5 mm is the maximum we can raise? Would you just want to raise the bite by 5 mm in this case? Let's get the maximum amount of bite raised. Would we still want to do that? Wouldn't our maxilla, which is already in front, and the mandible, which is already at back, go further back if I raise just by 5 mm? Is it making sense? So then, doing the right bite raise by the method that we do, we came to a conclusion that this case can only be raised up to 3 millimeters because the mandible was going way behind and we were losing the overjet and overbite, and hence causing a lot of phonetics and aesthetic problems. So this is what we could achieve post the full mouth. And if you want to look at an open view, this is how it was post the full mouth. Now there's a slight bit of catch here. Now there I worked as an orthodontist as well. Now here I want to explain that we took a bit of perio on board and did something which is in the front 4 teeth. Can you appreciate what that is? Crown lengthening. So when we do some amount of crown lengthening with lasers which are minimally invasive, the patient's on board with us. And let's just see how much of a difference can it make clinically by just looking at it the other way. That's what I could achieve. No lip repositioning, no surgery, just a bit of crown lengthening. The crowns look a bit longer and they still look natural and fine. Thank you. Now, if you want to just see the side profile, which is, I feel, even better, that's what we could achieve just by doing a bit of crown lengthening. So full mouth rehabilitation is not that difficult. It's just that we don't know sometimes what we are doing. And if we just get the basics correct and the mistakes are out of the picture, we are all, I'm sure, able to achieve results like these. So with that, I would like to conclude my presentation and also thank the organizers once again for giving me this opportunity. And I hope to see you all soon someday. I conduct these courses on full mouth and complete dentures. So I hope I can see you and teach you sometime later in the future. Thank you. So that's my Instagram page. I come by the name of Dr. Divij Kuller. So if anybody wants to interact, that's my handle right there. Thank you. Take it.
Thank you so much, sir, for such a wonderful session. Now, I would like to invite Dr. Anmol Bagaria, ma'am, Dr. Ashish Chandra, sir, Dr. Pankaj Patel, sir, Dr. Ruchi Patel, ma'am, for felicitation. I would request Dr. Ashish Chandra, sir, Dr. Anmol Bagaria, ma'am, and Dr. Pankaj Patel, sir, to felicitate Dr. Ruchi Patel, ma'am. Thank you, ma'am. I would like to invite Dr. Vishwaraj Nikam, sir, for felicitation. Sir, you can go. Thank you, sir. I would like to invite Dr. Krishna Prasad, sir, for felicitation. Thank you, sir. I would like to invite Dr. Neelam Das, ma'am, for felicitation. Thank you, ma'am. Now I would like to invite Dr. Bhuvan Nagpal, sir, for felicitation. Thank you, sir. Thank you, ma'am. Now we again start with our lectures. I would like to invite Dr. Vishwaraj Nikam, sir. He is an eminent oral and maxillofacial surgeon.
क्यों ना, मेरा नहीं लग रहा है। Hello. Good evening all. In this beautiful city, historical place, Lucknow. Myself is Dr. Vishwaraj Nikam, oral maxillofacial surgeon, working in Pune, Maharashtra. And I am very happy to see you here. Patients listening, you are still sitting in front of us. And this is the one of the good opportunity to learn. Because of this, Lucknow is very hot. Atmosphere is very hot, and even my topic is also very hot. This is minimal invasive procedure for mandible impacted third molar tooth, a study to prevent incision and soft tissue handling. It is something new, something different. See, in 40-50 years back, abdominal surgeries were like this, open abdomen surgeries, or any pathy, any surgeries were not minimal invasive. But the demand of the stitchless or minimal invasive surgery is increasing day by day in all pathies. Patient का demand होता है, कितने टाके पड़ेंगे? Because patient count, patient ऐसा count करता है कि कितने टाके पड़ेंगे उसके ऊपर the surgery और उसका डर. So after 20 years of practice, no, right now I am practicing since 21 years, but after 15 years of practice, I realize after the extraction of thousands of third molar, something should be there like minimal invasive procedure in case of mandible impacted third molar. I don't want to discuss the initial protocol, you know all. And for my technique, I got copyright by Government of India in 2019. Felicitated by Dr. Christopher Hemmel, University of Switzerland. I don't want to discuss initial protocol, you know all better. I will directly tell you what is MIT, minimal invasive. You can Google it and see the whole article also whenever you get free. See, in our language I am telling you, what is the motor aim behind the third molar removal? We have to remove all the resistances. Am I right or wrong? The first main resistance is the adjacent tooth. Because all 80% cases are hidden below the cervical C junction of the second molar. So, first of all what I do trimming of the contact point by trimming the third molar without hampering second molar. If even it is visible 5-7% in the oral cavity also. I will show you case by case, right? Now, after removing the contact point, there are 2 points during removal of third molar or any third tooth. You have to study 2P, 1, purchase point and path of removal. Believe me, I am telling you everything out of the book. Every tooth should have its, you have to get one good purchase point and path of removal. Path of removal should, you have to study here first. It is like a wrestling. हर बार ताकत की जरूरत नहीं होती है कुश्ती में. उसमें भी डाव होते हैं. तो extraction में भी डाव होते हैं. So what I mean to say you, every tooth is having its own path of removal. So you have to study it first, the path of removal. Simple things I am telling you. You have to trim the resistance first. If you are not confident, use matrix band in your early initial days. After cutting the contact point, create a purchase point. If it is there, it's okay. It's not, trim slightly, undermine the tissue and slightly trim that bone, just one ditch and get a purchase point. I am telling you, never ever use air rotor in case in the tissues, it may cause surgical emphysema. Contact point you may break with the air rotor, but purchase point or gutter of the distal bone, even no raise. See, what is the main culprit behind the post-operative complications of third molar removal? Anybody student from backside? What is the main culprit? Don't know. Soft tissue handling. If the soft tissue handling is less, the post-operative complications are less. So, without raising or incising the tissue, you have to reflect the gums and just undermine the collar of the distobuccal area with the help of air rotor, help of micromotor with copious irrigation. And what will going to happen for that? After that, this is okay, but the main concept of my MIP is, whenever you are elevating, always we elevate from the mesial side and elevating distally like this, right? But there is external oblique ridge and anterior body of ramus, very thick, huge bone. There is a big repulsion from backside. Believe me, whenever you remove 6 lower first molar or any tooth, where you pull buccally or lingually, buccally. तो सारे दांतों का, सारे टूथ का पाथ ऑफ रिमूवल इज बक्कली. तो ये भाई साहब ने क्या किया है, इनका भी पाथ ऑफ रिमूवल बक्कली ही है, बट इट इज अनेबल टू पुल बिकॉज ऑफ दैट टूथ इज हिडन इनसाइड. I am not able to pull it buccally, at least I can pull it buccodistally. See, if I am cutting the contact point, my elevator is going more in, so I always I am elevating like this, but now I am elevating like this. And it becomes a cornucopia. Cornucopia, Google it, it's a physics. I love physics a lot. In even 12th, I had 100 out of 100 in physics. Physics is a physiology of nature. Extraction में physics काम करता है, याद रखो. तो ये चीज बहुत important है. Whenever you elevating distobuccally, what is cornucopia? Cornucopia is a spiral. Cyclone आता है, कैसे आता है? Every quarter turn it becomes wider, right or wrong? So tooth moves like this, and that is a cornucopia. It's a nature's law. Sunflower, it's a cornucopia. Galaxy, it's a cornucopia. अभी key point of extraction नहीं लेता हूँ मैं थोड़ा. This is my first case. Believe me. Can you imagine this tooth with stitchless or minimal invasive procedure? And if the X-ray is like this, see the tooth is out, toto, like a simple extraction, patient satisfaction, and healing after 7 days. Another, see the cornucopia. This is cornucopia. In geometry, a golden spiral is a logarithmic spiral whose growth factor is phi and the golden ratio. That is, the golden spiral gets wider by a factor phi for every quarter turn. It's a cornucopia. Every structure, including maxilla, mandible, teeth, etc., had a growth site and growth centers. Growth centers, from the growth center, the tooth develops in a path which follows the logarithmic spiral. Logarithmic spiral follows the golden proportion like emerging as a cornucopia. Scientist Robert Murray Ricketts had studied growth rotation in detail and gave the theory to determine the center of a rotation of a mandible, from which we can access growth of a mandible, that is a growth prediction. Similar theory applied on the third molar growth centers, then the growth of a tooth is occurring in a logarithmic spiral path and also follows the golden proportion. So that in MIP, MIT, patient position, doctor's position, instruments, purchase point, site and force directed into the distobuccal direction, expansion of a cortical plate, all will provide same rotating or spiral direction to a tooth in which tooth develops naturally. So MIP, MIT actually following the tooth eruption pathway, and hence it becomes absolutely less traumatic. This is a mechanico-physiological theory of MIP, MIT. See another case. मैं थोड़ा rush कर रहा हूँ because you have to see some cases. See another cases, because this is a topic of at least 1 hour, but it's okay. See, if the 7 is carious, no need to take care. In case of distoangular, now see, distoangular mein we have to elevate the tooth from distally, because tooth is like this, we have to make it straight and take it out. But if you are breaking the contact point, and in this condition, if you are applying the elevator distally, the contact point, the surface area in connection with both tooth are less now, the resistance from the second molar is less, that lowermost point acts as a fulcrum, tooth rotates around its own axis, and it is easy to take a position, make it straight, and it will come out easily. And this is distoangular is also out. This is another case. For example, everywhere in the world, Germany, Japan, Korea, India, Delhi, Kolkata, Lucknow, everywhere, everybody is incising such tissue. Out like a collar. See, because if I am cutting the tissue, it belongs to the patient. If I am cutting the bone, it belongs to the patient. Good surgeon duty is that he has to preserve the thing that belongs to the patient. I am cutting the tooth that has to be extracted, and that is a waste product for the patient. Now some huge rooted tooth out. See another case. See, the tooth is like this. See amount of time. I am going distobuccally. See, distobuccally. This is my favorite instrument. We call it as a Bhavani Talwar to this. This is a London hospital pattern. एक भवानी तलवार है और एक भाला है हमारे साथ, बस. He is a gynecologist. Tooth is out, toto, with minimal invasion. Now J hook. See, the tooth is out. If the case is like this, see, everywhere there is only simple flap. Why to incise the tissue? Tell me. This is like a normal delivery. I don't want to go for the cesarean section like a gynecologist. I am trying like a baby, the gynecology, the tooth is coming out. I have to struggle for that. Just undermine the tissue. You won't get post-operative complications. And why to show the patient that I am doing very big job and so you have to pay me? Don't tell like that. Tell the patient directly. This is my technique. This is my study, and I am making you free in 2 to 5 minutes, 7 minutes. It's minimal invasion. Pay more. Yes, patient agreed for that, because we should be ethical. Don't tell, don't make a show for just we are putting so many instruments and all like this. See, our Bhavani Talwar is so great and it's coming out. See my struggle. क्यों भाई, क्यों आएगा इस पेशेंट को स्वेलिंग, क्यों आएगा? हाँ, now if the case is like this, tooth is not visible in the oral cavity and the patient is having a chubby cheeks like this. Even the tooth is erupted and patient is opening the mouth, the fat is on the occlusal table of the tooth. We have to search tooth first of all, if even it is erupted, and if the X-ray is like this, then can you think for the minimal invasive or without incision? And see, the tooth is out. See the invasion, no patients complain, nothing. If the case is like this, cut the contact point properly. Tooth is out. Patient is happy. This is after extraction, not before extraction. Sometime before extraction is also, the photo is like this. Now see this case. Ashish sir, 5-7 minutes more. Thank you. See the another case, because this is very important topic, and we have to, because अभी तो मैंने बहुत सारी cities में 6 countries में introduce किया है. You can see me on Google, and ये मेरा मानना है, पता नहीं, but within 4 years patient will ask you in your clinic, इतना मैंने वो spread किया है कि आपके यहाँ पे बिना टाके की अक्कल दाढ़ निकाली जाती है या नहीं. The demand of the stitchless is very more now. See the case, and see the tooth is like this. Can you imagine? And see the tooth is like this. And we are surgeons. Surgeons must have 3 qualities: lion's heart, lady fingers, and eagle's eyes. And eagle's eyes should be on the tip of your fingers, because आपके उंगलियां ही आपको बताती है what is happening. हम क्या करते हैं? एक तो कुछ एक्सेस नहीं होता है, टिश्यू वहीं पे, ब्लीडिंग, टंग, इंस्ट्रूमेंट, सक्शन, एवरीथिंग, कटिंग बर, हमको ही कुछ नहीं दिखता है, फिर भी हम चिल्लाते हैं असिस्टेंट की तरफ, उसको तो इतनी सी जगह दी जाती है, ठीक से पकड़ो, दिखता नहीं क्या. तो मैं बोलता हूँ ये करने की जरूरत नहीं है. See and go follow this. But I am telling you once again, ad aati hai, don't try this at home. Like that, I am telling you, don't try this at your clinic until you get a good knowledge, good that sensations of the, otherwise mandible fracture may happen. You have to learn first of all these things nicely. See the patient's satisfaction in this. There is a gauze in the oral cavity. See another case, if the tooth is like this, out, see the invasion. See even bone भी कितना hamper नहीं हुआ है. These are my, one is Bhavani Talwar and one is Bhala, my favorite instruments. और शायद ये दो कोई नहीं use करते. We want a fancy instruments. No, old is gold always. This is my clinic. This is another case of huge roots. Tooth is out. Once you get that physics in your mind, the cornucopia, believe me, you will remove every tooth like this within some minutes. If now you will ask me, sir, पता नहीं आप करते हो, बाकी लोग कैसे करेंगे, हम कैसे करेंगे? See, I conduct courses every month. 3 people are coming worldwide here from India to my place for 1 month, and see the girl from Mumbai. See another case. अभी इसका ये मैं नहीं दूंगा आपको, इतना टाइम नहीं है अपने पास. हाँ, see, done by that girl. See, after proper learning, see the minimal invasion everywhere. See the minimal invasion. See the tooth where it is in the X-ray. See, minimal invasion. Lot of thousands of cases. The girl from Dubai came for the course. See the pattern of root. Still the minimal invasion. done by that girl. Thousands of cases are there. Even foreigners are coming from so many places. Bilateral, same time. See, she is from US, same time bilateral horizontal. Voice please.
And now tell your US people, your friends, come to India for the speechless and penless extraction.
Yeah.
First, I presented this topic in the one Maharashtra State Conference. Then I conduct courses for this at Pune. First launch in National Conference. Then this, you won't believe, out of 50 people turned on the course, 8 is there, 7 is missing, and 6 is present. In Mumbai. So take an Got national prize at Trivandrum, Kerala, Uzbekistan. And the most important thing is I presented this technique in the conference of oral and maxillofacial surgeons at Maharashtra State Conference. Again, one more thing, I presented this in oral and maxillofacial surgeons of National Conference. And again, 1 month back only, I presented this in 16th Asian Oral and Maxillofacial Surgeons of Asia countries. So, this was live demo in Ahmedabad Dental College. Within 3 minutes, 4 minutes, 7 extra third molars done. This is my Raipur course. We teach everything from basic. Another course is in Raipur only, same place. 2 days course is there. This is copyright from IDA, Kolam Trivandrum, by World Dental Federation appreciated by, this was Pune, and I got a Family Dentistry Award of the year 2022. And actually, believe me, now listen this is very important.
Goes to Dr. Vishwaraj Nikam. He's here somewhere.
Means in Mumbai, people are conscious now for this.
Yes.
What the sir is telling, just listen to this.
Technique for third molar. Yes. Impacted teeth.
Voice please.
Which is almost non-invasive, I would say, but it's minimally invasive, and that prevents any sort of discomfort for the patient as well.
Congratulations.
He has a copyright on it.
In fact,
Congratulations.
at the last Family show, this was the last lecture, but it was an earth-shaking lecture because he shared technique of extracting third molars without using forceps.
And the most important thing for me is appreciated by Dr. Stanley Malamet sir. And this is my copyright, not only copyright, this is with my trademark, and this is going to come in the textbook of oral surgery, MIT Dr. V.H. Nikam's technique. Apart from medical field, I love to work in TV serials. I played a role of Chhatrapati Shivaji Maharaj in Mumbai. You can contact me, feel free to contact me on this, my number, or anybody want to join the course, or anybody want to, I am very freely available person. I never miss my call. Only I am in a lecture, otherwise, if even students I am telling you, if you want to ask, start with the conical roots, simple roots, mesioangular, do it, and एक बार आपको वो कला आ गई तो उसके बाद in your city patient will tell to each other that यहाँ इनके यहाँ पे बिना टाके की surgery होती है. So this is very important. This sentence is very important. The perpetual preservation of what remains is most important than the meticulous replacement of what is lost. Divan's principle. Thank you very much. Jai Hind. Thank you. And मैं एक विनती करना चाहता हूँ, जो हादसा हुआ है कोलकाता में, उसके लिए हम एक अपने यहाँ इसकी वजह से एक मिनट उनके लिए हम खड़े रहेंगे थोड़ा सा. Thank you. Anybody want to ask anything? I am available outside, huh? Because next lectures are important. It's already late.
Thank you so much, sir, for such an informative lecture. Now I would like to invite Dr. Piyush Shivhare, sir. Topic for this session is muscular pain in orofacial region.
Sound है, sound.
Good evening, everyone. So after a very nice presentation, there is a new technique, and I appreciate that technique. And we should work for new techniques, and that is minimally invasive techniques. Although work are going on all AI techniques and very costly techniques, which is I don't know how much is possible in India, but such techniques should be appreciated, and we should work for more for that. And my topic is going to be very basic topic. Okay, it is not a very the difficult one or it's a newer one, but a basic topic and very frequent topic of having patient with muscular pain encountered in our daily clinical practice. So this is something about me. I have fellowship in Orofacial pain, TMDs. So the muscular pain is I'm very much interested in muscular pain, so I will be presenting that only. Currently I am working as an associate professor in Government Medical College, Chandoli. Okay, usually lots of patient reported to our clinic with patient either complaining of, doctor, I am not able to chew, okay, not able to open my mouth completely, not able to yawn, feeling pain in teeth irrespective of no dental pathologies. When you check your odontogenic causes, there is no specific dental pathology, there is no decay, there is no tendon percussum, but still patient feels there is a pain in teeth. Pain in TMJ region, although there is no radiological finding, there is no features of any arthritic changes. Pain in ear without no ear pathologies. Lots of patient comes with patient complaining of pain in ear, and you referred a patient to ENTs, then ENT referred back again saying that there is no specific ear pathologies. Feeling of tingling sensation, not getting proper sleep, or many the patient have visited to many clinicians like ENT, dentist. So what we does for this patient? Okay, we either restrict ourselves to the evaluation of third molars. We say, okay, third molar is not getting erupted or it's partially erupted, maybe this is the cause for the pain, or sometimes we directly jump to the muscular pain. We give muscle relaxant, painkillers, all physiotherapy, still patient is not getting relief. So why this is so? Either because of incomplete examination or wrong diagnosis. So my topic is going to be myofascial pain dysfunction syndrome. Remember that it is not myofascial, it is myofascial. Okay, so lots of when I used to correct a BDS paper, they used to write myofascial. It's not myofascial, it's myofascial. So the main culprit of myofascial pain dysfunction syndrome is called as trigger points. It's nothing but it's a hypersensitive bands of it's called as taut bands. So we can see these, sorry. So these are the muscle fibers, and after the prolonged microtrauma or macrotraumas, some of the fibers get be contracted, and it will be a taut bands, and which will be more tender. So this is called as trigger points. So what are the precipitating factors? So precipitating factors, it can be a trauma to the muscles, occlusal disharmonies, chewing hard food, chewing gums, opening mouth wide for a longer time, systemic factors like emotional stresses, vitamin D deficiencies, sleep disturbances, systemic factors. Out of this, which I used to see is one of my articles we have done in Nepal, and we have seen that the hard food biting habit was one of the most important culprit other than stress and occlusal disharmony. So our food habit is also important for such cases. Stress is very important. We have to ask history about stress always, about the emotional stress, about the sleep, because once if there is a stress, there can be altered muscle tensions, reduced circulations, followed by muscles pain, and that vicious cycle again will be going on. So this is one of the case, the patient of nearly 18 years old patient reported with severe pain in the masseter muscles along with temporalis, and lots of treatment have been done with the patient, but still patient was not getting relief. So we have asked we have asked about the menstrual irregularities, and there was menstrual irregularities was present, and we have asked the ultrasound, and there was a right ovarian cyst. So sometimes such systemic irregularities also can cause muscular pain. And even in the articles it clearly mentioned that the ovarian cyst and ovarian dystrophies can be related to fibromyalgia or the muscular pain. So these are the very important systemic evaluation which we should not miss. Now pathogenesis is we all have seen the pathophysiology behind or physiology behind the muscles contraction and muscle relaxation, and we know the calcium and ADP is very important, ATP is very important for muscle contraction and relaxation. So following the microtrauma and macrotrauma, there will be depletion of calcium and ATPs, and that will lead to formation of firm taut bands and contractions bands, that will reduces the further blood supply, releases of endogenous inflammatory mediators, and that will cause pain, that is the pain in the triggered points. So what is Laskin criteria? We are all have seen Laskin criteria in the final year exams, very routinely asked question. So there will be 4 positive cardinal signs, that is pain, pain in the muscles, muscular tenderness, clicking and popping sound, limitations in jaw movement, and there will be 2 negative features, like there will not be any clinical or radiological features. Now then how you will going to diagnose these cases? First is you have to palpate trigger points, that is the most important thing. When you palpate trigger points, there will be a twitch response and patient will jump. So that is called as twitch response or the jump sign, and that is most important features. We should able to differentiate trigger points and trigger zone. Now trigger zone is seen in trigeminal neuralgia, where you just touch the tissues and there will be pain, but in trigger points you have to palpate it, you have to apply pressure. So you have to palpate, you should know how to palpate, because it will be a firm nodular type of feelings, you will you have to palpate this, make sure that it is a trigger point, nothing else. Okay, the one of the important feature of MPDS is the referring pattern. We all know that the fibers of the orofacial structures along with the neck and or the tooth, they all converge into pons and medulla. So if there is a pain in the muscle structures like temporalis muscles, it can refer to the odontogenic region, or the odontogenic pain can refer to the neck or the other muscular structures. Similarly, MPDS also have referring pattern. So sometimes the pain in the anterior temporalis can have a pain refer to the anterior tooth, or middle temporalis to the premolars, or similarly posterior to the posterior tooth, upper posterior tooth. So this is the thing why patient is complaining of pain in tooth, still you are checking the odontogenic cause, there is no specific odontogenic cause, and you missed the palpation of muscles, the examination of muscles, you are giving all treatment for the odontogenic cause, still patient is not getting relief. So check the muscles also. Similarly, there is a referring pattern of the masseter muscles. Okay, the SCM. Okay. So how you are going to check properly about the referring pattern? So if you palpate the site of pain, okay, if you provocate the source of pain, there will be the sensitization of pain along with the muscles along with the tooth as well. But if you revert back, if you check, if you do the tenderon percussion for the tooth, there will not be any pain to the muscles, remember that. So the site of pain should be palpated properly. Similarly, if you inject local anesthetic for the muscles, there will be the complete relief of pain, but if you do the anesthetic injections for the tooth, there will not be any relief of pain. So this how you have to diagnose, you have to check. Associated symptoms like tingling sensation, numbness, vertigo, blurred visions, fatigueness, these are all features can be present with MPDS. So, how to diagnose these cases? Because there is no radiological findings, no investigatory findings, there is a proper history, examination of muscles or trigger points, proper history of sleep, stress, or you have to rule out odontogenic cause, that is the most important thing. Now, what is soft end feel and hard end feel? So, patients have a restricted mouth opening, but patient is still able to open her mouth after applying pressure, and now patient having pain, patient is showing that patient have a pain in the masseter muscles. So, that means it is called a soft end feel, that is a feature of MPDS. Now, what about hard end feel? Now, this also patient also have a restricted mouth opening. Now, we are applying pressure. Now, patient is telling patient is not able to open mouth completely and patient having pain on nearly the TMJ area. So, is showing the pain on TMJ area. So, that is seen in anterior disc displacement without reduction. So, we should able to differentiate hard end feel and soft end, very important diagnostic feature. Another feature what we can do is you can apply tongue blade and you can ask patient to bite. If the muscles, if the culprit, the patient will have a pain on the same side, or if it is a TMJ is the culprit, the pain will be relieved on the same side. Okay. So, can you see the patient is biting on the right side, there is a contraction. If there is a pain in the muscles, patient will have a pain. If it is a TMJ pain, obviously it will be getting relief on the site of biting. This is another test which you can do in your chair site. So, there are advanced diagnostics also there, like T scan, jaw tracker, joint vibration analysis and EMGs, that is comes under neuromuscular dentistry, and you can read more about that. Now, treatment is because it is not very easy to be treated this case, because the systemic evaluation should be done, the exact causes should be known, then only we can treat these cases easily. So, elimination of stress is the most important thing, and if there is sleep deprivation, patient should be educated, and the medication should be given for sleep and any other etiological agents. So, pharmacotherapies, if we see muscle relaxant, we can go for the centrally acting muscle relaxant, but as per my experience, these muscle relaxants are having a very questionable role rather than the anti-anxiety drugs and the physiotherapies. Moist heat application can be done to relieve to causes vasodilatations and the stimulation of A beta fibers, and that is specifically causes gate control relief of pain. Spray and stretch, that is a good technique where we can use a cold spray, and I advise patient to stretch his or her muscles as much he can, so there will not be any pain. So, this technique a very successful technique to relieve muscles pain. Trigger point injection, which I usually follow in daily routine, and you have to palpate trigger point first and then inject either lignocaine or the dextrose, 12.5% dextrose, that is called as prolotherapies, that will also relieve pain. Okay, this how we does trigger point injection. First palpate properly, because the successful aspect of trigger point injection is to check properly about the trigger points. If you miss the trigger points, you will inject local anesthesia in some other places. So, make sure that you are injecting onto the trigger points. Now, once you inject it, you have to check for local twitch response. If you are in a correct place, patient will jump. That is a sign that you are injecting in a correct place. See, this is the local twitch response. It can be ultrasound guided also, but the trigger points is very small in the muscles of mastication. If it is the muscles of back, then ultrasound guided is good. So, what we are actually doing with trigger point injection? We are just try to stimulate the trigger points to generate ATP. So, this is the injections of trigger point injection on masseter muscle, trapezius, SCM, splenius. On TENS therapy, there is another physiotherapy, TENS therapy, that is the transcutaneous electrical nerve stimulations. We use low intensity electric current. We all have this TENS therapy in our dental clinics. So, what exactly it does? It either causes gate control theory, that is stimulate the A beta fibers, then it also release endogenous pain control by endorphins, enkephalins. It also increases vascularity, it also have a placebo effect. So, the main is it causes A delta A beta fibers, okay, A beta fibers, it stimulate A beta fibers, it closes A delta NC fibers, that causes no senses. So, हम लोगों ने पढ़ा हुआ है final year में, nothing new in that. So, stabilization splint is also have been tried in very successfully in case of MPDS, but it should be stabilization splint, it should not be night guard. There is a difference between night guard and stabilization splint. It should be a flat stabilization splint. Slow है थोड़ा सा. Okay, low level therapies or photobiomodulation also can be used, where we use 635 to 980 nanometers to release certain chemical mediators, and we can use 2 to 3 joules around the trigger points, that will relieve the pain, but do not overuse it, again it can cause their own effects. Okay. So, this was about the MPDS. Now, one more condition is called as fibromyalgia, which usually we get confused the fibromyalgia with MPDS. We just palpate masseter muscle or temporalis muscles and we say that is MPDS. But what we have to do is always try to palpate all possible muscles, not only the orofacial structures, along with the hands and the feet and the back, because there might be a fibromyalgic condition which is very common in old ages, and you will be just doing physiotherapy for a local muscles like masseter or temporalis, but patient will not get relief, and fibromyalgia is very common in older age. So, there will be 18 trigger points, there will be 18 pain points which you have to palpate, because there are lots of comorbidities for fibromyalgias, like there can be a migraine, joint hypermobility, anxiety, irritable bowel syndrome, polycystic ovarian disease and hypothyroidism, the case which I have discussed like polycystic ovarian disease. So, we have to differentiate fibromyalgia and MPDS because the treatment modality will differ. So, they require tricyclic antidepressant, duloxetine, anticonvulsant, it is very difficult to treat, but at least you can diagnose properly and take consultation from your ortho consultant or neuro, and you can also give at least tricyclic antidepressants and all can be given. So, my topic was very easy topic, not like which from afternoon I am seeing very great topics of great techniques, but these cases comes in very routinely it comes under your clinical practice, and we misdiagnose these cases. Okay. So, correct diagnosis is very important, and details systemic evaluation like sleep history, stress, menstrual irregularities, vitamin D deficiencies, This is all very important. Don't misuse muscle relaxant and painkiller. We all in the world where aceclofenac is combined with different type of muscle relaxant, all muscle relaxant is combined with all anticonvulsant, lots of combinations are going on. So, don't misuse those drugs. Okay. First proper diagnose it and then you give. Ruled out odontogenic cause, that is most important, then fibromyalgia, that also should be differentiated. So, keep getting more and more knowledge about the muscular pain, because MPDS is not only the one, there is few more, but because we have only 20 minutes time schedule, so that will be enough for me. Thank you.
Thank you, sir, for such an informative session. I would like to invite Dr. Krishna Biswas, sir. Topic for this session is From Despair to Repair, Saving Endodontic Cases Against All Odds. Over to you, sir.
Hello. A very good evening. I'm very thankful to have this podium and given by 12th World Dental Science and Conference and Cynodent. As it's been a long day and so much of plethora of knowledge has been imparted, so I'll be very short. My topic of presentation is From Despair to Repair, that is to save all the endodontic cases. But with the invent of implants, as we know, every tooth which has been extracted, or we have a fair chance to put implants. But initially when implants were in use, and if the patient cannot afford implants, what best we can do? Supposedly if a tooth has been out for around 1 hour or maybe 18 hours, and if the patient presents that teeth with you, that can you do any justice with that tooth? So, series of cases which I will be discussing of those endodontic cases, or maybe the reimplantation, intentional or delayed, how we can treat them. So, this is the institution where I work. I am faculty, currently assistant professor in All India Institute, Guwahati. So, the cases like this where the fracture of the file has happened at the apical third, she was a 18-year-old female. Then in cases where the tooth has been brought in a kidney tray and we put it in saline, or a tooth which has been brought in a postcard. So, can it be treated or can it be salvaged? So, and this is a routine case where we see pathologic perforation or iatrogenic perforation of tooth. So, let us start the journey. First and foremost thing is that don't limit your challenges, in fact challenge your limit. So, reimplantation can be defined as reinsertion of tooth back into its socket due to avulsion or trauma or any other iatrogenic procedure. So, it depends on many factors. Obviously, age, we know that in case of age, if the patient is younger, then the chances of reimplantation is much better as compared to older individual. Then width and length of root canal, the more the width, more is the PDL, so better is the chances. Then comes the mechanical damage. Now, if there is a trauma where the buccal plate or the palatal plate has been hampered, so in that cases, obviously the chances, the prognosis is lesser. Then sprinting of reimplanted tooth, whenever we are doing sprinting, it shall always be semi-rigid because we need physiologic movement of the teeth. Then effect of mastication, it has been seen when the patient has mastication effect, a little hard tooth, then the chances of ankylosis is less, and therefore masticatory stimulation is needed. Then external duration time, we have all read in the chapters that the duration time of the tooth should not be more than 1 hour because the PDL fibers start getting degenerated. So, storage media, what are the main characteristics of storage media? These are the main characteristics of storage media, where it shall maintain the periodontal fibers, the osmolarity, no antigen antibody reaction, and so on. So the best of the storage media is HBSS, that is Hank's Balanced Salt Solution. If you don't have, you can use Viaspan. Even chilled milk, the cold milk can be used, or not lesser than saline. So this is again the definition of interest. What is the good candidate and bad candidate? The one which has flared root, obviously we have to intentionally do the reimplantation by removing it, so chances of fracture is more. Such in case, this is a good candidate. So we will come to the first case. So the patient came with a chief complaint of right lower back tooth region past 15 days. So root canal treatment was done, and as a result there is a fracture we can see. Therefore, this is the orthopantogram showing the fractured file, and this is well near the infraalveolar nerve canal. So after that, what we did is that we carefully removed the teeth. Now the removement of the tooth was done as atraumatic as possible. Why? You can very well appreciate the periodontal fibers. Now this treatment has to be done within 15 to 20 minutes because the degeneration of PDL starts happening, and therefore chances of rejection happens. So the separated file was carefully removed from the root apex, and you can see that the periodontal fibers are still intact, and this is the separated file. So after that, the canal was redefined. The root canal treatment was done as we generally do in standard operating procedure. Irrigation was done with 5.25% sodium hypochlorite and EDTA. After that, the canals were obturated with F2 Gattapacha and H+ sealer. So this is how the picture. After that, what we have to do is that the apical resection. So we had done the apical resection, that is 2 mm depth with the ultrasonic, and we fill this with biodentine. We can fill this with biodentine or MTA. Why? Because these are biocompatible materials, and we need to basically eliminate the apical ramification where the maximum load of bacteria is there. Otherwise, then there are chances of bacterial invasion or ankylosis or many other things. So again the tooth has been placed back to the socket. Now when placing back to the socket, we have to do with slight digital pressure, and then this pink color is basically the splint. Because of the blood and the fluids, it has become pink. Otherwise, this is the splinting which has been done from the premolar to molar. Okay. So this is the immediate post-operative photograph, as we can see, and this is the follow-up after 9 months. So you can very well appreciate the amount of bone loss. The radiolucency has turned into bone. This is after the 9 months of follow-up. So it has been well taken. Then Second case is of delayed reimplantation, where the patient came with a tooth, so we immediately place the tooth in the saline because we have to moist it up. Now in this case the periodontal ligament is already dead. It's already 18 hours. So in that case what we have to do is that we don't have to scrap the tooth, because still to remove the PDL, in fact we have to do the chemical treatment, like we can use sodium hypochlorite or EDTA 24% for the surface treatment. After that I have placed the tooth in tetracycline fibers. Now this tetracycline fibers helps, basically tetracycline has a property of anti-resorptive property. So if we place this, then the resorption of the bone will be less as compared. So these are the tetracycline fibers where the surface treatment of the tooth has been done. Then similarly, whenever we are placing, in case of reimplantation, we have to resect the root to remove the apical ramification and the intricacies. So after that we are preparing with the ultrasonic, and this is the MTA which has been mixed, mineral trioxide aggregate, and then with the help of MTA carrier we are placing in the tip of the root. So this is the final outcome. So this MTA, that MTA or biodentin, whichever you are using, has to be depth of 3 millimeter. So it is again placed back in the tooth. So this was the, the tooth, it is again placed back by slight digital pressure. After that we have done the splinting. This slight, that thing is the splint. So this is after 2 weeks of post-operative procedure. Then this is the third case. Here also the patient got the tooth in the postcard as I showed earlier. After that the tooth was soaked in 2.4%. Now this soaking of the tooth is at most necessary if you are planning for reimplantation. That is 2.4%, 5.5 pH solution for 20 minutes. After that, so this was the patient, how he got the tooth, mode of transport. So we used in this case doxycycline, tetracycline doxycycline. Why? Because there are two types of root resorption. One is external root resorption, one is internal root resorption. So in this case, external root resorption is bound to happen. So in order to reduce that, we are using this kind of surface treatment. So after that, this tooth has been placed and a splinting has been done. So this was the fiber splint, and this is after placed back after the socket. So this is after 3 weeks of the removal of splint. We should generally place the splint for 14 to 21 days, and this is the 3 weeks, and this is the clinical picture of palatal region. So how the gingival tissue, how it has taken, even if after the tooth was out for 1 day. So this is the 5 months follow up, and this is the IOP X-ray after 5 months. So the bone has also taken up the tooth, in fact, and there is no external root resorption. You can very well appreciate. So perforation repair with the MTA, we must be doing endodontic cases. In such kind of cases, we generally come up with perforation. So how to deal with perforation? Basically, we have, after the perforation has happened, we have to negotiate all the canals, and we shall have collagen in pack or cola plug. Now this cola plug has to be placed over the perforation area so that the bleeding can be stopped. After that, we can repair with either the MTA, that is mineral trioxide aggregate, or we can use biodentin. So this is a case of perforation, and we have placed MTA. After that, the root canal treatment has been done, and this is the picture after 1 year of follow-up. So this is another case of perforation, same way we have done, but here we have used floor reinforced with GIC. So this is the post-operative image after the 8 months. So the important point in case of perforation repair is the location of furcal perforation. So it should be at the level of epithelial attachment and crestal bone, which suggests a guarded prognosis. Also the surface of perforation matters. Supposedly it is involving the whole the floor of the tooth, then you cannot repair, because eventually after the crown preparation there is chances of vertical fracture. So intra-alveolar transplantation. So in this, why it is done? When the crown root fracture is going subgingivally and has problem like isolation, maintenance of biological tooth and restoration. So these are basically the classification of the fracture of the tooth. Now in this case, as you can see that the fracture of the tooth has happened at the, the CEJ junction at the clavicular margin. So what we did is that we have to remove the tooth carefully outside and we have to rotate it 180 degree. So we have rotated the tooth 180 degree and then we have done the splinting. So after the splint, what we have done is the obturation, and this is the custom made post. In BDS time we have to make custom made post, not the fiber post. So we have made a custom made post and then we have placed the crown. So this is the immediate obturation done and the fragment reattached. So this is the second case, I suppose. Then this is something which comes to the clinic very rare, radicular groove. So I'll be just taking few minutes to explain what is radicular groove. So palato-radicular groove is an anomalous formation of tooth that begins in central fossa of maxillary incisor, extends over the cingulum and continue apically to varying depth and distance of the root. So this usually occurs in lateral incisor, more of central incisor, and the incidence of ranges from 0.9 to 9.6%. So with the diagram you can understand that this is the palatal groove which occurs, and this can be shallow or can be deep, and these are the types. So these teeth are generally not associated with caries, and whenever you take an X-ray there will be a periapical radiolucency. Now the thing which can be come in mind is that whether it is because of trauma from occlusion, whether the patient has some traumatic bite, but when you take an X-ray, then with the X-ray you will see a periapical radiolucency, and also you have to see this groove. So this groove is important, and there will be maybe a sinus opening as well in the labial or the buccal side. So what we have to do in such kind of cases, we have to remove the tooth. Well, first we have to do the post-obturation before removing the tooth. After the obturation has been done, we carefully remove the tooth as atraumatically as possible. Why? Because this groove need to be treated. So preparation we do with the ultrasonic, and then after that we see this is the 9-month follow-up. We can use a bioceramic sealer or some kind of thing to seal this area. Like in next case, this is another case. So we have done the tooth extraction and groove is extending up to the root. So this is the groove, and then we prepare this area with the ultrasonic. After that, sealing is done with iRoot BP+. So this white area, after this material has been set, we again place the tooth back and seal and do the splinting. So this is another case similar which we have done. Here in this case we didn't remove the tooth. In fact, we basically did a periapical surgery and we sealed it with iRoot BP+. So this is the suturing, post-operative 18-month follow-up. Then this is mandibular canine with 3 canals. The X-ray was not good because this was I took in some clinic, but you can very well appreciate that there are 3 canals in a canine. So definitely this has to be done under dental operating microscope or maybe a loop. So this is the classification. So this is Gulabi wala classification where 3 canals join into one, and this is the post-obturation which has been done. Then comes the furcal perforation with separated instruments. Now in this case there was a separated instrument as well as furcation. Now what we can best do? First is that with C+ file or any VDW files we have to negotiate and bypass the instrument, and after that we have done the perforation repair. So this is how the bypass of the instrument has been done in this case, and then the perforation repair has been done, and this was after 3 months, very well tolerated by the patient. So this probably will be the last case of mine where there was a fracture of the tooth, and this is the tooth. So we have to prepare this area as well, the crown area and the root area, and then we have placed a fiber post inside after doing the root canal. So this is the fiber post in place, and then after that the tooth has been reattached back to the area. So I would like to say that believe you can, and you are halfway there. Thank you.
Thank you, sir, for such an informative session. Now I would like to invite Dr. Neelam Das, ma'am. Topic for this session is groundbreaking application of artificial intelligence in periodontal research. Over to you, ma'am.
A very warm good evening. I think आप सभी लोग वेट कर रहे हैं because the scientific presentation result. I'm from Kanpur. Myself, Dr. Neelam Das. I'm associate professor in Kanpur. Today I have chosen this topic, that is artificial intelligence, specifically in periodontal research or any research topic, specifically for the students only, whether the PGs for their academic work, specifically their hard days, that is their library dissertation or dissertation. So let us begin with this. This is my department with my HODs and my all PGs. Till now I have completed more than 100 researches in my field. So I will guide you or tell you the few things how artificial intelligences work in your academic researches. How with the help of various tools you can accelerate your research and you reduce your traditional burden in those hard days. So I think all of you using Alexa in your home maximum. Now this tools already it is useful, we are using in treatment aspect, but now we are talking about in research. In academic writing, how this tool will help, because in my views there is a generation gap between the artificial intelligence, how it implement in the research. So today this is the topic of my presentation. I will cover in this few contents how talking about the basic knowledge or the constitutes, so how artificial intelligence work and how it implement in the academic writing, begin with the manuscript preparation till the publication in a respective PubMed journal. Okay? So let us begin. We all know that artificial intelligence, it is coined by John McCarthy in 1956. It is not new, but the use of this in research, this is something new in dentistry also. So this artificial intelligence has brought a paradigm shift. It not only refined the methodology, it can also introduce the data handling, analysis and various dissemination. So with this we can prepare, not only prepare the manuscript, we can go to the result part, we interpret, we go to the plagiarism check and we publish in a various respective journals which the students want in their PG academic. Okay? Let us give a basic idea what artificial intelligence has. You all I think know about it, or let me introduce. Artificial intelligence has a few steps like machine learning, natural learning, processing, they are the types. In machine learning, actually it is a type of artificial intelligence, but it retrieve from a large database. Then it implement to a research. It has a sub part, that is a deep learning, which include the neural networks like artificial neural network, convolutional neural networks. The next, natural languaging process. It is a machine, so that this machine can communicate and implement in human languages. Next, expert systems, visions, speech, plan and robotics. Robotics, that is a AI in a physical form. This all constitutes in artificial intelligence. Next, how this artificial intelligence actually work. This diagram will tell you how it works. The difference between the human brain and artificial intelligence is one thing, that is it has a layer of neurons. Like first step, there is a shallow neuron input and output, in middle there is a hidden. While talking about the deep neural network, it has a layer of hidden neurons. What it can work, it can retrieve a knowledge of input layers and it communicate to the output layer. Why we call a hidden? Because it has a multiple layers. What this does, this hidden layers will implement all the knowledge from the input and it will give to the output layer. Next, the convolutional neural networks. It has a scan where it visualizes digital outputs, like all the digital, like images, videos, this will analyze. This is the basic difference between the human brain and AI. We all have the neurons also, but the main part, it has a, it embedded with a neurons, it embedded with a deep layers, so it can enable the multiple layers of input and output layers. Now the topic begins, how this AI work in research, how we can use this various AI tools in the research purpose. By this presentation, I will tell you the schematic diagram. For the research, we all in conventional times, in previous times, we are doing the research works. So this research works is done by the human brain, which has a cognitive knowledge or skill. But by the implement of this artificial intelligence, the various tool, its analytic or resource tool, it will help or it will reduce our burden and time. Okay. This graphical representation, it is a layout where it tells this artificial intelligence how it work in research or a theory development. Theory development, it is a part of academic research where this theory, this implement with the knowledge in the field of respective study. Study in the respective every field, every 9 departments of dentistry. So what are the 4, it has to cross the 4 phases. The first phase, we have to cross check all the information. In second phase, we have to rationalize our information. In third, we have to evaluate the outcome generated by the artificial intelligence. And the last, we have to combine the research input, that is the cognitive knowledge, and the artificial intelligence result. So by this combination, we can lead to a research work or a theory development. Now begins, what are the tools which are useful for the topic selection? Yes, as a student, for a research purpose, for a thesis, we have to need what are the tools which helps. These are the few tools like, RCIF Sanity, Schematic Scholar, Scopus and ResearchGate. These are the various AI tools which help to identify the research topics, and it will gather the information also, because it utilizes the advanced algorithm to gather the extensive part of a research, that is a literature review. Next AI tool, that is for sampling method. We all need the inclusion and exclusion criteria of the sample. These are the few tools which helps. What are the tools? That is GPower, RedCap, Qualtrics, SurveyMonkey, OpenAPI and AI algorithm. These are the various tools which help to our methodology. Next we talk about the literature review, the tools which help to gather the information for our research. The tools are RSAI, Endnote, Mendeley, Zotero, PubMed AI. Mendeley, Zotero and AI, they are the new tools. This is, we can install it. We can install in our desktop, we can add in our word processor, and it will automatically give the references to our manuscript. I will give an example where I integrate all this AI tool in a respective topic. Next, for the data analysis or the result part, that is SPSS modeler, Tableau, Python and SAS, that is statistical analysis systems. This perform the advanced statistical test. It is mostly used by the statistician. So by researcher, we have to be have some knowledge about these tools, so we can interpret our result also. Next, what are the tools which is used for comparative analysis, for the comprehensive review and the meta-analysis research? The tools are Revman, Covidence, Rayon, API Reviewer and Distiller SR. These tools, they enhance the efficiency of the systemic review and the meta-analysis. Next, they not only enhance, they facilitate the robust conclusion in any research. Here as a periodontitis, I am working on a periodontal research. So, this give a better result to our periodontal research. Next, very important part, that is originality and integrity. We all facing the plagiarism in any manuscript, whether the dissertation, whether the LD. So these are the few tools I think most of the students are using. These are using by the institution also, that is iAuthenticate, Turnitin, Unicheck, Grammarly Premium and PlaqueScan. Next, what are the AI tools which is used for the writing, academic writing tools? What these tools are? Grammarly, Writeful, Pro Writing Aid, Skyflu and Typeset. These are the few AI tools which can install in our desktop, which can we can use this AI tools for best academic writing, that is all the academic purposes. Next, I will go to, by discussing all, I have given an idea and I proven how this AI tools work in a research. Now, next I am going to integrate how this various tool works in a respective topic. See, I integrate these tools in one topic, that is local drug delivery in periodontitis. Okay. These are the tools which I discussed. These are the tools which is used for the academic research purpose. The topic is local drug delivery. What we have to do, the respective tools. First, we have to find what are the topic, then enter the keywords, then install and review. The first is Discover. While talking about the RSAFE, we have to go to the website, we have to give the keywords and then update our research. Next, Schematic Scholar, same, go to the website and search for our respective topic, that is local drug delivery in periodontitis. Then we have to use the special features what he has, that is explore, citation and the references. Same thing for the Scopus and G-Power. Scopus also for the, go to the website and use the terms periodontitis and local drug delivery system and go to the result part. G-Power for the result analysis, RedCap, Qualtrics, SurveyMonkey and API, this all for the academic writing. We all go to this and we all make the research in an extended view. Next, Mendeley, EndNote, Zotero, they all, these tools for the, specifically for the research, we can install it, we can make our manuscript writing. All the citation or the references are come one by one. Covidence, Distiller SR, Rayon, API Reviewer and Grammarly, this is all for the, specifically for the manuscript preparation, making it grammatically, making it correct way. So this all give a style for our manuscript according to the journal, which journal we want. And at the end, this all tools for the plagiarism checkup. So what, at the end I give some, I have searched some links for all of you, this various AI tool which is helpful for a research I conclude that this various AI tool, it not only help, it will make a streamline starting beginning with the publications to the manuscript writing till the publication in a respective permit general. Rest, it can also has the ability to process extensive data, literature review, and it accelerate the innovation and clinical advancement in our academic research. So we all have to use these AI tools to reduce our traditional conventional research writing. So it will reduce our burden also. Thank you all.
Thank you so much, ma'am, for such a wonderful session. For the last lecture of today, I would like to invite Dr. Bhuvan Nagpal, sir. Topic of this session is essential traits for excelling in oral pathology. Over to you, sir.
Check.
Good evening, one and all. Am I audible at the back? How many are students here? Please raise your hands. Okay, that's really great. And how many are practitioners or faculty? Okay, fine. Anyways, my prime agenda was to target students only, because mine is the last presentation and I won't take much of your time. Only thing is, I want to highlight some of the peculiar things about the domain of oral pathology. This is my business card, and I am the India's first NABL accredited and approved authorized signatory for lab reports, which includes all the investigations except histopathology and cytopathology, which are belonging to head and neck region. My lab is Tohana Mangalam Diagnostics. It's the first and only diagnostic center with registration with Clinical Establishment Act in my city, and only NABL accredited medical lab in Tohana. And I am the primary NABL approved authorized signatory for lab reports. This is my team. You can Google my name on, and you can get information pertaining to my. Then I have one more center, which is for the Center for Oral Pathology and Maxillofacial Diagnostics, that is COPMD, for the diagnosis of OPMDs. You know what OPMDs are? Oral potentially malignant disorders. Recently, last year, I have founded one association which is registered in Haryana, and it is working to promote the specialty practice of oral pathology and to empower oral pathologists in India. I have one more academy, that is AOPLM, Academy of Oral Pathology and Lab Medicine, which is ISO certified, and under that courses for oral pathologists who want to learn more aspects which are not taught as per the curriculum in colleges. So just to highlight that man is not immortal but remains immortal through his work. Is it true or not? So my presentation is dedicated to Dr. Anita Borges, and those who do not know Dr. Anita Borges ma'am, you can Google, and she is the last word in histopathology. कभी किसी को histopathology के diagnosis में doubt हो, तो you can go to Mumbai and show the slide to her. Whatever she says, that is the last word. She has that Midas touch, and she has experience of more than 50 years. Even a road is named by his father in Mumbai. So she is my true mentor. And next is I am very much mesmerized by Dr. William G. Schaefer's, the textbook which you people must be reading in undergrad. So I just want to declare that this presentation is an informal effort to highlight and to think about the knowingly unknown qualities of oral pathologists with a different perspective, and it will be blend of my own comprehension and experience in medical diagnostic industry for more than a decade. And I just want to say that take these aspects in a positive sense. Every branch has its own pros and cons, and I am just here to highlight the importance of oral pathology and what all traits are required to become a good oral pathologist. So start करते हैं oral pathologist की कहानी उसी की जुबानी. So what oral pathologists do, why they do, where they do, how they do, and when they do. I have a question to majority of the audience here. I know some may be hating the subject. So do we dash oral pathology? You just keep the answer with yourself. I will ask at the end of the presentation. I just want to say that the value of college education is not the learning of many facts, but the training of the mind to think. This is what Dr. Albert Einstein has said. So I just want to ask 3 questions. Had pathology or oral pathology not been there, what would have been the story of medicine or dentistry? अगर caries होएगी ही नहीं, cancer होएगा ही नहीं, या और कोई भी pathology नहीं होगी, तो what will happen? I know these are hypothetical questions, but give a thought to them. Do we really value the plethora of information about oral pathology? Imagine if all the information regarding oral pathology is lost, what would be the situation? Now you never know what you have until you lose it. आपको कभी भी उस चीज़ की वैल्यू नहीं होती जब वो आपके पास है. Be it a phone, be it any material, be it any relationship, it is a true fact. So see, this is the graph. You can see that the value of something when you do not have that. And when you have this, the value reduces. And when you lose that, suddenly the value increases. So what is pathology? Pathos is all about diseases. It means the study of diseases, and it is a specialty of medicine and dentistry. Oral pathology is nothing but a confluence of basic sciences and clinical dentistry. And as per our curriculum of MDS DCI regulations 2007 and 17, which says that a dental surgeon has to be trained in general and special pathology, and to carry out all the investigations which are being done on a routine basis in any of the diagnostic center. So if we see the definition, so the specialized field of pathology dealing with the diseases of oral cavity and its associated structures, teeth, tongue, bony tissue, maxilla, mandible, joint, lymph nodes, nerves, blood vessels, nose and throat, and structures in the neck. So according to Dyke, a physician using somewhat different methods of observation, a microscope rather than a stethoscope, the results of chemical and bacteriological investigations rather than the unaided senses. McLendon has aptly described pathologist as a physician, as a scientist, as an educator, and a leader. So in my opinion, oral pathologists are microscopic or tissue physicians, laboratory physicians, disease detectives, or doctor's doctor. If any other best name you know, you can suggest me later. So how they work? Our work is like movie directors. Because by diagnosis, by doing a correct diagnosis, the treatment plan will be better and then the prognosis will be good. So the work of oral pathologist is like Sherlock Holmes. So you have to diagnose that disease or to to find out what is the correct diagnosis at the tissue level, including many aspects, which includes history taking, which includes different techniques of investigations and many other traits. So to solve the mystery of disease or slide, oral pathologist uses 7 qualities. Number 1, what are these? Whose eyes? Please wake up, please wake up, only 10 minutes. Whose eyes? Very good. So the beauty of the eyes is not how they look like, but how they see. This is by me only. Whose eyes are these? No, it's not the eyes of Donald Trump. These are the eyes of Dr. Brad W. Neville. The Neville textbook you must have read. So he's an oral pathologist. So eyes are the mirror of soul. So you can see the hematoxylin eyes. There was a song, no? Blue eyes. Yes. So from there only I have taken. So eyes are the mirror by which the information in the slide is reflected to an oral pathologist. They are the sensory organs of vision, but for us, they are these organs of observation. So as Dr. Bill Bass says from US, that you have to be very, very good observer, and you have to be an observer of minutiae and to look at the little things and which make a difference. And that's where our academic training comes into the picture. You have to be born with a certain visual aptitude. So what happens in our Indian system, at the UG level, it is not told what is exactly oral pathology is about. It is not reading just a Schaeffer's or Neville textbook. It is much, much beyond that. So some people, they join pathology not really knowing what it is all about. So what comes next? तुम मुझे ब्रेन दो, मैं तुमको. So brain is the higher center, which is central investigation agency, which helps in the thinking process, processing of the information, connecting all the clues to come to final conclusion or diagnosis, then reason and judgment, and visual memory. So now coming to reason and judgment, I'll take 5 minutes to explain that. You know that killing is a crime. Do you agree? Madam, at the last, yes, killing someone is a crime. Do you agree? Okay, then tell me, a soldier, an Indian soldier kills a Pakistani soldier in the war, will that be a crime? Why? Because the context is different. A Jallad hangs a person, will he be punished for killing that person? Okay. If you kill someone in self-defense, then you will be punished or not? Because you have to see the context. And remember, the undergrad students or even the clinicians, in all the cases you have to see the context. So those who are in 3rd year reading medicine and surgery, I just want to highlight, see, this is the case, a 50-year-old female lady who has osteoarthritis, recently lost her husband, and she is diagnosed mild hypertensive, that is 140/90 millimeter of mercury. She lives in Mumbai in a chawl. I hope you remember what is a chawl. There is a Mumbai guy also here. You know what is a chawl? It's a long building with where many people stay together, only single rooms or 2 rooms set is there. And she has to use an Indian style toilet at ground level, ground floor. Now our textbook says, the book says that diuretics should be used to treat mild hypertension. But can you suggest that diuretics can be used for this particular case? What are diuretics? Anybody in the students? Diuretics. These are those antihypertensive drugs which make you urinate, and by that they decrease your blood pressure levels. So in such case, an old lady of 50s, she has osteoarthritis and she has to go and pee on the ground floor. She lives in a chawl and recently lost her husband. So the judgment says, pertaining to this case, no diuretics but anxiolytics, because she is under stress. So this is, I wanted to make you understand reason and judgment. Now pathologists, they are more interested in the recognition of structural alterations but also their significance, understanding of disease, and therefore a foundation of sound clinical medicine or dentistry. This is the brain of Dr. Albert Einstein. Has anybody thought why he was so brainy? His IQ was because that parietal operculum was missing in his brain, which allowed the other part of the brain to grow more than the normal. So as Dr. John Rosai, he is one of my favorite pathologists, and he was from US, and last year only he passed away. He says that visual memory is very important in this field. And there is no question that a person, some people have a better eye than others. Like females, they remember that which color suit the other girl has worn in that party or not. Is it true or no? You remember, no? So it means the eyes are better in females. So, and third year resident with a good eye will see something which even an experienced pathologist must not have seen that. Again, I have not eaten enough of the tree of knowledge, though in my profession I am obligated to feed on it regularly, which means that you have to keep yourself updated and keep on reading and gain information from the textbooks and the journals. Now from where this information comes? The various textbooks, the various journals. Then information and experience is different, and information and knowledge are entirely different entities. Information is not knowledge. The only source of knowledge is experience, or what you can say, knowledge is wisdom. You need experience to gain wisdom. Most good judgment comes from experience, and most experience comes from bad judgment. We have seen that a majority of lectures today, people were talking about the mistakes which you should not do, and that was a very good part. So they were sharing their experiences. Now what is the stethoscope of an oral pathologist? Yeah, please say it loudly, no? You never know, maybe tomorrow you will become an oral pathologist and I'll be sitting there, so I'll reply to your answers. So a stethoscope of an oral pathologist is a microscope. There are different types of microscopes. Now what is this? Anybody wants to read this? सांसों की ज़रूरत है जैसे, सांसों की ज़रूरत है जैसे, ज़िंदगी के लिए बस एक सनम चाहिए आशिकी के लिए. Here I am not going to give any sanam or ashiki. I just want to say that diagnosis की ज़रूरत है जैसे, diagnosis की ज़रूरत है जैसे, treatment के लिए बस एक biopsy चाहिए histopath report के लिए. So here I want to emphasize that all students or all general practitioners who can identify any white or red lesion, please don't believe on their eyes what they are seeing, and don't defer the patient. आप ये ले लीजिए एक महीने के बाद आइए. No, you should always do a diagnostic biopsy and send it to a histopathologist. दिल चीज क्या है आप मेरी जान लीजिए, बस एक बार मेरा कहा मान लीजिए हिस्टोपैथ रिपोर्ट चीज क्या है, आप IHC की रिपोर्ट लीजिए, बस एक बार बायोप्सी करवा लीजिए. For us, biopsy specimen is equivalent to patient, a blood sample is equivalent to patient. So the different vitals in oral pathology are cell morphology, basement membrane and inflammation. This was the reason why I didn't took any other topic to explain, because again histopathology, it will become a very boring lecture and everything will go above the head and later everybody will clap and just go away. So these are the signs and symptoms. We can only see the signs. The cells cannot tell us the symptoms. So necrosis, apoptosis, different histopathologic bodies, cells, patterns, inflammatory cells and dysplasia. This is very important because on the basis of dysplasia we grade as a sarcoma or a carcinoma. I guess you people are aware what is a carcinoma and what is a sarcoma. What is oral pathologist temple? That is our laboratory. So analogous to physical examination in medicine, surgical procedures in surgery, tooth preparation and RCT in cons and endo, bracket placement in orthodontics, in oral pathology we have histopathological examination or microscopic examination. So these are the basic processes which happens in the body. I have categorized from my experience, either it will be an inflammatory lesion, it will be a developmental lesion or hemodynamic or immune mediated or a neoplastic. Majority of the lesions are either inflammatory, immune mediated or neoplastic. Now coming to words. Words can be powerful when put into action, they become life changing. So again, pathologist Dr. Paolo Domizio says that you have to picture, when you read a report you should be able to picture what the pathologist who has written that report is saying. You have to have a skill in putting up what you are seeing down the microscope into the words. So what is a histopathology report? This is my, it is a blend of good slide observation along with thorough thinking, with proper reasoning and judgment, which is put in together into the beauty of words. Every slide is a mystery, pathologist solves it by history. To solve the mystery of disease or a slide, we need observational skills, a visual memory and thinking skills to join all the clues. We need knowledge which will come through books, journals and experience, a good microscope, specimen, either blood, biopsy from the patient, a good laboratory and then a written report. Now again I ask you the same question, do we dash oral pathology? The options are live, like, love, passionate about, all of the above, none of the above, any better option which you can tell. So the dictionary meaning of like is to find something pleasant or attractive, to feel about, inclination or preference, love, a strong feeling of affection, passion, an intense desire or enthusiasm for something, anything which arouses great enthusiasm compelled by intense emotions. So allow your passion to become your purpose and it will one day become your profession. So this is true for any branch, not only oral pathology. If you are passionate about any branch in dentistry, please pursue that. Thank you so much. And lastly, I would like to acknowledge the organizers, Dr. Ashish Chandra sir and Dr. Anmol Bagaria ma'am, for giving me the opportunity to present my point of view or my presentation in front of you all. And one small thing I wanted to tell, that last year in the month of March, there was a judgment passed by Madras High Court. As I am also a lawyer, there was a huge discussion between a lawyer today. So क्या आप लोगों को पता है लॉयर क्या होता है, एडवोकेट क्या होता है और बैरिस्टर क्या होता है? गूगल पे सर्च कर लेना, बाकी मैं बता देता हूँ. Lawyer is the one who has only LLB degree. Advocate is one who has LLB degree and enrolled into Bar Council of India. I have 2 degrees, but I am not enrolled with Bar Council, but I am a medical legal consultant and expert in that. And last is barrister, who the person who has gained LLB degree from England is a barrister. So last year this judgment came which clearly says that BDS is a system of dentistry, is a system of medicine dealing with dentistry. Why this happened? Because there was a case in Chennai, post for food safety officer was announced, and in that many BDS people have applied, but their applications were rejected. So they filed a writ petition, and this was the judgment which was given by the bench of Madras High Court on 23rd March 2023. Thank you so much. So I just wanted to highlight this thing. I think I've finished on time.
Thank you so much, sir. It was a wonderful session. Now, as we have done with all the lectures, and it's a time for the results of your presentations. I know you are waiting for so long. So you all did wonderful presentation, and I know you all did a lot of hard work, and you know hard work will also pay off. So results for the offline paper presentation slot 1 hour. I would like to invite Dr. Ashish Chandra sir and our mother Usha Bagaria ma'am to please come on the stage. So result for the offline paper presentation slot 1. Third prize goes to Dr. Agrima Sood. Second, one more third prize goes to Bhavya Joshi. Second prize goes to Shushantika Dagar. Many congratulations. And we have 3 winners. First one is Mahir Verma, Shriya Srivastav, and Mansha Sajad. We have 3 first prizes, Mahir Verma, Shriya Srivastav, and Mansha Sajad. For slot 2, third prize goes to Vartika Srivastav. For slot 2, we have 2 third prize winners, Vartika Srivastav and Dr. Rishabh Kapoor. Second prize goes to Dr. Tarun Prakash. First prize goes to Dr. Reshu Singh. For slot 3, second prize goes to Dr. Pragyan Paliwal and Dr. Ankur Bhardwaj. I would like to invite Dr. Piyush Shivhare sir on the stage. Dr. Pragya Paliwal, second position. And also Dr. Ankur Bhardwaj. First prize goes to Dr. Mohit Tomar, Dr. Yashika Bali, and Dr. Satnam Singh Joli. One by one. We have one more first prize, Dr. Vinisha Bajaj. For slot 6, third prize goes to Dr. Second prize goes to Dr. Gaurav Jain. And the first prize goes to Dr. Khushbu Arif. Second prize goes to Gaurav Jain and Priti Shukla. For on spot registration, third prize goes to Dr. Swadnata Raz. Third prize goes to Swadhinta Raz and Supriya. Second prize goes to Bhavya Joshi. And also Divya Rastogi and Love Verma. First prize goes to Ada. It's a time for offline poster presentation. For slot 1. Third prize goes to Dr. Abhishek Singla, Dr. Jagriti Bora, Dr. Naman Kumar and Dr. Akash. Second prize goes to Devansh Dev and Upasna Patel. Also Manvi Goyal. And Rupa Swain. First prize goes to Siddhant Sharma and Farhad Sandhu. For slot 2, third prize goes to Priya Dhama, Anusha Rana, Antara Shukla, Shreya Saxena, Second prize goes to Yatharth Pannu, Yasleen Kaur and Agamjot Singh, and also Diksha Sharma. First prize goes to Arjit Chandra. अर्जित चंद्र ठीक है फर्स्ट प्राइज आपका for slot 3, we have only first prizes in slot 3. First prize goes to Dr. Fatima Rashid Khan. Dr. Fatima Rashid Khan and Dr. Saif Rauf Siddiqui. And also Dr. Brijendra. For slot 3, second prize goes to Khushi. For table clinic, first position goes to Dr. Rishi Singh, Dr. Prashantra, Dr. Reshu Singh, Dr. Prasanta, Dr. Suchetana. Second prize goes to Dr. Shweta, Dr. Alankrita, and Dr. Surbhi Singh. Congratulations. Third prize goes to Divya Mishra and Rama Pandey. For on-sport presentations, second prize goes to Dr. Prashant Dwivedi. First prize goes to Dr. Vijay Shri Pandey. In UG category. Third prize goes to Pavitra Rastogi and Love Verma. Ayushi Jaiswal, Nishu Kumari, What do you present? Poster. Okay. I think you already. Poster. Okay. Ayushi Jaiswal, Nishu Kumari, Tanjot Kaur, second prize goes to Pragya Gupta. What's your name? Okay. Okay. You got third prize and she got second prize. Rosal, Tanishka also holds the third position. Second position. Certificate second करना है ना? अभी वो one by one. First prize goes to Shivam Pathak and Nandini. And Monica Sharma.
Shivani Patha. Shivam nahi hai. It's Shivani.
First prize goes to Shivani Pathak and Nandini. And Monia Sharma. So we are done with the prize distribution. Congratulations to all the winners. It's time to felicitate our organizing committee. For culturals, Dr. Shweta got a first prize in dance. For organizing committee, I would like to invite one by one. First of all, Dr. Noman Sheikh, Shubham Bharti, Shivendra, Dr. Nikhil, Dr. Nikhil, Dr. Shrishti,
Next, Dr. Misbah Kadri. Mansha Shahzad.
Welcome back to this US Open office plan. Miller just
Palak. Next, we have Shubhangi. Next, Evelyn. Khushi. Now I would like to call Dr. Ashish Chandra sir for the vote of thanks.
We have one award for Dr. Piyush Shivare sir in the category of Oral Medicine and Radiologist of the Year.
Next from the organizing committee we have Riddhi Eatwala. Now I would like to call Dr. Ashish Chandra for the vote of thanks. From the organizing committee, I would like to call Dr. Pranav. Now I would like to call Dr. Anmol Bagaria, ma'am, for the vote of thanks.
So a very good evening. Hello. I know it was a tiring day for everyone, and we had a mixed kind of day of lectures, scientific presentations, and even in the morning we had PFA, fellowship, convocation and awards. So I would like to thank everyone who has given us the valuable time and support in making this event a grand success. And I would like to congratulate all the winners of the scientific paper, poster as well as the table clinics. Thank you so much. Hope to see you soon again. Thank you.